Good morning, everyone. And I wish you all a happy Mother's Day. I am Dr. Sarojini. On behalf of Susruta Ent and Laser Center, I extend a warm welcome to all of you for this much awaited CME program on snoring and obstructive sleep apnea. So your overwhelming response shows the importance of this topic, and we are delighted to have such distinguished gathering. I request you all kindly stay till the end of this program, as this has been meticulously planned to various levels of doctors, starting from the general practitioners to the specialist level. Ensuring that each session provides valuable insights into the complexities of the OSA, and for this program we have international faculty like Dr. Srinivas Kishore, Dr. Madhusudan Rao and Dr. S.K. Rao for this program. Without any further delay, I invite Dr. Kavyasri to start the scientific sessions. Thank you all.
May I now request Dr. T. Leela Prasad Garu, Professor of ENT, Siddhartha Medical College, Vijayawada, and Dr. M. Srinivas Garu, Senior Practitioner, Srinivasa ENT Clinic, Gajuwaka, to please come on to the stage and chair the session. Dr. Sivarama Krishna Garu from Eluru, to please come on to the stage and chair the session. Thank you, sir. I request Dr. Susruta, consultant at Susruta Ent Clinic, to come on to the stage and give her talk on the OSA conundrum. I request the chairpersons to introduce the speaker.
Good morning all. Dr. Susruta Saragadam, she did her MSc ENT from Wills Medical College. She has been honored with fellowships in otology from PKR ENT Foundation, fellow from Adas University Allergy and Immunotherapy, advanced training in FES and INA in Mumbai. She is the Joint Secretary of AOI AP State Branch. She has good academic achievements like she won second prize in the head and neck dissection course organized by Homi Baba Cancer Institute, Visakhapatnam, and second prize in temporal bone dissection, which was held at Kurnool in 2024. She got second prize in junior consultant category in the state conference AOI at Bhimavaram. Thank you.
Good morning, one and all. I welcome you all to the CME on OSA and sleep apnea, on snoring and sleep apnea. At the outset, I feel this is the need of the hour for all of us to focus on this topic and create more awareness among the public, as it is on the rise based on our present lifestyle. I am Dr. Susruta, a consultant at Susruta Ent and Laser Center, Dwarkanagar, Visakhapatnam. And today I would like to discuss how do we evaluate a case of OSA, from the basic evaluation up until how an ENT surgeon handles such a case. So OSA is a dynamic state which happens during sleep. It is nothing but obstructive sleep apnea. So a little bit about sleep. Sleep is nothing but a temporary state of unconsciousness that can be interrupted by an external stimuli. It is not a uniform state but is organized into a cyclic pattern of sequential stages based on the EEG, EMG and EOG into quiet non-REM stage and the active REM stage. And there are multiple cycles of quiet non-REM and active REM stage which happens during a single night of sleep. So coming to the sleep disorders. Sleep disorders are divided into respiratory sleep disorders and non-respiratory sleep disorders, and our topic today, which is OSA, falls under the respiratory sleep disorder. And the other respiratory sleep disorders include central sleep apnea, hypopnea, chain stokes breathing, and sleep hypoventilation. And the non-respiratory sleep disorders include narcolepsy, periodic limb movement disorder, and also idiopathic hypersomnia. So a little bit about sleep hygiene. What is sleep hygiene? In today's day, where people working night shifts and having varied habits, focusing on sleep hygiene and emphasizing on it to our patients and the public is of significant importance. Something like following regular timings for going to bed, waking up at the same time, having good food habits, like avoiding any alcoholic beverages before going to bed, avoiding heavy meals before going to bed, reducing naps during the day, avoiding screen time during the day, just before going to bed, and important handling of stress, that is good stress management. So what is snoring and what is sleep apnea? Snoring is nothing but a loud sound produced during sleep by the vibration of respiratory structures when the airways get obstructed and collapsed with irregular flow of air. And sleep apnea is pauses in breathing during sleep which last more than 10 seconds and it could be of varying duration. Obstructive sleep apnea is blockage of the upper airway in spite of respiratory efforts by the individual. Coming to the history. Who are the snorers that we are concerned about? Who is it that we should evaluate further? An occasional snorer, somebody who snores only during an episode of acute URI or after alcohol consumption or other food habits. Those are the ones we are really not worried about, but the ones we need to focus on are the habitual snorers. That is somebody who has increased excessive daytime sleepiness and decreased quality of life. The heroic snorers, that is somebody who snores and we can hear them from the other room. These are all the people we should focus on and evaluate further. Coming to the clinical history, it is always important while taking the history to involve the bed partner of the individual, that is the spouse in most of the cases, and ask for symptoms because the nighttime symptoms are usually clearly seen by the bed partner more than the individual themselves. There is a lot of denial around snoring. A lot of people, when you ask them, do you snore regularly, they would say, no, I don't snore. So asking them, and they are the ones who actually see the person suffering because they see them getting up in the night for taking a good breath. There are apneic spells during sleep. There is loud disruptive snoring. They could gasp and choke during sleep, and they're restless during sleep. Whereas the daytime symptoms is something we can directly ask the patient. There is an excessive daytime sleepiness, there is decreased quality of life. They wake up with a morning headache despite having a good 8 hours sleep. There is a lot of difficulty in concentrating during work and other activities. Many of them wake up with sore throats during morning because of all the mouth breathing that they do. In the case of a child, that is pediatric OSA, symptoms we can ask the patient's parents, that is, there is mouth breathing, there is snoring, some children have bedwetting, night terrors, hyperactivity, poor performance in school, and some children also complain of, some parents also complain of hearing complaints in the child. So these are all questions which we can ask the patient and the partner, and this is more of a subjective evaluation where we give the sleep chart to the patient themselves. There are multiple sleep charts like the Epworth Sleepiness Score, the Stop Bank Score, the Berlin Questionnaire. The most common one which we use is the Epworth Sleepiness Score, where we ask the patient and the patient's partner to sit and evaluate their sleep and their habits regularly and score themselves. So anything below 10 is considered okay, but above 10 and more than 14 or 16 should be evaluated further and treated accordingly. So this is all evaluation up to the level of our OPD without having any equipment in a rural setup as well. A general practitioner can also evaluate the case up until this stage. One thing we need to identify and notice is that excessive daytime sleepiness is a complaint in many other conditions other than OSC. So not everyone who has excessive daytime sleepiness is a case of OSC. So to evaluate further, when the patient is sent to somebody like me who is an EAT surgeon, how do we evaluate the case? So there is the gold standard for evaluation of a case of OSA is usually the PSG, which is the sleep study, which tells us the severity. Polysomnography, which tells us the severity of the condition. There are other evaluations like local examination, the OPD, a rigid endoscopy, a DNA, CT scan, and some dynamic evaluations like flexible nasopharyngoscopy, drug-induced sleep endoscopy, and a dynamic MRI. So when the patient comes to the OPD, what is it that we do? We evaluate the patient with the help of headlight. We look for any gross deviation of the nose or if there's any polyp which we can see. We also do a rigid endoscopy to look for any gross DNS, adenoids in some cases, and also look for any large tonsils, a large tongue. All of these can be seen in the OPD. But one thing that needs to be kept in mind is evaluation of the oropharynx, that is, if there is a large tongue. Just seeing the anterior two-thirds of the tongue, that is, with a headlight is not sufficient, because usually when there is an involvement of the tongue, it is at the level of the base tongue. So in such cases, we need to evaluate the case more dynamically. That is, we need to either use a flexible scope in the OPD or also with the help of a drug-induced sleep endoscopy. In such cases, dynamic evaluation is much more important. So usually the nasal components can be evaluated in the OPD with the headlight, a DNA, and also a CT scan to look for any static obstructions. So coming to polysomnography, this is considered the gold standard for evaluation of OSA, which gives us the gravity of the problem to differentiate between respiratory sleep disorder and a non-respiratory sleep disorder. So there are four levels of sleep study. Level 1 is one where the patient is monitored in a sleep lab or a hospital. There's multi-channel testing with 7 parameters, including the EEG, electrooculography, electromyography, chest movements and thoracic movements, oxygen saturations, heart rate, and also the patient is filmed. Radiography is also done. Level 2 polysomnography is very similar to a level 1 polysomnography, but it is one which is done unattended at the home, as usually that is more comfortable for the patient, because as you can see in this picture, doing a polysomnography with all of these wires attached to the patient, especially somebody who's already having a sleep disorder, is very cumbersome and not very comfortable for the patient to go through. So in such cases, it's usually preferred by the patient to get it done at their home. A level 3 polysomnography is one which is done again at the home, with including 4 parameters, that is the oxygen saturation, heart rate, thoracic movements and abdominal movements. Level 4 is more or less something like a pulse oximetry where only the oxygen saturation and heart rate are monitored. So which level of polysomnography do we advise for whom? When the patient has vague symptoms, that is, they're not very sure of their symptoms, they say that I'm unable to fall asleep, something like insomnia, or they say that they have, the partner says that the patient is moving frequently during their sleep, something like a periodic limb movement disorder. In such cases, to differentiate between an OSA and non-respiratory sleep disorder, level 1 or 2 is usually suggested. Whereas in the case of a level 3, where the patient has typical complaints, that is gasping and choking during night, multiple apneic spells during the night, excessive daytime sleepiness, reduced quality of life, morning headaches, all of these usually direct us more towards a diagnosis of OSA, and in such cases, probably a level 3 might suffice, as it is more cost effective to the patient and also easier for the patient. The number of wires attached to the patient are relatively less. Level 4 is usually not suggested. Though polysomnography is the gold standard, it has its own limitations, as AHI is the index which all of us look for when we look at a polysomnography report. And AHI is nothing but apnea and hypopnea spells. AHI index, in which apnea hypopnea index is nothing but the number of apneic and hypopneic spells an individual has during 1 hour of sleep. So coming to the grading of AHI, anything less than 5 is considered normal, 5 to 15 is considered mild OSA, 15 to 30 is considered moderate OSA, and anything above 30 is considered severe OSA. Though sleep study is the gold standard, there are some limitations with this AHI index and sleep study, as it only shows us the severity of the condition and not the level of obstruction, because that is something we as surgeons usually look for before planning a surgery, especially in cases who need a surgery. That is a definite limitation for us. So to further evaluate the case, we have to do other dynamic evaluations. So in a case of a pediatric age group, it is usually not, the children are usually not suggested to get a sleep study, as it's fairly cumbersome and they usually don't get along very well with it. So when the child is having typical symptoms of adenoid facies and large tonsils. The complaints are typical. There is mouth breathing and snoring, and there is some hearing complaints in some children. Or the child is morbidly obese. In all of these cases, the children are usually suggested, the parents are suggested to ask the child, to make the child lose some weight or use some intranasal steroid medication. Oral medications are tried, and if that doesn't suffice, eventually plan for a surgery. So one important thing all of us need to remember is that in adults, we know that apnea-hypopnea index above 5 is significant, whereas in the case of a child, anything above 1 should be taken seriously. And the oxygen saturation also below 85 is considered significant in the case of an adult, and anything below 92 is significant in a child. This is a typical sleep chart, level 3 sleep chart that we can see here, where before going to all of the results and analysis, some basic information that all of us need to look at is the BMI of the individual. BMI of the individual and the gender of the individual. As usually it is more commonly seen in males who are obese with a high basal metabolic index, and also postmenopausal women. And also some sleep studies also have the neck circumference, they have the Epworth sleepiness score. So all of this gives us more direction towards the diagnosis. Next, coming to the result here that they're showing, which is 81 in this case. So we know that AHI above 30 is considered significant. In this case, we see AHI of 79. Sorry, yeah, 79. So other parameters that we come across in this is the average oxygen saturations, the average heart rate, number of apneas during sleep. So one thing we can all suspect is usually when the apneic index is high, it is more of a pharyngeal, it could be more of a pharyngeal problem, and when the hypopneic index is high, it could be more of a nasal complaint. So till now we came to know of the polysomnography and how it is done and the levels of polysomnography. So how do we dynamically evaluate a case? That is, how do we find out the level of obstruction in such cases? So dynamic evaluation can be done with the help of a flexible nasopharyngoscopy in the OPD, or a drug-induced sleep endoscopy in the OR, a dynamic MRI, and also an apneograph. So the most commonly followed, so one thing all of us need to keep in mind is that a flexible nasopharyngoscope is something we as sleep surgeons, if we want to become sleep surgeons, we should definitely try to have one or have access to a center which has a flexible nasopharyngoscope to look for the dynamic obstruction. A drug-induced sleep endoscopy gives us the exact location where sleep is induced. It takes about 15 to 30 minutes to do the study, where the patient is put to sleep and the level of obstruction is identified. Here we see a ward classification, which is something which most of the surgeons try to look for and identify, which is nothing but level of obstruction at the level of the velum, the oropharynx, the tongue base, or the epiglottis. So finally, I'd like to emphasize on the public health perspective of OSA and snoring, as it is a significant occupational hazard, especially with someone who is a professional driver or somebody who handles heavy machinery. And it is a globally highly diagnosed situation with a significant incidence in India with about 104 million in the working age group and more than 1 billion across the world. As it also affects the personal relationships, causes depression, aggression in the patient, there's decreased quality of life, decreased productivity, and there are multiple cases of sudden cardiac deaths in the middle of the night owing to OSA. Thereby, I urge you all to raise awareness and take action against sleep apnea. Thank you.
Insightful presentation. I request the chairpersons to give your inputs.
Susruta, thank you very much. You have given an excellent and elaborate lecture. In English, there is a one proverb: "Aluminium is an option." You have given the teaser. That shows that how the CLB will be. Very good. Thank you. Thank you very much.
I request Dr. Devi Madhavi, Professor of Community Medicine, Vice Principal, Government Medical College, Vijayanagar, to present the mementos, the speaker and chairpersons.
Sir, all of you. Sir. Okay. Now, sir.
The next section, Dr. P.V. Krishnakantharao garu, Siddhartha ENT Clinic, Senior ENT Surgeon from Visakhapatnam. Sir, please come on to the dais. Dr. K.S. Panendra Kumar garu, Senior Pulmonologist, KIMS Hospital, Visakhapatnam. Please come on to the stage. Now I would take the privilege to invite the speaker for this session, Dr. T. Sudhir garu, Consultant Clinical and Interventional Pulmonologist, Medicover Hospital, Visakhapatnam, to kindly come on to the stage to give a talk on pulmonologist perspective of obstructive sleep apnea.
Hello, good morning all. Dr. Sudhir is a qualified in Medicover Hospital, Visakhapatnam, and he published more than 45 papers in the national and international journals and trained in polysomnography and all other sleep apnea conditions, and specially trained in interventional pulmonary procedures like fiber optic bronchoscopy for OSA patients, rigid bronchoscopy and foreign body removal, and he got many awards including first prize in clinical PG in Susruta Hospital and second best paper in NAPCON. Thank you.
Good morning all. Thank you, Chairperson, for the introduction. First of all, I thank organizers, Dr. S.K. Sir and Dr. Sarojini Madam, Dr. Susruta and Dr. Santosh for giving me this opportunity. And topic for my today's discussion is obstructive sleep apnea, pulmonologist perspective. So these are the sources from which my content was taken. The first two are the textbooks of sleep medicine, and the third one is American Academy of Sleep Manual and up to date. And I'm very thankful to my teachers, Professor Ravi Gupta and Professor Girish Sindhwani and Dr. Abhishek Goyal. Three of them who had taught me the sleep medicine, and we are trained in level 1 polysomnography due to these three professors. And the content of my talk will be under the following headings: introduction, pathophysiology, phenotypes and endotypes of OSA, and how do I approach a patient with OSA, polysomnography interpretation, the little bit thing on EEG and respiratory events, treatment and so on. So first of all, we will see what is an OSA. It is a disorder characterized by repetitive respiratory events like apneas and hypopneas, and it is due to repetitive closure of the upper airway and mainly occurs during the sleep. And if you want to define OSA, by polysomnography using an index called as apnea-hypopnea index. It is an index which measures hypopneas and apneas per hour of sleep. If you want to define OSA based on polysomnography, it is AHI more than equal to 5 along with the symptoms like excessive daytime sleepiness, snoring or nocturia, or the patient can have comorbidities like uncontrolled hypertension, uncontrolled diabetes, strokes, heart failure or arrhythmias. Or you can define OSA if the AHI is more than equal to 15 without any symptoms or comorbidities. So these are the two criteria used to define OSA in polysomnography, that is sleep study. So this is the pathophysiology of OSA. So based on the Starling Register model, in this there are we describe the airway as a tube. They describe the airway as a tube with rigid and collapsible segment. The rigid segment is the nasal passages and the next rigid segment is the trachea. In between there is a collapsible segment which is the pharynx. So the main pathophysiology lies in the collapsible segment which is in the seed box. So due to compression of this collapsible segment by fat deposition or anatomical factors, it collapses and causes a sound known as snoring and is the main pathophysiology in OSA. So this is the normal airway. Air goes into the lungs through the nasal passages, it passes the pharynx, then it goes into trachea. So in OSA, you can see there is an obstruction. So there is obstruction to the airflow during the passages through the airways. So when air passes through this narrow passage, it causes snoring and the airflow in the lungs decreases and it causes all symptoms of OSA. So coming to the risk factors of OSA, what are the risk factors? The most common one is the obesity and the second one is the craniofacial abnormalities, tobacco smoking, alcohol consumption, old age, gender and genetic predisposition. So we see one by one. The first one is the obesity. In obesity, there is a fat deposition in the abdomen and the upper airways, due to which the fat deposition, it pushes the diaphragm upwards so that the lung volumes are decreasing. And there is a decrease pulling of the upper airway and causes increased collapsibility, causing the symptoms of OSA. So this is how obesity causes OSA by excessive deposition of the fat in the abdomen and the upper airway. So these are the various craniofacial abnormalities which mainly cause non-obesity related OSA. The first one is the retrognathia and the second one is macroplasia. How we will define macroplasia? We ask the patient to protrude the tongue. If we see the lateral ridges on the tongue on the both sides, you can define the patient is having macroplasia. And the most common cause of OSA in children is due to adenoid hypertrophy, and it can occur due to deviated septum or enlarged tonsils, or it can also occur in patients with rhinosinusitis due to obstruction of the airflow with turbinate hypertrophy or nasal polyps. So these craniofacial abnormalities are the main causes of OSA in non-obese individuals. So other risk factors like tobacco smoking. Tobacco smoking increases inflammation and it causes increased risk of airway collapse during the sleep. And the second one is the alcohol consumption. We also know that alcohol causes relaxation of the upper airway dilator muscles and cause collapse of the upper airways and cause OSA. In old age, there is increased fat deposition around the pharynx that is independent of the body fat. So in old age people, there is increased risk of OSA. In male gender also, there is increased risk of OSA as compared to females in premenopausal period because of hormonal changes and increased fat deposition. And in postmenopausal period, the incidence of OSA in males and females is same. And other risk factors are pregnancy. We should also look for endocrinology abnormalities like hypothyroidism and acromegaly, polycystic ovarian syndromes, and drugs like benzodiazepines, muscle relaxants, and testosterone therapy, which all can cause relaxation of the upper airway dilator muscles and cause collapse of the upper airway. So these are the main risk factors. So how these people present with OSA? The first and most common presentation is the habitual snoring. As told by Dr. Susruta, it is usually reported by the bed partner or other observer. Or the patient can wake up with breath gasping or choking. And the patient can present with excessive daytime sleepiness, that the patient will sleep during reading, watching television or driving. Or the patient can have lethargy, or the patient can have neurocognitive symptoms like memory loss, poor concentration or intellectual impairment. And some patients can also present with psychiatric symptoms like personality and mood changes, depression, anxiety, sexual dysfunction. These main symptoms are due to reduction in the airflow, so there is chronic hypoxia to the brain, causing these various neurocognitive and psychiatric symptoms. So in olden days, basically the phenotypes of OSA are divided into two types. The first one is obesity-related OSA, which contributes to 80%, and non-obesity-related OSA, which contributes to 20%. But there is change in spectrum of the OSA due to technological advancements. So there are many phenotypes and endotypes because of many diagnostic procedures and important understanding of OSA and pharyngeal anatomy. There are many of phenotypes and endotypes. The phenotypes based on pathophysiology due to anatomical compromise, that is the collapsibility of the pharynx, high loop gain, mainly in patients with heart failure, low arousal threshold. So based on these four factors, there are again endotypes and phenotypes. And based on clinical presentation, there are also phenotypes. That is, patients who are having excessive daytime sleepiness, patients who are having insomnia, patients who are having mood disturbances, and patients can be minimally symptomatic. So based on polysomnography also, there are various phenotypes and endotypes. And comorbidities also, patient mainly with cardiometabolic symptoms or patient with mainly neuropsychiatric symptoms. So these are the various factors or underlying features where we can phenotype or endotype the OSA patients. But the most important one where we phenotype the patient is based on the pathophysiology. So these are how the OSA can be due to anatomical or non-anatomical causes. In anatomical causes, the most common one is obesity, and the other one is craniofacial abnormalities. And in non-anatomical causes, there is a palm approach. The palm approach means the first one is upper airway collapsibility due to increase in pharyngeal pressure, that is critical pressure in the airway. A stands for aerosol threshold, L stands for loop gain, and M stands for muscle responsiveness. So this is how there is phenotypes and endotypes of OSA. So we'll see a little bit about palm approach to OSA. Based on the palm approach, there are various phenotypic traits in OSA. The first one is P. This is the airway. This is the muscular portion of the pharynx. The pressure inside the pharynx, which is known as P critical pressure, it is normally negative. In OSA patient, it becomes positive due to the compression of the surrounding structures. Based on this P critical pressure, there are many phenotypes. And the second one is the aerosol threshold. Means normal aerosol threshold is like here. In the patient, the aerosol threshold is decreased. So if there is minor disturbances in the airflow, the patient can be easily aroused and it can cause obstructive sleep apnea. This is the high loop gain, mainly occurs in patients with heart failure. In this is the normal ventilation. This is due to excessive sensitivity of the CO2 receptors. So if there is excessive sensitivity of the CO2, if there is little increase in CO2 which occurs normally during sleep, there is an excessive ventilator response like this. So the patient will do hyperventilation and that will cause washout of CO2. After washout of CO2, the patient will go into an apnea. Again the CO2 will build up, again the patient will do hyperventilation and again patient will go into apnea. This is how repeated hyperventilation and apneic spells occur causing OSA. And the third one is the poor muscle responsiveness of the upper airway dilator muscles due to various disorders of the nervous system. This is also one of the phenotypic traits of OSA. So based on this palm approach to OSA and based on the traits, there are 3 palm scales. This is the palm scale 1, palm scale 2 and palm scale 3. The one is the patient having severe anatomical problem. So these are the various phenotypic traits and how we should approach the patient based on these phenotypic traits, which will be discussed in the subsequent lectures. Though the majority of the patients will fall into the palm scale 2. Palm scale 2A, it is the patient should not have any major anatomical impairment. These are the non-anatomical impairments. And the palm 2B, the patient will have one or more non-anatomical components. And palm scale 3 is the minor one with minor anatomical problems. So based on this approach, everything in the sleep medicine is now phenotype and endotype and patient should be treated accordingly. It is not that we have polysomnography and we have to do preparation and we are giving the sleep missions. We have to do endotypes and phenotypes and we can treat accordingly. So what are the consequences of OSA? The consequences of OSA are mainly due to chronic hypoxia leading to activation of sympathetic nervous system, causing various abnormalities of diabetes, obesity, GERD, pulmonary hypertension, nocturia, depression, memory loss, cardiovascular diseases, hypercapnia, and arrhythmias. Out of these, the main important ones are in which you should work up for OSA are strokes. The patients who are presenting with recurrent strokes, you should evaluate for OSA if there are no underlying abnormalities. Or the patients who are presenting with cardiovascular diseases in young age, you should work up for OSA. Uncontrolled diabetes, uncontrolled hypertension, uncontrolled COPD and asthma and obesity. So now, how we approach a patient with OSA? First of all, you should do a good clinical history and you should examination. And you should see patient in total. You should not focus only on OSA. You should see for other systems also, like cardiovascular system, neurological system. That is, you should see patient in total, not only you should focus on OSA. Then you have to apply screening tools like Epworth Sleepiness Scale or Berlin Questionnaire, and you have to see for comorbidities like hypertension, atrial fibrillation, cardiovascular diseases, and you have to do some biomarkers like ABG, and you have to order for polysomnography, which is diagnostic and titration. Then you have to prescribe the treatment and follow. So first of all, we have to take a good clinical history and examination. So, for good clinical history, first of all, you have to know what are the symptoms of OSA which occur during sleep and which occur during daytime. These are the symptoms which occur during the sleep. The first one is the snoring, which is the important one, followed by breath gasping. And the patient can have pause of breathing for some time during the sleep and insomnia. The patient can have nocturia, the patient can have bedwettings or night sweats. These are the symptoms which are mainly occur during sleep time. And we should also ask for daytime symptoms like excessive daytime sleepiness, fatigue, morning headaches, memory loss, mood disturbances, and decreased libido. So you should ask symptoms in the sleep and daytime, and you should also ask for any recent history of weight gain, and you should ask for symptoms of rhinosinusitis, allergic predisposition, and you should inquire about the comorbidities like uncontrolled diabetes, hypertension, recurrent CVS, uncontrolled asthma, and uncontrolled erythemias. This is how clinical examination should be taken in a patient with obstructive sleep apnea. Clinical history. Now coming to clinical examination. For examination, you have to measure the neck circumference. If it is greater than more than 17 inches in males and more than 16 inches in females, then the patient has high risk of OSA. And you have to check for BMI. If it is more than 30, that defines obesity, and you should do workup for OSA. You can use modified Malapati score, and you can see the classes. The class 3 and class 4 have high risk of OSA. And you can also see for cranial and facial abnormalities like retrognathia, macroglasia. So all of these should be included in the clinical examination, and you should prescribe the treatment for the OSA patients. This is the modified Malapati or Friedman tongue position. There are 3 categories, A, B, C, D. A, in which you can see the uvula and soft palate. In B, you can see only part of the uvula. In C, you can see only soft palate, and D, you can see only hard palate. In this, there is narrowing of the airway and decrease in the airflow, so it causes symptoms of OSA. So you have to do complete examination to complete workup for OSA. After examination, you have to apply the screening tools. So what are the screening tools we have? We have Stockman questionnaire, Epworth sleepiness score, and Berlin questionnaire. So what is the main caveat for the screening tools? These are only used to tell the probability of OSA. These should not be used for diagnosis. Why? Because they have very poor sensitivity and poor predictive value, so they can only tell about the probability. We cannot apply and start treatment based on the screening tools. So this is the individual Stockman questions in Indians. So they have asked various questions in OSA patients after they are diagnosed with OSA and found that only snoring and hypertension have good sensitivity. So after these all questionnaires, only 2 are having good sensitivity, rest of all having poor sensitivity and poor cutoff value. So it is not used for diagnosis, it is used to tell only probability of OSA. This is Epworth sleepiness score. It mainly tells about the excessive daytime sleepiness, that patient would not sleep, or patient there is slight chance of sleeping, moderate chance of sleeping, or high chance. We will give this paper to the patient and ask to circle the score, and we will document the total score. We will give this patient at the time of OSA diagnosis, and we can see this one during follow-up. That is, we have prescribed some treatment, and we will ask the patient to tell how much there is improvement in the Epworth sleepiness scale. So it is used to tell the probability, and it can also use in the follow-up of the OSA patients. And this is the Berlin questionnaire. This is a long questionnaire, and it is a little bit cumbersome, in which you have 3 categories: category 1, category 2, and category 3. Category 1, you will ask about the snoring history, and category 2, you will ask about the fatigue, tiredness, and category 3, you will ask about BMI and hypertension. If you have 2 or more categories positive, then they indicate there is a likelihood of OSA. So these are the 3 scoring questionnaires. This is a study which was done by us, and it is still unpublished. In this, we have various questionnaires, and we have seen the sensitivity and positive predictive value. And we have seen that there is a poor sensitivity and poor positive predictive value in the patients with OSA. So we recommended the Stockman and Berlin questionnaire have very poor predictive values to diagnose OSA. And we have developed a simplified score for screening of OSA patients, and it is still unpublished. And there are 4 variables, and it's SONA questionnaire. The first one is snoring, which has 3 points, and obesity, which has waist circumference of more than 93 in males and more than 85 in females. And neck circumference, which is more than 37 in males and more than 32 in females, and age more than 35 and more than 45 in females. If the scoring is more than equal to 3, then we can tell that patient has probability of OSA. Still, it is unpublished and going to be published. So coming to what are the investigations should be ordered in a patient with OSA. The first one is complete blood counts. Here we have to look for any polycythemia, because these patients have low oxygen levels chronically, that leads to increased stimulation of the bone marrow, causes polycythemia. You should look for renal function test, because chronic kidney patients have risk of OSA. You can order for liver function test and lipid profile, because obesity patients have abnormalities. Thyroid profile to look for hypothyroidism, and RPS to look for diabetes. ECG to look for any arrhythmias. Arterial blood gases to look for hypercapnia. Because mainly the OSA OSA patient do not have CO2 retention. If there is CO2 retention, then you can label the patient as obesity hypoventilation. That is the main difference. You should not mention OSA in a patient who are presenting with CO2 retention. The OSA patients will always have normal carbon dioxide levels. If there is carbon dioxide level means you have to label him as obesity hypoventilation syndrome, and there is a different criteria for this one. And you have to get an X-ray PNS to look for any rhinosinusitis or deviated nasal septum, and you can get a basic chest X-ray, and all other investigations can be done on the individual basis. So now coming to the diagnosis. So how we will diagnose OSA? It is basically diagnosed by help of polysomnography, which is a gold standard one. So what is a polysomnography? It is basically recording, analyzing and interpreting multiple physiological variables. Means we have to measure brain activity, eye activity, heart functions, muscle activity. These all activities are measured when the patient is slept in the lab or in home, and it is connected to a variety of channels like this. These are the various channels which are connected to the patient. The first one is to measure the function of the brain, and we can see the eye movements, we can see the airflow. These are the movements for airflow, and this is the sensor to record SpO2, and this is for muscle tone or limb movements. So by connecting various channels, we have various variables like electropulmonogram, electroangiogram, electromyogram, ECG, airflow, transducers, movements of chest and abdomen, oximeter, snore position. So these are the various parameters which are recorded during polysomnography. So these are the 4 levels of polysomnography: level 1, level 2, level 3 and level 4. And out of this 4, the gold standard is the level 1, means which is done in the hospital and is technician attended. Here we have 16 channels, and the data of the total 16 channels is recorded throughout the night in the computer, and it is analyzed in the morning. It is a little bit cumbersome, and so it is available in some hospitals only. And the most commonly used one is a level 2, which is done at home without technician. All the channels are the same, except that it is done at home and it is unattended. And the other studies are level 3 and level 4, which are usually not recommended. In the level 3, we have used only 6 channels, and level 4, we have to use only 4 channels. Like we have to measure the airflow, saturation, and the heart rate. So the gold standard one is level 1. Due to non-availability, we can use a level 2, level PSG. So we will see what are the indications for level 1 and level 2. The main indication, level 1 is a gold standard. You have to always order level 1 polysomnography in the patient having serious medical conditions like heart failure or arrhythmias, because if you do a polysomnography in these patients at home, there is a high risk of chance of adverse medical events like cardiac arrest and everything. So who are unstable patients, you have to do polysomnography or diagnostic titration in hospital only. And in mild OSA patients also, you can do polysomnography in a hospital only, because there is chance of missing of mild OSA if you done sleep study at home, because all channels cannot be connected to the patient at accurate places at home.
Okay.
So because of non-availability, we are mainly doing level 2 and level 2 studies. This is mainly used in moderate to severe OSA patients who do not have any serious medical conditions, or the patient is not willing to stay in the hospital also. You can do level 2, and you can do the level 2 in the patient who will document the efficacy of the non-PAP treatments like mandibular advancement devices or upper area surgeries or the weight loss. So level 2 is mainly used for diagnosis of OSA in patients who are having mild conditions and to document the efficiency of the non-PAP treatments. So these are the newer sleep devices which are level 4. Basically we can see nowadays everyone will record their oxygen saturation, snoring in their iPhones and everything. So these are mainly newer devices which are very portable, and they can be connected to the patient with the help of the mobile phone or with the watch. These are attached to the skin or can be implantable. So these are the variety devices. With the advancement of technology, we have get variety of devices which can be used in mobile patients who are not willing to stay or get the level 2. So this is the recent one, Watchpad device, the level 4 device. It basically measures the peripheral blood flow, which indirectly measures the peripheral arterial tone. So this is the Watchpad device. Here the sensor is attached. It measures the peripheral blood flow, which is mainly influenced by the sympathetic nervous system. So it can indicate the respiratory events like apnea based on the blood flow, which is indirectly influenced by the sympathetic nervous system, and they can record the events. This is the ECG one which can be attached to the patient at home, and we can record the events. And this is the most advanced one, night owl one sleep test. Here we can attach to the finger. It mainly measures the actigraphy data or reflectance based photoplethysmography signals such as SpO2, peripheral tone and pulse rate. Here we can also diagnose OSA. Patient who does not want to connect to all these cumbersome channels, we can ask them to connect by watchpad device or night owl test. So coming to the sleep, what is the main physiology of sleep? In olden days, there are 5 stages of the sleep. That is NEA, non-rapid eye movement 1, 2, 3 and 4 and REM sleep. But in 2007, American Academy of Sleep Medicine divided the sleep into 4 stages. That is N1, N2 and N3. The N3 and N4 are combined together into N3. So presently sleep scoring, there are NERM1, NERM2, NERM3 and REM sleep. This is how sleep. The patient from wakefulness will go into N1, then goes to N2, then goes to N3, REM sleep, and again he will go into N1 or N2. So majority of the sleep is contributed by N2. N3 and REM sleep are the deep sleeps, and N1 and N2 are the light sleep. So we will see what are the types of the sleep studies. There are basically 2 types which are mainly useful. The first one is full night diagnostics, polysomnography, which we commonly do, and the second one is the continuous positive airway pressure titration study, which we usually do. The first one is diagnostic and second night is titration. Or the patient cannot spend this much of time and there is high probability of OSA, we can do split night study. Means first initial 4 hours of the sleep for diagnostic and rest of the 4 hours of the sleep for titration. So these are the main sleep studies which are helpful for us. So when you order a sleep study and you want to see a sleep report, first of all you have to see a hypnogram. Hypnogram means it represents the various stages like wake, REM, N1, N2 and N3. This is important because the scoring of sleep event should be done only during sleep. If the patient is not slept at night, then you will get only wakefulness and that sleep study report is waste. There is nothing to record. There should be the stages of the sleep, like the patient should have REM sleep, the patient should have N1, N2 and N3. Sleep study recording and reporting should be done only during sleep, not in wakefulness state. So before seeing any sleep report, we have to first see a normal hypnogram and then only we have to score the events. So these are the basically EEG waveforms. There is no need to remember this. The first one are the delta waves, which are the slow waves. These are high amplitude and low frequency. These are the high amplitude. High amplitude means increased brain activity. So these are seen in wakefulness and these are seen in the deep stages of the sleep like NER, REM sleep and N3 stage of the sleep. So this is the first one, wakefulness stage. This is the how scoring of the sleep stages is done in polysomnography. The first one is the wakefulness. Here the brain activity is more, so there is high activity in the brain, which is typically represented by beta waves. So patient from wakefulness will go into stage 1. So slowly is going into the sleep. Slow the brain activity is decreased. That is the frequency is decreased. Then he goes into stage 2. Stage 2 sleep down, the brain activity is decreased. In the deep sleep, the brain activity is decreased. That is the frequency is decreased and amplitude is increased. So these are the 4 different stages of the sleep: wakefulness, N1, N2 and REM sleep. So this is how in EEG the wakefulness, the high activity of brain, and this is the N1. N1 means the patient is slowly going into the sleep, so the frequency is decreased. You can see the distinct waves. This is the N2 sleep, where the characteristics are sleep spindles and K complexes. There is no need to remember this one. And this is the N3, the deep sleep, where there is the slow waves. This is the slow waves, high amplitude and low frequency waves. And with the REM sleep, which is characterized by these rapid eye movements. So this is how sleep staging is done. Then we have to score the respiratory events. Respiratory events means apneas and hypopneas. So apnea means this is the absence of the airflow. This is the how polysomnography data is recorded. This is the airflow. If the absence of airflow is more than 10 seconds, then you label this as apnea. Or there is decrease in the airflow or decrease in the saturation, you will describe the events which are not characterized into apnea, hypopnea, you can put them into RERAS. And with all of these events, that is apneas, hypopneas and RERAS, there is a scoring known as apnea-hypopnea index. It is the total number of apneas and hypopneas by per hour of sleep. The normal scoring is less than 5. 5 to 15 is mild, 15 to 30 is moderate, and more than 30 is the severe. This is how AHI scoring is given. So when you order a polysomnography, what to do and what to see in polysomnography? First of all, you have to see for sleep duration. That is, adequate sleep duration is more than 6 hours. Next, you have to see for apnea-hypopnea index. It is more than 5 or it is more than 30, mild, moderate and severe. Then you have to see for sleep efficiency, which should be more than 75%. And you have to see for REM sleep, whether it is present or not. And you have to see for minimum SpO2 and baseline SpO2. The minimum SpO2 is most important because there is chronic hypoxia, which will lead to more complex problems like heart failure, strokes and neurocognitive effects. And leg movement is mostly important in periodic limb movement disorders. So this is how we have to interpret and we have to see in polysomnography report. For learners, it is basically enough to see these variables. There is no need to see all these waves and this one. So after doing polysomnography, after getting the diagnosis, here we can see the AHI is more than 30, that is very severe. We have to do titration. If the patient is obese, we have to do titration. Means we have to apply the positive pressure and we have to see the pressure at which all the events, that is the respiratory events are abolished, and we have to prescribe that pressure. Means we have to start at a pressure of 4 and we can gradually increase by 5, 6, 7 and 8 and we have to do titration. This is manual titration and we will get a certain pressure where all respiratory events, that is apneas, hypopneas are abolished and we can prescribe that pressure to the patient. This is how manual titration is done, or else you can do auto titration. Means you can fix a specific pressure like in between 4 and 20 and you can do auto titration and you will get a pressure and you can prescribe it. So titration for giving the treatment can be done by manual titration or auto titration. So for management, CPAP remains the gold standard for the management of OSA. So after giving the CPAP, we have to choose what interface should be given to the patient. It is very important. There are 3 types of interfaces. The first one is the nasal pillows, and the second one is the nasal mask, and the third one is the oronasal mask. You should always see the patient and ask for the history of rhinitis or rhinosinusitis. Because in a patient with rhinosinusitis, if you give a nasal mask, it will cause puffiness of the nose and the patient unable to wear it. So he will remove the continuously mask and there is decreased compliance to the treatment. So in patient with rhinitis or rhinosinusitis, if he is not undergoing any treatment and he has severe OSA, in the meanwhile it is better to prescribe the oronasal mask. And various studies recommended that in patients who are not having rhinosinusitis, nasal mask is better than the oronasal mask because of increased opening of the upper airway. So in the patient with rhinosinusitis, you should use oronasal mask, and in other normal patients, you can use nasal mask. So this is the treatment based on the endotypic approach. If the patient has anatomical problem which is severe, you can give CPAP treatment, and the patient is not having no major anatomical problems, you can phenotype and you can give the patient the option of CPAP or any upper airway surgeries, which will be dealt in the subsequent lectures. And if the patient has minor anatomical problems like retrognathia or macroglossia or adenoids, you can correct them. So this is how phenotypic approach and phenotypic based treatment is given to the OSA patients. So this is our alternative therapy apart from the CPAP, like mandibular advancement devices, surgeries like tracheostomy, which will be done in very severe patients. Nowadays it is not usually recommended, and now recent advances we have pharmacotherapy, which will be done in subsequent lectures. So this is how basic interpretation of the sleep report is done. In diagnostic polysomnography, we have to look for the total sleep time, stages of sleep, sleep latency and efficacy. You have to see for obstructive apnea-hypopnea index, you have to see desaturations, you have to see healthiness, you have to see for snoring. And in titration with treatment, the adequate pressure is put to pH less than 5 per hour is recommended, and we have to prescribe the patient CPAP or BiPAP based on the ABG. So this is how level 1 sleep lab looks like. Here the patient sleeps on the bed and he is connected to various monitors which record these variables like EEG, ECG, EOG, and in other room the technician will sit and he will monitor all these recordings and he will give the sleep report. So this is how our sleep lab looks like, and the take home message is the pathophysiology mainly based on the Starling register model. Apart from the metabolic and systemic comorbidities, we have to ask the patient about the sleep history, and the level 1 is the gold standard, and the gold standard treatment is CPAP, but due to advancement in various surgeries, mainly in ENT, we can offer treatment modalities like maxillofacial surgeries or mandibular advancement devices. So the overall phenotypic and endotypic approach is the best way to diagnose OSA. It is not that we have to prescribe CPAP to every patient. We can refer a patient to ENT doctors and we can phenotype and we can provide surgery and appropriate treatment to the patients, because many patients are not compliant to CPAP. Thank you.
Very good presentation, Dr. Sudesh. In-depth presentation. And the role of chest physicians, general physicians, and ENT, what are the managements and all. And my question is, the routine sleep polysomnography tests we get, there will be a report generated by the computer. How far it is related? The role of manual scoring and the number of the comprehensive report given by those technicians, 4 or 5 pages, is it enough? Do we need to have total study?
So the gold standard is level 1 because manual scoring is done mainly by certified technicians or certified doctors, because here there is an epoch. We have to count every epoch and we have to stage the sleep. In manual there are some habits like the machine. For example, if any lead is missing in during the split night study or in level 2, we mistakenly score the stages. So level 1 is better and level 2 is non-inferior, mainly EEG scoring. In respiratory events we can use.
Any questions from the audience?
Now I request Dr. Mallai Garu, retired Professor of General Surgery, Andhra Medical College, to present the mementos to the speaker and the chairpersons.
reputed senior international endocrinologist at Dr. G.M. Narayan Swamy Center, Krishnanagar, with numerous publications, and Dr. K. Manohar Garu, Professor of ENT, MIMS, Vijayanagaram, to come on the stage and chair the session. MPDM, PGIMR, Chandigarh, Endocrinology, Advanced Center for Endocrinology, Vizag, to give the talk on endocrine insights into obesity and sleep apnea, exploring novel anti-obesity therapies. Thank you.
Speaker and the audience subtract short interview. It's a very gratification for me, not just because Dr. Sarojini and I were classmates or Dr. S.K. Appara and I were contemporaries in Indian College. Because my first association with sleep began 30 years ago. My first major publication was in the prevalence of diabetes and sleep, and it continues to be the most cited one. So that was presented at the World Journal of Sleep, World Conference of Sleep. And here we have 31 years later, a full-day conference on one aspect of sleep, sleep apnea syndrome, with a stellar group of speakers and the kind of audience which, when I was young, I would have seen only in the APA conference, annual APA conference. Congratulations to all of you and thank you for having made me part of this. I request my co-chairperson to introduce the rising star in endocrinology, Dr. Ramesh.
Thank you, sir. Now about the speaker, Dr. K.V. Ramesh. He was a visiting endocrine fellow at William Harvey Research Institute, Queen Mary University of London. And the publications he has got international reputed journals like Nature Journal of Endocrinological Investigation, JENI, Indian Journal Endocrinology Metabolism, and JCEM. He received 2 prestigious awards in the field of endocrinology: Endocrine Society USA Outstanding Abstract Award 2022 June, Atlanta, Georgia, and Endocrine Society of India ASAAB Gandhi Award for Excellence in Endocrinology 2021. His research work was selected for presentations at international annual conferences, British Endocrine Society 2021, Endocrine Society USA Endo 2022, American Diabetes Association 2023 and 2025. His special interests are diabetes technologies and emerging complications, obesity, neuroendocrinology. He is working as a consultant endocrinologist, medical director and head, Advanced Center of Endocrinology and Diabetes, Visakhapatnam, Andhra Pradesh. Over to the speaker, sir.
Very good morning to you all. Very good morning to you all. So thank you, Amkosa, for this opportunity, and thank you, my dear chairpersons, for kind introduction. So already my fellow speakers have set the context perfectly, Dr. Susruta and Dr. Sudhir. So now I will be trying to shift your focus from ENT and pulmonology to endocrinology. So my topic is on endocrine insights into obesity and sleep apnea, and I will be exploring the novel anti-obesity therapies. My talk overview is, so I start with some learning objectives and brief introduction about the obesity, and then I will discuss the relationships between obesity and sleep apnea and the role of melatonin and vitamin D. Then I will update you on the new anti-obesity medications available with us in India, and then I will take one small case scenario which is interesting. Through that I will try to redefine the obesity here, how the paradigm shift is happening. These are the learning objectives. So we should develop comprehensive treatment plans for patients with overweight, obesity and or sleep apnea. That should be very important. And the management strategies should address multiple pathophysiological mechanisms and which are connecting obesity and related comorbidities. And it should help, it will make a path to improve the obesity care among healthcare professionals by making them to select treatments that reflect the guideline recommendations and the individual patient needs. And also they should apply strategies to improve the adherence of these treatment plans for weight management. So I start with these barriers which will be connected with the learning objectives I mentioned before. Definitely we see there is a lot of stigma and these communication challenges related to weight bias, poor communication between the healthcare professional and the patients. And another aspect is like obesity management itself is very complex, it needs multidisciplinary care. And in the practice what we face is there will be limited time and there is competing priorities. We have other emergent health concerns and we don't have time to address obesity comprehensively. And another point I have highlighted here is the modest degree of efficacy of anti-obesity medications, which is relative to the degree of excess weight in most. This was the thought before. Now after my presentation, definitely know that we have good anti-obesity medications available now, which can help our patients. And another barrier is there is definitely underutilization of multidisciplinary care. So this type of conferences definitely will help improve the awareness about the multidisciplinary care needed for this obesity and sleep apnea. And also there is a delay with the patient and provider discussions. That is also happening. There will be long delay for recognizing and initiating the treatment. So definitely we should have a proactive approach. That also I will be discussing in my presentation. And finally, the most important one, there is a lack of training and knowledge because many healthcare providers they are not specialized in the training in the obesity medicine, and they are little unfamiliar, I can say, with evidence-based treatment guidelines, including the newer pharmacotherapy options. That's why these type of CME programs will be helping them to keep updated. I start with the definition. It's a very simple. Obesity is defined as abnormal or excess fat accumulation that can impair your health. And how it is classified? Now we have the most convenient one we have is body mass index, that is BMI, and it is easily measured with the weight and height. And if you see in the global prevalence of obesity, it is expected to hit now 1 billion by coming by 2030 in most of the adults. And this is the classification which is used. So here if you see Asian population here, underweight, normal range is considered 18 to 23, and pre-obesity or overweight, that is considered from 23 to 25, and obesity is considered about 25. So why is this different from international classification and other classifications for Asian Indians? And is BMI the ideal one to classify and define obesity? So I will explain here. So what should be the arithmetical evaluations? So here if you see, definitely BMI has some limitations. It doesn't distinguish between lean mass and fat mass, and it doesn't have any update on the fat distribution. And the most important thing is body fat distribution actually, not the excess weight, which is associated with the obesity and other related risk factors. If you look in the Asian Indians, we have more visceral fat and the lower BMI. That is the thing which has shifted the classification of BMI for us with a lesser number. And in even many studies in Indian population, they have highlighted need for newer anthropometrical parameters. That is waist circumference, waist hip ratio, and waist height ratio. And so I will discuss these three also. Before going to that, I will show this BMI approach, how it is going to, not that fair, you will also agree with me. So in the normal weight, if you clearly see here, it can have both metabolically healthy and also metabolically unhealthy in the normal weight. In the obesity also, we have both metabolically healthy and at-risk people. So in the unhealthy people, they usually have these common risk factors if you see. That is the most important one is excessive visceral fat, insulin resistance, diabetes, sarcopenia, dyslipidemia, inflammation. These are common for these metabolically unhealthy people. And if you see the waist circumference, how it is important. So it is mostly, you can see, appreciate in the figure also. It has visceral adipose tissue is, you can see here, appreciate here the difference. So it is the important indicator for abdominal fat, and also it has associated with cardiometabolic disease, CVD, and it is even predictive of mortality. That is what we have to notice. And in the general population, they have given 102 centimeters for male and 90 centimeters for female. But for us in the Asian descendants, it is 90 centimeters for male and 80 centimeters for the female. That is the cutoff. So this we have to start implementing in our day-to-day practice. And if you see the waist hip ratio, the hip ratio means circumference, it has to be taken at the maximum diameter. And the ratio of the same waist circumference, if you see, it should, when it is more than 90 for male and 0.9 for male and 0.8 for male, it is abnormal. And definitely above 1 indicates very significant health risk. And if you look at the waist height ratio, 0.4 to 0.49 is considered healthy. Less than 0.4 it may even indicate underweight, and above 5 is definitely the risk for obesity and health issues will be there. So to put it simple, our waist circumference should be less than half of our height. So I have, when thinking about this conference, I have just gone to up-to-date. So many of us might be using up-to-date, and I just typed what's new in obesity and diabetes. So first thing they showed me, it is new diagnostic criteria they have made up recently, and it is published in the Lancet 2025. So they have made two terms like preclinical obesity and clinical obesity. This is definitely don't confuse preclinical with the overweight or pre-obesity. This is a different entity. Both are obesity only. So they clearly appreciate here. So both will be having excess adiposity, And measures we will use BMI and also waist circumference. And in the mechanisms and pathophysiology, if you see, there will be alterations in the cells and tissues and also organ structure, but there won't be any functional dysfunction. So when the functional dysfunction happens, then they will move on to clinical obesity, where we have alteration in organ function and organ damage, and there won't be any clinical manifest, especially in the preclinical stage. That's what it says. So there will be minor or very absent. But in the obesity clinically, they have signs and symptoms and they have limitations of daily activities. Lot of complications I will show in the coming slide. And to detect and diagnosis, again we have to use the same anthropometrics and medical history, and we have to check all the systemic examination and all. This is the extensive list about the obesity and the comorbidities. If you see here, from head to toe, almost most of the systems are involved. This is one our topic of discussion today, sleep apnea. Other than this, we have depression, anxiety, and cardiovascular diseases, and asthma, and this MASLD, that is metabolic dysfunction associated steatotic liver disease. And it can even affect infertility, and it can some cancers like colorectal, postmenopausal, breast, endometrial, GI, and liver. Even we have seen the infection sensitivity, even influenza, COVID, and we have seen many of them good prognosis with obesity in the COVID time. So how important it is for this weight loss? So if you see here, I have put a scale here. So even 5% of weight loss can improve your hypertension and hyperglycemia. And to prevent the risk of diabetes and steatotic liver disease, steatosis, 5-10% of weight loss is needed. And even if this weight loss can help improve in the PCOS and dyslipidemia. And this, if you see the increasing in the number, 10 to 15%, it can improve this whole obesity, sleep apnea, that is obstructive sleep apnea syndrome also, and NASH and GERD and osteoarthritis, many things. So the increase in the number, the benefits of even difficult diseases to treat also we can appreciate. And more than 50%, definitely type 2 diabetes remission can happen, but it happens only in a selective population, cannot generalize, and it can improve the CV mortality and all. So most important thing you have to understand is it should be sustained weight loss, not just transient one. That is the most important thing. And now I will be exploring the relations of obesity and obstructive sleep apnea. So if you look here, it is a bidirectional causal relationship. So already these points were discussed. Obesity, how it contributes to obstructive sleep apnea. It will accumulate the adipose tissue around the pharyngeal area and reduce the airway lumen size, and also it will increase the propensity for collapse of the airway during sleep. And here if you see how OSA can contribute to obesity, so it will disrupt the balance of appetite regulating hormones, and it will lead to increased hunger, and it will cause weight gain, and it will induce fatigue and mood changes, which can reduce physical activity. Again, it will increase the weight gain. That's how both are bidirectional causal relationship. And one interesting Wisconsin sleep study have put some statistics. If you see here, even 10% of weight gain, it can increase 32% of this apnea-hypopnea index, which was very well discussed by Dr. Sudhir, and it can increase 6-fold in the moderate to severe OSA. And if you see the other side of the coin, 10% of weight loss, it can predict almost 26% decrease in the apnea-hypopnea index. So this shows the importance of the weight loss, how important it is. And if you see what are the risk factors and comorbidities, they are common for both. So they are genetic, sex, age, lifestyle factors, diet and physical activity. And they have increased risk, both of them have not only for type 2 diabetes, dyslipidemia and hypertension, but also cardiovascular disease, metabolic dysfunction associated steatotic liver disease. This is a newer name for NAFLD. And reproductive disorders, depression, even other comorbidities. So what is MASLD? It is a new name for NAFLD. And the prevalence of MASLD is increased in patients with obstructive sleep apnea, even in those without obesity. That's what we have to notice. And the severity of OSA and MASLD are associated, and the severity increases the risk of fibrosis also. And the CPAP alone does not appear efficient to improve MASLD. It can improve some other parameters, as Dr. Sudhir highlighted before. But for improvement in MASLD, weight loss is the most important thing. And recently we have a newer drug approved, that is resmetirom, which is thyroid hormone beta agonist. Because of this implication, definitely the optimal approach for management, we have to consider patients with OSA, they should be screened for MASLD also. That can be done easily in a day-to-day clinical tool. FIB4 calculator is available. And other than that, we can use imaging fibroscan. Through that, we can have both CAP score and LSM score. And if you move on to next aspect, that is reproductive and sexual function in the male, this is most under-discussed and stigmatized aspect. We have to proactively take patients into discussion and help them. So if you see here, low testosterone can be a consequence of obesity, but definitely it will improve with the weight loss, but not CPAP. So weight loss is the important thing here for this aspect. And who are elevated with BMI and with low testosterone, when we treat with testosterone, if they develop polycythemia, That's one important aspect. We have to consider screening for underlying OSA. We have to keep it in mind. And there is independent correlation between OSA and the erectile dysfunction also. And especially in younger men of less than 65 years, they have ED when they have severe OSA, and older than 65 years, even they have moderate and severe OSA also is linked with erectile dysfunction. So definitely we have to consider obstructive sleep apnea in men with ED, who are having obesity, hypertension, everybody can be considered, even symptoms of depression. So it is associated with not only decreased sexual desire, and it is also independent of obesity and also testosterone value and other confounding factors. So that shows the importance of treating obesity, obstructive sleep apnea. And one large-scale case control study, they have shown this is significant number of controls on the men with infertility. They have shown significant link between OSA and infertility in men. Now, if we move on to reproductive and sexual function in the female, so again we can see this obstructive sleep apnea and insomnia, they have increased the prevalence of hypoactive sexual desire and also female sexual arousal desire and female orgasmic disorders also. And again the same study in the Taiwanese, they have shown that women aged 20 years and older with infertility, they had twice the prevalence of OSA compared with the controls. And another important thing, this is polycystic ovarian syndrome. In this women with them, the OSA is approaching up to the men. We all know OSA is more common in men than women, but in this situation they are equal to men. And PCOD and OSA, they also have other risk factors like cardiovascular disease, type 2 diabetes, mood disturbances, all this can happen. Other than these, if you look at other endocrine metabolic effects, it can be seen in the overt hypothyroidism, we all know it very well. And it is independent of obesity, and even goiter can obstruct the area and cause OSA, independent of even thyroid functions. And other endocrine disorders like acromegaly, Cushing syndrome, and hypothalamic obesity, they have increased obstructive sleep apnea, and it is even disproportionate to the degree of obesity also. Other factors also will be contributing. And the recent meta-analysis, they have showed that OSA is even associated with osteoporosis, especially low BMD of lumbar spine. So now, without these two, our endocrine discussions won't end, especially related to this topic. Melatonin and vitamin D, the management of obesity sleep apnea. Just go back to your physiology, yes, that we have read circadian rhythm, melatonin. I'll try to simplify it. We have three these cues that light is the one important cue, and after that food and exercise. So this will decide the biological clock here. We know suprachiasmatic nucleus is the master controller here, and it will, pineal gland will be producing melatonin. It is not only sleep inducing but also antioxidant, anticonvulsant, and anti-inflammatory also. These are some genes involved in these mechanisms and all. So how this day and night is decided by the light, and this is the main biology. When what happens when it gets disturbed? This is what happening in the modern world of urbanization. So if you see here, the actual peak levels of melatonin start from 8 p.m. and till morning 7 to 8 it will be there, and then it start reducing. This is the graph of melatonin production. So what's happening is light pollution. This is the new thing which we are facing because of these digital tools and all. They are exposure to artificial light at night. So what it does, blue light and all this, it disturbs the circadian rhythm, and it is linked with not only obesity and sleep disorders but also cancer and neurodegeneration. So definitely there is a need for light pollution regulations. And other than this artificial light, late night eating, shift night workers, social jet lag, that weekend partying for long night, all this can disrupt your circadian rhythm, and it definitely impairs your metabolism, and it causes endocrine, metabolic, and cardiovascular diseases. So now to summarize the role of melatonin, it showed promising in the improvement of not only sleep quality and also outcomes in the patients with obstructive sleep apnea. We have to notice this point, particularly those with comorbid insomnia. That is the term they have given COMISA. And in the recent randomized study, they have shown 10 mg melatonin significantly improved sleep quality. Here all the p-values are significant. Insomnia severity, daytime sleepiness, and even posterior pressure adherence also it is shown to be better. And with this, I can say that melatonin is a definitely viable alternative therapy for OSA patients with a comorbid insomnia, and it can definitely enhance sleep quality and PAP adherence. But further research is needed to confirm its efficacy in the broader OSA population who doesn't have comorbid insomnia. So, and this is the vitamin D slide, only one slide here. It's a very interesting, and it has a lot of pleiotropic effects, and a lot more to learn from vitamin D. Still a lot of research is going on. So it has very well connected with the healthy sleep and airway complex also. So it has clearly shown low vitamin D associated with short sleep duration, increased sleep latency, poor sleep quality, sleepiness, and even obstructive sleep apnea. So now moving on to our primary focus related to how to redefine underlying obesity care and what is the paradigm shift happening with the new treatment options. So without connecting obesity and diabetes, we cannot discuss obesity in India. So almost 88% of people are overweight or obese in the type 2 diabetes diagnosis, and 80% of type 2 diabetes have poor glycemic control, that is hemoglobin A1C more than 7. This is the twin epidemic or dual epidemic. So when if you look obesity, diabetes and CVD, it's a very unholy trinity. So why it is unholy, you can see the numbers speak, there are a lot of deaths connected with all these three things. You can clearly appreciate death rates in the type 2 diabetes and even this obesity and all. So what should be the approach? So we have to target early, weight early, that is upstream approach we say. So how this weight loss is going to help? We should not wait till BMI is 35 or more than 30 and all. So early only we have to intervene. It can not only help to promote glycemic control, but also it will impact cardiometabolic risk factors, it will disrupt underlying pathophysiology, and it will reverse or slow down the disease progression, and even prevent the micro and macrovascular risk factors. So if you see, this is an interesting slide. Definitely there is always been tug of war in the weight management, especially related to weight loss and weight gain. So we all know low calories and high activity, the balance always towards this will improve the weight loss, but definitely metabolism will be reduced, hunger hormones will be increasing. Who try to lose their weight will be, can easily appreciate what I am trying to say, and decrease fullness hormones and all. Ghrelin is the one which is the hunger hormone. All these things will be trying to maintain a balance, and that's why sustained weight loss is not an easy thing actually. So I start with this interesting simple case. So here we have 55-year-old male with type 2 diabetes, obesity and hypertension with waist circumference 120, definitely very high, BMI is also very high. He's already on medication, metformin, dapagliflozin, linaripin, rosuvastatin, telmisartan, and even orlistat. He recently started walking, so he sees that it's a hypothetical case only. I can't seem to lose weight, and he's depressed and he's having even sexual dysfunction and excess snoring. How are we going to help this patient? What are the better treatment modalities? After this current treatment landscape, we can decide. So we have to definitely see what are the options available, and where very unmet needs are still there, and we have to strike a definitely important balance which improves both obesity and metabolic care. So this is one slide I want to summarize about the new, all the FDA approved drugs with their efficacy and the statistics also. So to begin with, phentermine, we are not using here. Naltrexone, bupropion, it is available in India also, but it's less much used. Orlistat, we all know very well, it shows up to 120 mg, 8.8%. Our patient is already on this drug. And the GLP-1 receptor agonist, the liraglutide is the one daily drug available. 3 mg is the one for obesity, and it showed up to weight loss up to 9.2. And phentermine, topamide, we don't have here. Semaglutide and tirzepatide. Semaglutide is now the most important drug nowadays in this GLP-1 receptor agonist, which have changed the treatment of obesity a lot, and bariatric surgeries have come down significantly because of this. And tirzepatide is a dual GLP-1 and GLP-1. So if you see here, I will be focusing on GLP-1 and GLP-1 predominantly in the coming part of my discussion. So if you see here, weight loss in comparison to the surgery, that is bariatric surgery, tirzepatide is almost matching, and even this is like one study which I am quoting. We have even seen even better weight loss. The more the weight loss we are appreciating, and even semaglutide also even better percentage we have seen in our real world practice. And in this they have shown 25%. So these are the options available for our patient. So, and first of all, I want to explain what these GLP-1 receptor agonists are. They are not only diabetes and anti-obesity medications, we can say they are cardiovascular medications. Now, a lot of research data has come up with, they are even helpful for CKD, so they are even helpful for heart failure, and most very wonderful drug and wonderful results we are seeing. So, to summarize just the GLP-1 receptor agonists in type 2 diabetes, they have very high glucose-lowering efficiency, no hypoglycemia, they cause weight loss, and they have cardiovascular benefit, and they have renal effects also, they can improve. Adverse events you have to remember, GI intolerance and potential acute pancreatitis. So glycemia improvement you can appreciate here, ASCVD risk is reduced, you can see the numbers are very good. And weight loss is definitely it's there. These are the options available, dulaglutide, liraglutide, semaglutide. Semaglutide in India we have only oral drug, liraglutide we have, dulaglutide we have, and injectable is yet to come in India. And if you see tirzepatide, it is both GLP-1 and GIP-1. So it acts on the brain, decrease appetite, decrease food intake, and increase weight loss. And in the pancreas also it will increase the insulin secretion. These are actually nutrient-stimulated hormones, we say NUSH. So increase and even they are helpful for beta cell survival. And the wider deposition they increase the lipolysis. So just a simple comparison how these two are effective in type 2 diabetes and also changing the weight. If you look at the change in weight, tirzepatide 5 mg, 10 mg, 15 mg I have shown here. The color is compare with the colors here. And semaglutide, this is once weekly 1 mg, which we don't have in India right now. So this is this one. So semaglutide 1 mg is definitely less than tirzepatide 5 mg here. So now in India we have tirzepatide 2.5 and 5 mg available. Just recently come last month we are having availability. So if you compare the weight loss here, so definitely semaglutide 1 mg weekly, then tirzepatide 5, then tirzepatide 10. These are weekly, all are weekly injectable subcutaneous tirzepatide 50. So significant weight loss can be seen here. So and if you look the tirzepatide, there is one trial Surmount OSA. So here the obesity and sleep apnea, as Dr. Sudhir already mentioned about this. So here the patients received two types of patients were there with CPAP and without CPAP. And change in the apnea hypopnea index, they have shown tirzepatide is showing much better compared to the placebo, and it is very significant also. And in the graphical also you can see for not only weight loss and AHA both compared to the both groups compared to the placebo, you can really appreciate how this tirzepatide is going to give wonderful results here. And to what should the precautions we should know for this GLP-1 and GLP-1, both co-dual and monogonist. So medullary thyroid carcinoma, medullary definitely is contraindicated even though it is there. PTC there is no contraindication, tablet thyroid carcinoma. Pancreatitis definitely we should not use this fast history of anyone having pancreatitis, we should avoid. And birth control should be there always for both the drugs, because they should shift to this barrier methods and all these precautions they have to take. At least 2 to 3 months before conceiving they should stop this drug. Even safe preferably 6 months. Breastfeeding should be contraindication. And one important thing in day-to-day practice is hypoglycemia with comorbid use of this sulfonylurea, concomitant use and insulin. Definitely the risk of hypoglycemia we have to lower by reducing the doses of sulfonylurea or insulin. We should keep this in mind. And coming back to our case. So he was started in semaglutide, then obviously linaglutide we should stop. Both mechanisms are almost same. And we can appreciate the improvement in waist circumference 122, 110 and BMI reduction, weight reduction and all. And his current medications are these. So we have added oral semaglutide which is available in India. He started with 3 mg, then 7 mg and came to 14 mg. And physical activity also became much better. But further he is not losing weight. What can be done? So if we see again, now he was started and then tirzepatide and further weight loss we have seen. So 10 mg we don't have in India, we have used 5 mg to OLs for this dose. And even further BMI reduced and waist supports improved, everything is improved. And even he felt better in their snoring acid and all, even much better in their tiredness, fatigue and all. So still further he felt one interesting point which is body composition. So for when he investigated that can help him. So I want to say glucagon agonists are in the pipeline. It can help by increasing energy expenditure and increase fatty acid oxidation. So these are the glucagon agonists like survodutide which is already in the phase 2 data for MASLD also. Retatrutide is there for obesity, promising studies that happen. This is a triple agonist, GLP-1 and glucagon. So body composition, just thought to give you this one slide. So fat-free mass and fat mass. So if you see the comparison, so obviously weight loss is associated with both fat mass and fat-free mass, and this is primarily due to breakdown muscle protein. And we have to explain the patients the need for increasing the exercise and the protein intake. And they have obesity people already, they have greater amounts of fat-free mass. And this loss of fat-free mass may decrease muscle strength, but not likely to decrease physical function. So future directions, as this body composition aspect I have got up, myostatin activity pathway inhibitors MAPI, they are coming up. So they can help to prevent this fat loss, fat-free mass loss. And it can be potentially used this GLP-1 adolescents and pre-diabetes also. We can combine cagrilintide is the one once weekly amylin analog, which is planned to combine with semaglutide. It is a nutrient stimulator hormone. And we have to focus on personalized obesity pharmacotherapy, phenotype-based interventions. So take-home points for obesity. Obesity is a common chronic inflammatory and complex disease. Definitely it is difficult to achieve clinically significant weight reduction just with weight lifestyle modifications. And nowadays incretin based on nutrient stimulator hormones are evolving therapeutic class for obesity and related complications. Semaglutide and tirzepatide, they are the most effective agents currently available for us. These are coming up glucagon, prevalence and amylin analogs. And definitely we have to create individualized obesity treatment plans with smart to treat obesity so that it should be beyond body weight and it should optimize their health and quality of life. So this is the take-home point for obstructive sleep apnea. Both are very closely linked with bidirectional relationship, and it can worsen obstructive sleep apnea can worsen weight gain through hormonal behavioral pathways, and it is also a major cardiometabolic risk factor, and it increases risk of diabetes, hypertension, and MASLD. Weight loss significantly improves OSA. Even I have shown already 10% weight loss can be helpful. and we should always focus on comprehensive screening and management. They should be screened for metabolic and other comorbidities, and multidisciplinary individual approach is essential for the optimal outcome. Thank you.
Thank you for the activities presentation, sir. And now request the chairpersons to chamber.
Audience మాట్లాడాలండి, chairperson speaker మాట్లాడేసి any comments or questions from the audience? Please.
You said it is terzepatide and semaglutide are contraindicated in papillary carcinoma thyroid.
No sir, it is medullary thyroid.
But it is written that these two things can cause carcinoma of thyroid.
Yes sir.
Semaglutide and terzepatide both can cause carcinoma thyroid. What is your comment?
Yes sir, yes sir. That is shown in actual animal studies and not documented in the human studies, but it is medullary thyroid carcinoma, which we see most commonly in the multiple endocrine neoplasia type 2, MEN2. But it is not associated with papillary thyroid carcinoma. And the PTC is the most common which we see, and MTC is the rarest thyroid carcinoma which we see.
But still you will advocate in spite of this complication these two drugs.
Yes sir, we can explain because it is shown only in animal studies, and it is medullary thyroid carcinoma, not papillary thyroid carcinoma.
Okay, thank you.
Thank you sir for bringing up this question.
Obesity is more dangerous than the theoretical risk of MCT.
Yes.
So Dr. Teja has said there is a tiger next door and here is the rope, go and tie it. So he wants to modify the energy intake and output. Those of you who have tried to measure obesity using the simple BMI, find patients said, I saw my weight in my bathroom, it was showing only 68.9. I think the clinic weighing machine is wrong. Same way, measuring the height is also quite difficult. Keep these 2 points in mind before you are very dogmatic about this. And so he's saying there's something called clinical obesity that is much more relevant, where BMI should be matched with other risk factors, the so-called metabolically unhealthy obesity. And when I was doing my DM, the Williams textbook of endocrinologists gave all these lists, and finally it said obesity is defined when the person looks fat. So ultimately that's what aesthetic kind of thing, it's a subjective kind of thing, but we can't really brush it aside. And practical points about the drugs, sleep is very important. They say that disturbed sleep is as important as elevated level of LDL for adverse metabolic effects. And second is, if you can stop using water from plastic bottles, the endocrine disrupting chemicals they add via the microbiota, and these two are cheap and maybe not very difficult interventions that can be done for those of us who cannot afford the newer drugs. And he's given an excellent overview of how obesity is caused and what are the methods that are available. As a speaker, he is anchored to speaking of what he has been asked to speak on. And as the chairman, I have taken a little bit of effort to go beyond what he said. అందరూ ఎండోక్రాలజిస్ట్ మాట్లాడిస్తున్నప్పుడు ఏంటి డాక్టర్ ఏమన్నారు, unless we have your feedback, the loop won't be closed.
The presentation is very nice. Thank you.
So I would just like to add one point, sir, about this endocrine disrupting chemicals. So recently, World Hormone Day, we have conducted for the first time ever in the world, and it happened in April 24th. And they have clearly told the focus should be because endocrine disrupting chemicals, like they are present not only in the plastic, but also dust mites and even many of the cosmetics. So we should be knowing which should be avoided. Bisphenol and many other things are there. So they will be disrupting your hormone balance and causing a lot of complications, reducing your quality of life. So please be aware of these endocrine disrupting chemicals in your day-to-day life. Thank you.
Sir, sir. Take it right, sir, right. One more smile. Sir, come. Sir, get ready. One more, sir. Okay. Sir, correct.
Scenarios of adult OSA multidisciplinary management. Now I take the honor to request the panelists to come on to the dais for this session. Dr. P.V. Ramana Rao Garu, Senior Cardiologist of Visakhapatnam, who worked as Professor and HOD Department of Cardiology, served as the Principal of AMC for a brief period. I request you to come on to the stage, sir. Come on to the stage. Dr. A. Maitri, ma'am. Dr. A. Maitri Garu, famous endocrinologist, Visakhapatnam, served as the Professor of Endocrinology. Andhra Krishnan Garu, Senior General Physician, Professor and HOD of Andhra Medical College.
Dr. Srinivas Kishore Sisla, Director, Department of ENT and Sleep Apnea Services, AH Hospital, Hyderabad. Dr. Srinivas Kishore Sisla is a highly experienced ENT sleep surgeon practicing at AH Hospitals in Hyderabad. With 23 years in the field, he holds an MBBS and MS ENT from Manipal Academy of Higher Education, India. He has completed fellowships in endoscopic, sinus surgery, and sleep apnea surgery at renowned institutions like the University of Pennsylvania and the University of Wisconsin. His clinical attachments include working with the notable professors in the United States and Australia.
Who is student of Andhra Medical College, Dr. Jayadisa Garu, student of Andhra Medical College. Next slide. And is a grandson of Dr. Jagannath Garu, is an ENT surgeon, 1940 batch. So he is a grandson of our composer. Really, we are all proud of you, Kishore.
Good morning, everybody. Can you hear me? Yes, sir. Right at the back. Yeah, thank you. So, I think we have a stage full of stalwarts here. And of course, the biggest stars are here. So, you're also panelists, by the way. I think, first of all, let me first thank Dr. Apparao to put us all in such a, it's a truly multi-speciality, interdisciplinary condition for which it requires anything but an interdisciplinary care, right? In terms of management, so this is how we're going to go about with the panel. I'm going to start off with some introductory slides, and then we'll go system by system, and probably I'll involve. That's okay. So, all of you have basically seen this morning with prolific presentations from the speakers before me as to what is sleep apnea. And as we all know, sleep apnea comes under the big banner of sleep-related breathing disorders. Now there are 4 kinds of sleep-related breathing disorders. Each one of them are different from one another, and these are the basic tenets based on which we differentiate one another. Right? For example, is there a... Yeah. Okay, so there is snoring, upper airway resistance syndrome, there is obstructive sleep apnea, and there is obesity hypoventilation syndrome, and these are the basic ways in which they are distinct from each other. But I would like to draw your attention to this particular video. Audio, please. That's all you're going to do. Audio, please. Yeah, the whole hall is vibrating with snores. All of you agree that this is sleep-related breathing disorders, correct? And how do we measure sleep-related breathing disorder? Based on what Dr. Sudhir said, different kinds of sleep studies. And what is the outcome? We look at AHI as the primary metric of measure. These are the sleep studies of all these three individuals, right? But if you can see the AHI of all three of them, I'm not sure if you are able to see it. And I've encircled that in red. Sir, Appara sir, can you just read those things? The first, the second, and the third. All of them, if you can read the AHI.
The first one is 274.
That is total event, sir. Index is in the bracket. AHI is
50.4.
Second patient.
50.2.
Third patient.
50.4.
But do all of them look the same? Just because the sleep study is saying 50, does it mean our management is going to be the same for this person, and this person? It is not. The primary problem is that till now, today, what we were doing is measuring everything with the only yardstick that we have. And Dr. Sudhir brought a very nice concept, which is the phenotypes and endotypes, wherein we'll have to do some kind of risk stratification and personalization of medicine. And when you dig deeper into this, we come to understand that sleep apnea is not a single problem. Sleep apnea has various pathophysiologies. And this is something that we should be completely moving from. If we are practicing veterinary medicine and broken leg treatment is shoot, infected eye shoot, splayed hoof shoot, runny nose shoot, the treatment for all of that is shoot. Similarly, if we go by this and would have given CPAP for all of these patients, just because they have an AHI of 50, what does that make us? Veterinary specialists, right? I think even veterinary medicine is not practiced the same way today. So there is a definite need for us to understand what is going on underneath all these three basic patients. And there is something that has also changed. Now, if all of you close your eyes and see OSA, what do you think of? Based on what Dr. Raviteja just said, most OSA patients are obese and men, which is not true. There are a significant, if we do a sleep study here, there may be about 50% of us, we may have some amount of sleep apnea affecting us in some way or the other. And I will bring up some data about that. Now, people are starting to realize that sleep apnea and other sleep disordered breathing can affect a wide range of people. The women, which manifest differently and don't get picked up because they're not doing the test properly and not asking the right questions. Two, the teenagers that we present differently now with all the kind of inputs that they get and their quality of food that they eat and the lifestyle that they lead. So, sleep apnea is not something that is a male-specific, gender-specific condition. Number two, it does not just affect the obese people with craniofacial problems. It can affect anybody like you and me. This is something that we published in sleep medicine clinics where chemosensitive receptors in your carotid body and the arch of aorta are responding, how your tongue dilator, which is the genioglossus, is responding to the negative pressure in your upper airway, and how your brain responds to the increased effort to breathe. So these are all the things that one needs to understand before we go ahead and manage this. So if you look at the problem in India, this is data from India in 2007. We were 7.5 in men and 4.5 in women. And this is prevalence of Indian population 2023. From 7 to reach a dubious number of 32.5% of Indians have obstructive sleep apnea, which is a staggering number, and that is why in order for us to all fight this condition, we need to improve awareness, and awareness has to come across specialities. So the emphasis, dear colleagues, is on early detection and management, more in lines of primary care. Evaluation is also key to select the right algorithm for the patient who is sitting in front of you. But the question is, where and which specialty do we start? Right? I mean, if we can go to the next question, if we can just introduce ourselves, and I think one by one. Sir, we start with you.
Good morning, everyone. I'm Dr. Satish, transplantation surgeon at Professor and HOD within Manipur.
Thank you.
Good morning, all. I'm Dr. Achut Gongada. I head the Department of Anesthesia and Intensive Care at Apollo Hospitals.
Good morning, all of you. I'm Dr. KVV Satyanarayana, ophthalmologist, Professor and HOD of Gita Medical Institute and Research.
Everyone, I'm Dr. Maithili, endocrinologist at Visakhapatnam. I'm happy to be associated with today's CME, and I thank Dr. and his team for the kind invitation.
First of all, I should thank SK Apparo, gave me a last minute call yesterday, asking me to replace somebody in an emergency. I'm very happy to be here in the presence of my former teacher, General Mission Dr. Chittabandalu, and other teachers like Dr. Chandrasekharam, Dr. M.V. Appara. I would have missed many in the audience. I mean, very good friends, and some of them are also my students. It's a very good gesture to have an academic initiative for the last 2 months initiated under the new leadership of Snoring Osa. I am Dr. Raman Rao. I am also a teacher to many, I think, probably in MBBS, MD, and DM cardiology. I have worked my whole time. AMC is my bread and butter and a second mother. I am always proud to raise the flag of AMC in any fora given to me. Thank you very much for this opportunity.
Good morning, I'm Dr. Sunil Kumar, Pulmonary Professor at HOD, Department of Pulmonary Medicine, Andhra Medical College, and Superintendent of the County Health Hospital. And very thankful to SK Apparo for arranging such a nice stage with the audiovisuals, and even the timer is also there, maintaining the very good timing during the sessions also. Thank you, sir.
Good morning, all. I am Dr. Radhakrishna, Professor and Head of the Department of Medicine, Andhra Medical College, Deputy Superintendent KGH. I thank Dr. Apparo for giving us this opportunity. Thank you, sir.
Good morning, all of you, respected teachers and dear friends. Actually, this concept was initiated with one of the feedback from the previous CME program. In March 23rd, we have conducted a multi-specialty CME program. And after that, the feedback is one of the professor of pediatrics, Dr. Padmalai, as mentioned, he quoted one newspaper article, and the hypertension be cured by treating the OSA problem. And our Dr. Somasra ignited that and started this idea, and today we are able to see the very good response, overwhelming response, around 400 members, means not a small issue. And thank you one and all for attending this and making this grand success. I am Dr. SK Apparo, EM surgeon for the party, 40 years.
Thank you, sir. So we have stalwarts here, and let's see what best we can get out of all of them. So So I think I'll go from Dr. Satish. In fact, so the question will be common for all of you from each of your specialties. See, because this is if all of you remember that cartoon where we are all looking at the same elephant, but we are holding different parts of it. One person is holding the leg and saying that it's a pillar. One person is holding the tail and he's thinking it's a snake. So on and so forth. But we are all looking at the same animal, right? So what we will try to see is how is this sinister condition called obstructive sleep apnea presenting across specialties. So I think we'll start from Dr. Satish and probably we'll go from person to person. How does a patient with OSA present in your specialty?
Most of the times, like we the maxillofacial surgeons, like we deal with various types of dentafacial deformities. We deal with most of the dentafacial deformities very commonly, like mainly the class 1 or class 2, class 3 deformities. So when a patient comes with a class 2 or class 3 deformities, that is where like we expect these patients to have some form of obstructive sleep apnea, or like where they are having narrow arch palate or like other conditions. These are the patients we expect and we tell them like before doing any orthognathic surgeries or PMD surgeries and all, we send these patients for sleep assessment also so that the post-operatively we don't encounter any of this obstructive sleep apnea. Thank you.
Thank you, sir. That was perfect any time. Sir, you must be seeing on screening a lot of patients, especially when they come for bariatric surgery, when they come for any surgery for that matter. So if you can be very crisp as to what is it that you really look at phenotypically, and what is your go-to tool, and what are the alarms that you raise when you see such a patient?
So as an anesthetist, we come across lots of patients coming for all sorts of surgeries, right from scalp till the toes. So when we see the patients, in the first place, we look at the obesity, and obesity triggers the possibility of obstructive sleep apnea syndrome. Though we do find people who are not non-obese, but still have obstructive sleep apnea syndrome. So this will be a risk factor both intraoperatively and postoperatively for airway-related complications and breathing-related complications. So during surgery, during induction of anesthesia, it can cause difficulties in airway management.
I have questions for you separately.
So when we see the patients for preoperative evaluation, we look for screening tools, and there are lots of screening tools available. The initial and easy screening tool is stop time questionnaire. So is the patient snoring? Is there are any observed apneas? And is there tiredness, and how are the pressures, blood pressures? And BMI, neck circumference.
So we'll come to that.
So we all look for these screening tools and then go for the specialist evaluation as required.
So from an off-tel standpoint. I know, so that we have, but how, supposing when you look at a patient who has a particular problem.
Sleep apnea, now we made it a point of the glaucoma screening. So the patients with glaucoma screening, in spite of the good control of IOP with all the medications, in spite of that, the glaucoma disease itself is progressing. So for that, in spite of adding so many medicines, if we miss this simple historical point sleep apnea, we break our hands how this glaucoma is progressing in spite of good control of it. So we mandatory, and we included this history of taking the sleep apnea in the clinical workup of.
So that's a very, very important point also, because as ENTs, we know that allergic rhinitis is a very common comorbid condition for sleep apnea, and we tend to use a lot of intranasal corticosteroids. And if this patient were to have glaucoma, And if you use indiscriminately intranasal corticosteroids, there is a higher chance that the patient's glaucoma may get worse. So how much absorption happens depends on drug to drug, but we have to keep that in mind. I think that's a very nice point. Matt, from endocrine perspective.
Thank you. So, OSA is a very common comorbidity in endocrine metabolic diseases. Maybe around 1/3 to almost 50% who have OSA. So, common disorders are, number one is metabolic syndrome. So, it is so common that today we use the term somnometabolic syndrome, a combination of metabolic syndrome plus OSA is called as somnometabolic syndrome, just to emphasize the relationship. Then second is adolescent girls with PCOS, obese adolescent girls with PCOS. Then number 3 is diabetes in young, again obese individuals. A very common comorbidity is OSA. Then as has been mentioned by Dr. Raviteja, all endocrine disorders, hypothyroidism, acromegaly, Cushing's, then aldosterone excess are all associated with.
So you're going to screen all of them for?
Yeah. And most important is men with hypothyroidism. Yeah, thank you.
Sir, in your specialty?
I think OSA is a quite underdiagnosed disorder. Sleep disorder is to be specific. Nowadays the concept is all patients of hypertension have to go at ambulatory blood pressure monitoring. The most important aspect of hypertension, which causes increased cardiovascular cerebrovascular, is nocturnal blood pressure. And nocturnal, especially if it is rising during night or it is not falling during night, indicates probably a sleep disorder with at least a substantial number of years.
Dipper or a non-dipper?
So hypertensives who are having only labile hypertension is not as benign in all patients as we think. Similarly, patients who say they're getting early morning headache and early morning BP is higher, daytime BP is almost normal. Again, you have to suspect sleep disorder, breathing. Third disorder, all of them have been taught, resistant hypertension. When you give 3 maximal doses of the drug, including the diuretic, the BP is not controlled, it is called as resistant hypertension. Substantial number of the people have activation of renin angiotensin aldosterone system has already been taught in biochemistry and physiology. And aldosterone levels are substantially high in such patients. And sleep disorder breathing also contributes to increased aldosterone levels. So hypertension in these aspects with early morning headache or non-tripping patterns or difficult to treat hypertension or intermittent hypertension, early morning hypertension are subsets. Second, patients having in addition to other risk factors, in spite of being optimally treated, they are not having adequate options, management like coronary artery disease, cerebrovascular disease, and arrhythmias like atrial fibrillation. Now the algorithm for all patients of atrial fibrillation, intermittent atrial fibrillation, or paroxysmal atrial fibrillation is like atrial fibrillation, a common disorder. As age increases, it increases in incidence. And especially nocturnal atrial fibrillation or nocturnal palpitation by water monitoring, if you detect them, kindly look for sleep disordered breathing, and OSA is an important concept. They can also have sudden cardiac death. Similarly, heart failures where the heart is either not pumping properly or not relaxing properly, sleep-leading disorder can also contribute. Now remember, all this does not mean sleep disorder breathing is the cause of all these disorders. Because all of them share common pathophysiological disturbances known as insulin resistance, inflammation, oxidative stress. There are so many things to be talked. I think it should be crisp. Thank you.
Thank you, sir. Sir, I think you and me will have lots of things in common. Not so, sir.
Good morning all once again. So basically OSA revolves around the hypoxia. So that's what the
hypoxic burden.
Yeah. See that sudden awakening from sleep is just a difference of SPO to around 4 to 5%. So that's very crucial for the things of this. And increasing the decreased tone and increased collapsibility of the oropharyngeal muscles is very alarming feature in our actually how to deal with the patient. And this is going to reduce the volumes of the lung, and the expected reservoir volume is also decreased. And especially the patients who are having comorbid like COPD, asthma, they definitely have more acute episode.
What we call as overlap syndromes.
So that is why the pulmonary hypertension series is also more in cases of OHCP. So what we suggest from primary screening level is that during the clinical case history taking, I always advise my postgraduates to
that I have.
The sleep pattern is there. Thank you.
So as a physician,
so you will have the biggest sort of menu because anybody and everybody will be coming into you, and I think you are one of the biggest pillars in this kind of management.
Check the associated comorbidities whether the patient is having hypertension or diabetes, increased sympathetic activity, hypertension. These patients may land with cardiac failure or atrial fibrillations, cardiac failure with preserved ejection fractions as well as diastolic dysfunctions. I have to take all these things into consideration.
Sir, last but not the least.
So coming to the patient point of view, most of the times the patient denies. I'm not snoring. If they come as a wife and husband, the wife says, no, sir, chala custom, sir. So this is all, the first point is it's a denial problem, most of the time. So you have to evaluate the proper way and not to hurt his feelings. So even I snore. If I take ice cream, I'll snore that day. That means minimal congestion of the nasal cavity can produce snoring. But snoring doesn't mean that it's OSA. See, this is sound only. But holding breath, respirating negative pressure in the chest, that is OSA. So if you ask the partner, bed partner, the best diagnostic criteria is from the bed partner, not from the all this laboratory test or the secondary. If the bed partner says, sir, suddenly lechipotarante, well, kenda padipotarante. So these are all the presentation of the patient. And some people say, sir, I'm not able to travel by train. Why? That means there are a lot of disturbance with the co-passengers. So these are the things. So your presentation is a delicacy. You have to ask in a delicate manner to evaluate the patient. Then that's how the patient comes. Even nasal obstruction is one of the cause for even CPAP which will not be accepted by the nasal obstruction fellow.
So basically this is a condition which is like it can present to different specialists in wearing different clothes. It's a great drama artist like Dr. Matsudan, who's a great drama artist. So sleep apnea is, the underlying mechanism is the same, but it sort of wears different, so with the same platform, it wears different things. So one needs to be very clear as to, even though phenotypically it is presenting differently to different people, the underlying mechanism is the same, and hence it becomes important that we all ask the relevant questions. So, I'll ask the physician, sir, because you see a lot of these patients, and you will be very busy, you'll be seeing so much OP. So when you suspect, and any kind of a favorite questionnaire that you have in a busy OPD that you would like to use, or do you generally go based on history?
Usually go based on history. We'll take the patient's history as well associated comorbidities.
Sir, I think we'll go from here to there. Any kind of questionnaire which is your favorite, because this has all been discussed. But if you can come out with a favorite, please let me know why it is the favorite.
So, simple questions like daytime somnolence, fatigue, unexplained fatigue. Many times patient because they're just tired or some fatigue. So probably with associated comorbidities, I think we do suspect. And then spending couple of minutes in the OPD is fine. Or simple look for any risk factors as already have been mentioned, like age, gender, so on.
I think I'll ask Dr. Archul. Now, everybody talks about stop bank questionnaire, and I think it has been very clearly grilled into all of your head. Now, from an Indian standpoint, do you really think that stop band is a good metric of measure? Especially body mass index more than 35 people. That means anybody and everybody, like somebody like me, who do not have a body mass index of 35 will not come into your, so these people will be slipping between your fingers. Number two, the neck size, 43. I mean, I'm sure you know a lot of people who wear a shirt size of 38 or 39 may have sleep apnea. So what do you think in terms of this? Is this adequate for our Indian population? This is something that we published, that stop band is not for Indians. Your perspective.
I can see the publication from your own work. Yeah, stop band is a very good sort of complete questionnaire. Probably we being Indians, we may have to change the parameters of exclusion or scoring. But the questions as such are important, are more or less full.
That's a very nice way of putting it.
So we cannot use the same parameters, like as you mentioned, body mass index of 35 is way abnormal body mass index for Indians. So instead of 35, we can consider 25 and give it the same score, and even other parameters as well. But it's very short and quick method of assessing or screening the patient for obesity or sleep apnea related problems.
Sir.
Dear delegates, I have given both the efforts scale and the stop band score in your folders. Please try to fill it.
So since you raised that topic, sir, how relevant is effort sleepiness scale for us? I think any one of you can take this question. Especially, how many people in India actually drive cars? It is increasing, number one. Number two, if you look at the last but one, sitting quietly after lunch without alcohol, I think again, from an Indian standpoint, again to be taken with a pinch of salt. So as Dr. Achyut said, I think the questions are pertinent, but the way they are asked, we'll have to tweak it for our population.
What a failure.
Little bit. Sir, anybody who likes the Berlin question?
It's not daytime sleepiness alone. People are rapidly losing their memories, especially they are also before 60 years of age. People are losing their concentration, especially academicians and software engineers. People are having emotional outbursts, either depression or arousals or anger, which is not present previously. This could be the manifestation also, need not be only sleepiness.
Correct.
They are all considered as equivalents, though less common, you have to ask them.
Correct.
Absolutely. Easy category, especially women. That's why women always is missed.
So that's a different topic. I think I'm glad you brought that up, sir. We're going to have that question. I bought some case vignettes that we will discuss.
Keep for time in mind that it is so more important questions I think we can discuss. I'm not saying it's not important.
And then I got it, sir. So because we also have a plethora of people, we are almost 8 of us, 9.
What I mean to say is time also should be managed.
That's it.
Because I think your topic requires about an hour or more also sometimes.
So I think we will skip this clinical exam, but maybe one of you can just volunteer what clinical exam, just maybe stick to the point, because now I've been reminded that I have only 17 minutes, but we have a lot of ground to cover. So if any one of you can quickly, clinical exam, is there anything that you would do from your specialty standpoint? I think Dr. Satish, I think that I will, yeah, this is good.
So we look mainly whether what is the type of population, but clearly like mostly the skeletal class 2 and skeletal class 3. So skeletal class 3 or skeletal class 2, these people have like, we see what is the type of, whether there is deficiency in the arch width of the maxilla, or retrographic maxilla or metaplastic maxilla, mandible or something like that. And Another thing is we assess we take certain X-rays like spectrograms and see exactly what is the airway space which is present between the oropharynx and the hypopharynx. So these are some, or we'll do some cyclometric analysis and finally rule out what is the amount of airway space that can be, that is being compromised in these particular patients.
So the most, why we brought this up is us as ENTs and pulmonology and all of us, we forget to look at the oral cavity. It is very important. It has been shown that 60% of people who have some kind of malocclusion will have sleep apnea. We need to understand that and we cannot take that away. The other concept of what we call as high arched palate. Now, all of you, when you close your mouth, where is your tongue? Is it touching the inner part of your upper teeth? Yes or no? Yes. Can you please, let's have a show of hands and see how many people's tongue is touching the inner part of your upper incisors? The rest it's not touching? And you'll have to consult us. So again, how many of your tongue is touching the upper part of the teeth, your upper incisors? All of you? That's a better thing. They're either scared of us because we have to come for consultation. So for people who have what we call as a high arched palate, there is no space for the tongue to sit there. And this is a major epidemic that we are seeing nowadays because of our dietary profiles and also because of chronic mouth breathing. So I have 15 more minutes, so I am rushing. This is a huge subject by itself. And this is called as loss of coupling. That means the tongue has no place to sit inside where it needs to sit. That means the car is bigger than your garage. All right. So actually I'm not sure if you are able to see. Any relevance to tongue ties? I think Satish, this goes to you again. Very quickly, please.
It's very common, like angular glossia is very common situation mainly in children as well as adults also. So because they can't, this is mainly the tongue can't move properly and the tongue won't necessarily say that it's coupling mechanism lost in these particular patients. So these conditions can lead to obstructive sleep apnea and some conditions, mainly in children particularly.
Aparav sir, this question is for you directly.
Tongue has got a lot of functions, not only the
No sir, not that tongue. I think Satish spoke.
Yeah.
Role of CTPNS.
Yeah. The CT is, we have to take all three sections, coronal, axial and sagittal also. The coronal will see how the palate is, how the roomy nasal cavity and all. Based on that, we can see what is the resistance the patient is getting through the, if it is narrow, the upper airway resistance. Then comes to the what is the length of the hard palate, the sagittal sections, and what is the soft tissue. That's the palate, soft palate, and ovular. Then how about the tongue base? The tongue base is suppose bulky and all. The space between the retroglossal space is very narrow, and the patient is under the intubation. They are liable for OSM. So all these parameters can be seen in. It's a static obstructive phenomena can be assessed with the CT scan. I mean the dice.
That will come later. Okay. So this is basically to see, just to rule out if there is any sinus involvement also, because it has been shown that more sinus involvement increases nasal resistance, hence. All right. And this is something that we are also seeing very clearly. This is adenoids, and we are seeing adenoids in adults also nowadays. And this is a patient who was given CPAP, not looking inside as to what is causing all that AHI. So a simple flexible examination inside can give us an idea as to whether this patient requires something else other than just blindly giving a CPAP. Right. So this question I think we'll ask to the pulmonologist. Sir, very quickly, what level of sleep study for what category of patients? I do not want what levels. I think Dr. Sudhir covered that beautifully. What category will you prescribe what level?
As per the literature, actually, Sudhir has already told the 4 types of sleep studies are done.
So in your practice,
but what category of patients?
What category will you offer? Which?
Yeah. There are only the asymptomatic patients also there in the diagnostic. So for any unexplained hypoxia events or any daytime sleepiness excessively, is there any undiagnosed pulmonary hypertension even in the adulthood also? So those are the things especially, and along with all the visas are not cross class. So these are the set of population where we go for category of patients. We go for sleep studies. Along with the
which level? Which level?
What mean?
Which level?
Which
level of sleep study? Like, for example, if there is a patient with COPD, heart failure, and seizure disorder, what level?
Yeah, basically level 2 is the one, or level 3. So those are things. Sleep study.
So, if there are comorbidities, we would probably prefer a level 1.
Level 1 is very cumbersome. It is not available everywhere, and it is also associated more of neurological examination and the EEG also. So level 2 is the best one, I suppose.
Correct, sir. That's from a practical standpoint. But if you have a patient with multiple problems, for example, a person has a seizure disorder, let's say, it's probably a good idea to put him up for level 1 study. So from a cardiology standpoint, one point, which level would you prefer? Supposing there's a patient with heart failure.
I'm not very sure about what these levels are because it's not part of my head.
So you would send it to somebody like us too.
Yeah.
So we are happy about that. Then, role of nose and nasal airway patency. Now there is a lot of literature to show that how nose is pivotal and primary in the management of obstructive sleep apnea. And this is something that, can anybody tell me other than upper house what is happening here? Of the
collapse of the pharynx?
No, sir. That is what Dr. Achut and us see every day. So, yes. So if you have a collapse happening at the level of the epiglottis, probably giving CPAP for these patients may not be an ideal way of treating these patients. Hence, it becomes again very important for us to look at the shape of the airway and the structure causing the obstruction. So, information from sleep study will go. Sir, this is for you. Sir, I have series of, because see, anything that you are relating to cardiac suddenly becomes important. If somebody says I have allergic rhinitis and I have OSA, nobody will care. But if you say you have a cardiovascular problem, everybody pays attention to it. So let me just bring these things, sir. So there, like how you beautifully said, this is the pathophysiology. And there is a lot of literature, like how you alluded to earlier, that CPAP is very good and it brings down cardiovascular morbidities. But I would like to draw your attention to these particular publications. Especially particular phenotypes like positional sleep apnea patients. In these patients, it has been shown that just giving positional therapy itself gives them very good relief in terms of the problem. So, it's not that only giving CPAP for every patient is important, and hence the importance of reading your sleep study properly to see what is going on. Now, this is also not my question. This is my question, and all of you must be, this is called the SAVE study. This is from the New England Journal of Medicine. CPAP for prevention of cardiovascular events. And if you see down, no significant effect on prevention of recurrent serious cardiovascular events despite significantly reduced sleepiness. This is called the SAVE trial. This is funded by ResMed and the equipment given by Respironics and equipment given by ResMed. What is your point here, sir?
Due respect is a long-term back. 2016 is a long-term back. Months makes a difference in approach to every problem. latest reports regarding the role of CPAP and lifestyle modification and correction of comorbidities probably will decrease both cardiovascular mortality and morbidity. All the studies which are done randomized, some of them are underpowered, some of them are done on patients who have used CPAP for less than 4 hours. So many
That is the
parameters.
same trial. That is why I put this
Yeah, so I think if you want to comment on these things, I don't comment on 10 years back trials.
Sir, please comment on something 5 years old. This is a 8 randomized control trials, 5,817 participants.
2023 review by American College of Cardiology, they say there should be a methodologist probably error in all these trials. There has to be a randomized or a meta-analysis trial taking multiple criteria because it is not a disorder, it is a mechanistic involvement of the jaw or throat muscles. It's a systemic disorder involving multiple things like insulin resistance, inflammation, so on, so forth.
So because we need to give take-home messages.
The take-home message is quite simple. They do have a role.
Absolutely. We are not saying that. But what we are saying right now is the SAVE trial, yes, you said that is true. But it's just not that only CPAP delivers. Positional therapy delivers. Mandibular advancement devices.
Lifestyle modification delivers. And correction of anatomical factors delivers. Correction of sleep problem, supine posture also delivers in certain subsets. Not all subsets. Supine posture accelerates the mechanical compromise in the upper airways in all patients affected with sleep apnea. More so in certain subsets where only supine posture causes what is
Done, sir. I have only 5 minutes. So, ma'am, we know the wonder drug now, tirzepatide, which seems to be working in everything that is possible. Tirzepatide is also being shown to sort of eliminate, also this is the insights from the Surmount OSA trial, which is supposed to be very good for cardiovascular also. This seems to be the wonder drug, like the solution for everything. In your practice, in your understanding, what do you think of tirzepatide?
So in India, we have just started using tirzepatide. So I think we really need some more time to really know its benefit. Number one, tirzepatide is right now approved only in the management of obesity and type 2 diabetes in India.
Point taken. Perfect. But this is a Lancet publication, which basically shows that most patients of OSA have no obesity, with 44% having overweight and 23% having underweight. So, for after all, this is not a disease which is only for the obese, and that is what I would probably like to do.
I want to add one thing.
Sir?
It's not the amount of fat you have in the human body. It's the amount of the metabolically active fat which is available in the human body. The fat which can go far and wide from the adipose tissue into the liver, into the heart, into the peritoneal walls, into the kidney, which causes cardio, knee, metabolic health in the middle-aged and elderly. Keep this in mind.
So one point about tirzepatide is, I think right now we have to limit its usage to individuals who have a BMI of more than 30 plus OSA. Not to everyone, it really doesn't help you.
Sir, I think we need to give Sir also some time to give his presentation of that standpoint. So I'd like to also bring this to your notice, the use of statins and associated new onset diabetes when there is a patient with hypertension and OSA. So, sir, do you want to come now, or maybe after I finish you can, I think that we will. So let's go with case vignettes. We'll go from the pulmonology perspective first. These are the, this is the patient, sir, who typically walked into your clinic. Okay, he's a software professional, allergic rhinitis. Now, complaints of loud snoring, sleepiness, BMI is 29, class 2 skeletal profile, he's a mouth breather, ESS 18. This is his oral cavity exam. This is, let me just pull this up. This is his sleep study. If you can. tell me when to stop so that I can stop where your interest lies.
Go ahead, sir. Breathing pattern is very, very important actually there. As
You
well
want me to
as
stop here?
as well as the change of the SPO to levels also during the sleep study is also very important. And snore analysis is AHA is very, very important in evaluating. The O2 saturation, that is very, very important where the, yes, sir.
Okay, so
Yeah.
let me just stop this and come back to that. Then I will ask you very relevant questions as to what will be your next. How will you counsel your patient regarding treatment, sir? Will you say, here it is, your AHI is high, just use the CPAP? How would you like to titrate and follow up your patients? Just one point.
I would like to first know is comorbidities, not only his body but like to know his comorbidities, and also like to have the idea of his sleep breathing and all this thing before.
I have given all that, sir.
We have to evaluate what interface is comfortable for the patient before we start CPAP activity, and whether it's natural interface or the full face mask, like that. And then after the evaluation, we have to start putting the pressure also CPAP between 4 and 9 hours.
I'll need 5 more minutes.
We used to have we can have a board, like a cancer board, to discuss multi-specialty opinions, and that comes to the conclusion that is the more appropriate treatment for that patient. This would maybe in future it will be there.
So here is a compliance report of a patient for whom we have done. So if you really look at, he's compliant, he's using quite well, his residual OSA is quite high, he's using it regularly. Look at his pressure, his leak is within normal limits, his pressure, 95th percentile is 17 centimeters of water pressure. How would you, this guy is come back to me and given the machine back, he said, I'm not able to wear it, sir. What is your next plan? Sir, maybe from a physician standpoint, what would you do?
Actually, we have to titrate the pressure. If not
It's been titrated and has
not
been
comfortable,
yeah.
we have to go for bi-level support also sometimes, because bi-level is also better tolerated in some other patients who are not having good relief with CPAP.
Sir, from anything else that you would like to further? Fine. Let's just go back to this. All right. This is a man with a BMI of about 32. And obviously, he's got very high AHI. He's got tonsils. Upper Osa, this is for you. Would you give him a CPAP directly, or do you want to clear off those obstructions and then give CPAP? Or what precautions will you take?
So coming to this particular patient, first I advise to lose weight and refer to endocrinologist. Any other issues are there to increase this weight. Then comes to the treat conservatively, if infection is there, treat some antibiotics. And the physical dimensions of the tongue is grade 4. Obviously it needs surgery, but take up a surgery and immediately may produce a lot of complication, this especially this obesity. So we prepare the patient and give a CPAP machine first. Do a sleep study and then sleep apnea, of some kind of weight loss, then we can plan for a surgery. Surgery is not an emergency.
So that's the point I think that needs to be conveyed. Sir, you again, from an anesthesia standpoint, what special precautions will you take for these patients? From these broad headings that I've given you, what the one that you started off with?
Yeah, so we have problems intra-op and post-op as well. So we have to be very careful, and sleep apnea.
But first, let's talk about intubation itself.
So usually they are associated with difficult airway management. So we have to have proper difficult airway management plan, and we try to avoid opiates and neuromuscular relaxing agents. If we can intubate without opiates and neuromuscular relaxing agents, that would be the best that we can do. And during recovery, that is during extubation, we take longer time. We want to make sure that the patient is fully awake before we extubate them. And we monitor them post-operatively, because if the patient falls asleep and obstructs his airway, snores, he's going to drop his saturations. So we may end up extubating the patient electively onto a positive pressure ventilation, non-invasive positive pressure ventilation either by PAP. And the place of care usually more than a routine ward, either high dependency unit or intensive care unit, so that we continuously monitor them for any sort of respiratory and sleep related problems like desaturations, airway obstructions, and further worsening.
So when you have your patient, it's all recovered and all that, your intubations are post-surgery, would you send them to HDU or ICU? What are the red flags that you look for?
Red flags, we start collecting the red flags from the preoperative assessment. If there is a polysomnography done, what are the AHI index, how risky the patient is, and if the patient was using some sort of positive pressure support at home, we ask them to bring the same machine and we use it in the hospital itself. And also we have to understand that the AHI index will be high for at least 6 months post anesthesia and post surgery. So we have to warn the patient that the intensity of these complications can be higher and he should be monitored continuously.
So I think for want of time, there are more cases that we could discuss, but for want of time, I think we'll invite Sir for his talk on OSA with ophthalmological considerations in OSA. So I think you are, he has to come and connect it to you. What we do was think,
And in India, 90% of glaucoma is undetected. So as the basic definition, glaucoma is raised intraocular pressure, but there are some conditions where the intraocular pressure is normal, but it has glaucoma by damaging the optic nerve and leads to the silent blindness, which is irreversible for the lifetime. So the sleep apnea is a cause for the glaucoma. The incidence ranges from 9% to 42% as per the American Academy of Sleep Medicine. The causes are multiple. This is hypoxia, oxidative stress, sleep inflammation, endothelial dysfunction, and mainly the vascular or mechanical factors. And here we have a case, a 64-year-old gentleman with normal tension glaucoma, and he's on treatment. In spite of the normal intraocular pressure and the best treatment, he's going to progress for 3 years. And every time is for the hemorrhage visit, we are able to notice a new disc hemorrhages and retinal nerve fiber defects, which are the indicators for the glaucoma progression in spite of the normal intraocular pressure. already with the treatment. But every time, because of these signs, we are adding a new medicine to control the glaucoma process further. And he has been sent to several consultations, all are turned to be normal. But on repeated insistence of his history, finally revealed the history of mild snoring. So after that, we have sent that patient to the sleep lab, and he was put on treatment for continuous positive airway pressure, and his glaucoma progression has stopped. We have followed this patient for 6 years, and the glaucoma is stable in spite of, and we slowly regressed and stopped the treatment of some of the glaucoma medications, but continuously maintain him on the sleep apnea treatment. And there are other studies. With the simple sleep apnea treatment, the glaucoma is being controlled for 9-10 years follow-up also. Thank you.
Thank you so much, sir, for your wonderful talk. Now I request Dr. S. Reddy Garu, Senior ENT Consultant.
With the permission of the chair, certain treatments they should be genetically or otherwise prone to structural changes in the throat. So kindly make a point to diagnose early. It starts early in the 40s. By the time we diagnose, most of them have irreversible damage, especially cardiovascular system.
Dr. S. Reddy.
Yeah. Oh, is it? We are from here.
Sir, we are touching, sir.
I'll tell.
It's an honor to welcome you for this CME program organized by Susruta Ent Clinic, Indian Society of Pathology, Visakhapatnam branch, North Coastal Andhra branch of AOI, AP State, and in association with Osa. As president of Osa, this is the second program we are organizing. March 23rd, we have organized one CME program with multi-specialty talks, which was to upgrade our colleagues' knowledge and those who are working in the peripheries and non-medical college people need to have refreshing their knowledge. For that purpose, we have designed this program. And for this program also, around more than 400 delegates have been registered. And I have invited my friends, international repute, both Dr. Kishore, and who is a son of Amcosians and grandson of Amcosians. It's a rare feat. And Dr. Madhusudan, who is a legend in ENT, I was given a national award in National Forum as a legend of in Bangalore conference. And my friends in ISO committee, Dr. Surya Prakash, Secretary and Treasurer Somasra Garu. And on the dais, we have a common friend of mine, Mrs. and myself, Anuradha Garu, retired IAS officer. And it's almost the teacher for all the people, those are in this audience, is Dr. Chittubandhu Garu, and who is a role model for the most of the practitioners. So look at his enthusiasm to learn, hear, and participate. It's very phenomenal. I think this type of personality should be handled purposely to encourage much more juniors to do a good job in the society. And other friends, that's Sriramurthy, now with the National Forum, President of Indian Society of Pathology. It's a great honor to be here, sir. You have to be here with us. And our APMC member and our classmate, Dr. Kurnar. Thank you very much, Kurnar.
Dr. Baparao, State Secretary, and Organizing Secretary, Dr. Sarojini, so, and their members. So the idea is conducting these programs to upgrade our knowledge. And today, on behalf of all the people, I thank the faculty who have taken a lot of strain to come here and spare their time, valuable time. Thank you.
When he came from Kakinada and take care of him from me, he has telephoned me. He told me one sentence, he is a workaholic. Work, work, work. He is a very workaholic, so please take care of him. From that day onwards, even first day onwards, he started doing work. The first lecture, I still remember, he gave in the SC Railway about vertigo. Still he talks about vertigo. So he is a workaholic. Today, he is in Vizag. Tomorrow he says in Baroda. I don't know how he manages. Please tell me your secret of your workaholic. So this is the association that Aparav says. So you must also see, I don't know how you get so much of energy to go. It's not only academics, it's also in the non-academic field. He is the treasurer of our CAB and he manages all the accounts very nicely. And he has got a very good relations with all the people in the Andhra University and everything. So now I thank Dr. Apparao and wish him the best of luck for his all the things. Thank you very much. God bless you.
With her is since my college days as a friend, and we are close, our families are also very close, and I had the opportunity to work under her when I was the DM and HO, and at that time she was the Commissioner of Family Welfare. And she is very dynamic and she used to take decisions, very quick decisions, and she used to support the team very well. And I thank you, madam, for the support you have given. So about the brief note of madam. She is a 1993 batch IAS officer who retired in 2018 as Principal Secretary to the Government of Andhra Pradesh after 31 years of distinguished service. And she has also worked as Commissioner of Endowments Commissioner, Commissioner of Women and Child Welfare, and Commissioner of Health and Family Welfare, our department also. She began her career with the Central Customs Service before joining the Andhra Pradesh State Civil Services in 1987. Over the years, she held several key positions, including the Collector of Anantapur District, Commissioner of Women and Child Welfare, Commissioner of Family Welfare, Commissioner of Endowments, as well as the Director of Census of Operations AP. She is known for her long and impactful tenures, Mrs. Anuradha, for her commitment to public service, particularly in tribal welfare development and social sectors. She currently resides in Visakhapatnam with her family. Thank you, ma'am, for blessing that.
On the dais, off the dais, let me remind you that today is a very auspicious day. Today is Nrsimha Jayanti and it's a National Technology Day. So rightly, and Mother's Day. How can I forget that? It's Mother's Day. So all these days put together, Dr. S.K. Apparao made an initiative to see that all of us meet and celebrate this in a different way. The National Technology Day, it is declared on May 11th. This day is declared as National Technology Day to highlight the importance of science and disseminate the knowledge to the youngsters and make them follow the principles of science and technology and then pass on to the next generations. And today, that is what the obstructive sleep apnea, this workshop is doing exactly and passing it on to the next generation. So your take-home message is that you should disseminate the knowledge the older people, the experienced doctors, pass on this message to the next generation. Now coming to Dr. S.K. Apparao and Sarojini. In fact, I find it very embarrassed to call them as Dr. S.K. Apparao and Dr. Sarojini. In fact, our association was 40 years old. We knew each other as youngsters, and especially Dr. S.K. Dr. Chitpantul garu has rightly said that he is full of activity. I knew him as a youngster, bubbling with activity, a sportsman on one side, and a quick repartee, full of humor, and very friendly. I think he has got lot of contacts, and you name anybody, he knew him. That is how, and a busy doctor. In fact, after 15-20 years, when my father told me that he visited SKE, and we call him SKE, he visited SKE, he said that it seems you know him and you never told me, and he is very, very social, very friendly. So my father doesn't certify so easily, and I felt very happy when I heard about him. Then I said, yes, I knew him very well. In fact, the society, it says that whatever you learn, a good guru, in fact, he searches his sishya and then he passes on the information. I think SKE has a guru in him because he takes everything as his social responsibility and he carries on. And just now I heard from Dr. Chitpantul garu and many of you that he is no doubt the right person as President AMCOSA, President ISO, and he is rightly transferring all the knowledge through all of you, assembling everybody, all the right persons on one forum, and then at one platform, and then trying to do a lot of service to the society. I really congratulate him and feel proud that I am associated with him all these days. And regarding the obstructive sleep apnea, when he asked me to be the guest or chief guest or whatever you call it, I felt conscious. I said, what is this? Why did you choose me? Because you are talking about a subject which is snoring. So do you think, I suspected that he, unknowingly, is suggesting that I also knew that you snore. So I was just joking with him and then telling him that why did you choose? He said, no, we want you to be there as a family. It's almost like a family get together. So I came with my family, in fact. But today I realize that there are not many things. I'm not a medical student, but I find that there are not many things not only the doctors but also the general public should know. And this information should pass on to the society that look here, you don't take it very light. I knew many of my friends and colleagues, as SK had rightly put it, that they refuse to travel overnight in trains because either they are embarrassed and conscious or they feel that the fellow passengers may complain about them. That is how they have this sleeping status. So I feel that this is high time all of you really help the society and then make this as a subject for discussion, and many more such workshops are required. And after a long time, in fact, I feel very happy to attend such workshops because as Commissioner on Health and Family Welfare, I knew Sarojini was my colleague and we have attended to many such workshops. But always the Health and Family Welfare wing concentrated on the primary health centers and also the basic IMR and MMR and this gynec side, but never on non-communicable diseases. In fact, many of the officers used to complain, why the NRHM then, now subsequently it had turned into NHM, did not give enough budget to these chronic or non-communicable diseases. At that time, in fact, stress and stroke, a few thyroid, very few subjects were used to be discussed, but definitely not obstructive sleep apnea. So I really, feel that I am enlightened that I attended this and then got a few information bits, which I think I will now try to learn more from people like you. And I feel that this is a very good opportunity to me to learn from you people, such experts here. Thank you very much. And I thank again Dr. Sarojini and SKE for giving me this opportunity. Thank you.
Thank you, ma'am.
Sir, here, the camera.
Dr. B. Sriramurthy.
Okay, sir.
Dr. N. Someshwara.
Sir, camera. Okay, sir.
Dr. MBSS Bapa.
Sir. Okay, sir. Take a camera. Okay, sir.
Dr. Jeevan Karim. Dr. C. Madhusudan Rao garu.
Recording code. Recording code. చేస్తాను recording code. Code. అలా సైడ్ కొంచెం బ్యాక్. ఓకే రైట్ సార్. రెడీ. వన్ మోర్. సార్. సార్ ఇక్కడ కెమెరా. సార్ పట్టుకోండి లేదా సార్ కెమెరా. ఓకే సార్.
I request our chief guest, Mrs. Anuradha Garu, to felicitate Dr.
Cutting. Recording. చాలా పట్టుకోండి సార్. కొంత దగ్గర పట్టుకోండి ఎలక్ట్రండి. మరి కొంచెం బ్యాక్.
I request the dignitaries on the dais to felicitate the guest of honor, Dr. Chitti Parikar.
Photo. సరేలే మేడం కెమెరా. వన్ ఓకే సార్. చల్లగా ఏం డౌన్ ఓకే అది ఇచ్చేయండి నేను రికార్డింగ్ చేసి సార్ కెమెరా ఓకే రెడీ సార్ రెడీ one more ఓకే సార్
Our guest of honor, Dr. T. Chittupanthulu sir, Samya Devi Ma, Principal, Andhra Medical College, Dr. Shivananda sir, Superintendent Vijay for their encouragement. Dr. K. Kumar sir, APMC Observer for his valuable guidance and continued support. Dr. N. Someshwara sir, Senior Most Senior Surgeon and Founder, Member, ISO Visakhapatnam Branch. Dr. S. Surya sir, Founder Secretary, ISO Visakhapatnam Branch for their vision and contribution. Dr. B. Sriramurthy sir, President National Body ISO. Dr. Jivan sir, President North Coast AIAP. Dr. MBSS Baparao sir, Secretary AIAP State Branch for the leadership support. Our guest faculty, Dr. Srinivas Kishore sir from Hyderabad, sir from Nandyal, Dr. S. K. Appara.
So coming to the cardiovascular disease and disease burden, sleep disturbances are associated with increased cardiovascular risk. So whenever we say cardiovascular risk, the 2 or 3 important factors which help in the prevention of the heart disease are exercise, regular exercise, and then no smoking, cessation of smoking, and the other important thing is having good sound sleep. A period of 7 hours of sleep is optimal for a good cardiovascular health. And the prevalence of the sleep disorders as a whole, which includes insomnia, hypersomnolence, restless leg syndrome, and sleep-related breathing disorders, etc., would be up to approximately 32%, and for sleep-related breathing disorders in the general population is approximately 7%. So all the sleep-related disorders are associated with the mental disorders which have hyperarousal as the underlying mechanism. The hyperarousal is a very important part of this obstructive sleep apnea syndrome, so we'll discuss it soon. So coming to the definition of the sleep apnea, although the previous speakers might have already discussed these. So cessation of airflow for greater than 10 seconds during sleep. It is of obstructive or central types. And then the hypopnea. It is not the complete cessation, but there is a reduction in the breathing flow during the 10 seconds of the sleep associated with desaturation, documented desaturation. Oxygen levels are dropped in 3% associated with arousal. And the other term, which is called as RERA, respiratory effort related arousal, which doesn't fit into hypopnea, but however it has also a compensatory increase in inspiratory effort. So coming to the spectrum of the sleep related breathing disorders. Sorry. A brief introduction, yeah. Coming to the spectrum of the sleep-related breathing disorders, it is of predominantly 3 types. They are classified into 3 types according to the INOSA guidelines. It is central sleep apnea, which is the mechanism is predominantly central, and then obstructive sleep apnea, which we are going to discuss today. And the other term is called sleep-related hyperventilation. So, what is obstructive sleep apnea? It is the absence of airflow in the upper respiratory tract when there is a respiratory effort. We are trying to have a respiration, but however there is no airflow, so which is caused predominantly to the obstruction. So, the difference from the central apnea is there is no respiratory effort at all. So, this is the basic difference between these 2 terms, and today the topic of discussion will be obviously obstructive sleep apnea. And it is defined as greater than 5 episodes per hour of obstructive respiratory efforts with sleep-related symptoms, or without sleep-related symptoms if it is greater than 15 episodes per hour. And the most important clinical findings which we already have discussed, the important findings would be some lack of sleep and excessive daytime sleepiness, and then morning headache, increased fatigue. Both are due to excessive excessive carbon dioxide levels which have been built up due to the apnea, and erectile dysfunction and mood changes, and some important nocturnal symptoms like nocturnal awakening, so sleep fragmentation, which we call it as nocturnal awakening, and then nocturia, and then dryness of the mouth. These are all some of the coronative symptoms which are associated with this condition. And it is also associated with multiple comorbid conditions like diabetes, hypertension, dyslipidemia, polycystic disease, chronic kidney disease, hypothyroidism. So overall, obstructive sleep apnea is a disease or a syndrome which is coexistent with multiple medical disorders. And then coming to the basic pathophysiology of the obstructive sleep apnea, so it is basically a mismatch between the dilatory mechanisms which keep the oropharynx open and the collapsible mechanisms which will close the airway during respiration. So this is basically a mismatch when the collapsing forces are more. The collapsing forces include a deep inspiration, right? So when there is excessive intrathoracic pressure which has been built up during respiration, along with the compounding factors like craniofacial abnormalities which have a narrow airspace, and a soft tissue accumulation in patients who have morbid obesity, and adenotonsillar hypertrophy in kids and children, and some fluid overload conditions like chronic kidney disease and heart failure, where there is excessive accumulation of the fluid around the neck and the pharynx. So these are the conditions which compound the excessive inspiratory effect and then result in the collapse of the airway. And then the balancing opposite force is predominantly by xenoglossus muscle, which keeps the tract open. So when there is a mismatch, there is a collapse of the airway, and this causes apnea and then followed by hypoxia. So this is the basic mechanism. And now, how does it affect cardiovascular system, and how does it have a systemic effect? So the systemic effects of obstructive sleep apnea predominantly stems from three important features. The main features are apnea resulting in hypoxia and then hypercapnia, and then this is compensated by arousal, which results in sympathetic stimulation, and then these excessive sympathetic stimulation causes endothelial dysfunction and inflammatory syndrome, inflammatory response. So these are the features which predominate over the period of sleep apnea causing the systemic effects. When coming to the heart, it can have some acute features based on the symptoms which I have already discussed. The acute features includes acute MI or NST, ACS or acute coronary syndrome. So all these can be the manifestations, and then subacute manifestations. And some of the manifestations occur over a period of days to weeks. And this is predominantly due to the change in electrophysiological properties of the cell membrane in the heart. So the figure here shows. So this is the action potential showing the early increase in the early depolarizations because of the membrane excitability, change in the membrane excitability. So all these results in in the change in the electrophysiological properties and result in arrhythmias. And then the chronic features. Chronic features includes cardiac remodeling, which includes the LV hypertrophy and predominantly fibrosis and the increase in the stiffness of the ventricle. So these are all the features which can occur due to the three major effects which we have already discussed. So in the next 4 or 5 slides, we discuss all the pathophysiology is predominantly due to these three important features, which includes apnea followed by hypoxia and then hypercapnia and then an arousal and then excessive sympathetic response, and then to compensate there would be a deep inspiration which creates an exaggerated negative pressure and then causes the collapse in the area. So these three features can explain most of the cardiovascular manifestations. So this is it. When there is hypoxia, you have endothelial dysfunction and oxidative stress that causes endothelial dysfunction, and which is a prothrombogenic state and can lead to exaggerated systemic inflammatory response syndrome. And then the hypoxic and hypercarbic pulmonary vasoconstriction can lead to pulmonary hypertension, and then excessive sympathetic activation can cause arrhythmias as well as a rise in blood pressure and then increase in heart rate. So basically the excessive sympathetic activation and then actions of the parasympathetic system. This is the basic mechanism going around. So the community-based studies here clearly show that obstructive sleep apnea is associated with increased cardiovascular morbidity and mortality. So both of the features, both morbidity and mortality is increased in obstructive sleep apnea. And then, now basically if you want to come to the disease spectrum of obstructive sleep apnea in terms of cardiovascular disease, so it is known to increase the risk of acute cardiovascular events like acute coronary syndrome, STI-AMA and NSTSCS. And then it can result in increased hypertension, it can cause both tachycardia as well as bradyarrhythmias, and it can cause sudden cardiac death, heart failure and pulmonary hypertension and thromboembolism. So it has got a, it in fact covers all the cardiovascular spectrum, it can cause everything. It is associated with everything. Right? So of which the more important or more common association would be hypertension. Hypertension is commonly associated with obstructive sleep apnea. So it is seen in approximately 50% of the patients, and the prevalence of OSA in patients with hypertension is 30%, it is vice versa. And predominantly the pathophysiology, which was already discussed, excessive renin-angiotensin system activation, sympathetic activation, and then vascular remodeling. So all these cause three important factors. So the non-dipping in the nocturnal blood pressure. Generally what we have is we have a quiescent sleep in the NREM phase, and that is the slow wave sleep, which is responsible for decreased sympathetic activity. That is a period of quiescence, cardiovascular quiescence, and that is altered by this obstructive sleep apnea. So the normal nocturnal dip in blood pressure would not be seen. So loss of the nocturnal dip in blood pressure followed by elevation in the daytime routine blood pressure, which we measure. And then it can also result in poorly controlled and resistant hypertension. As the graph already clearly shows, there is a dose dependent effect. So if you see the severe the OSA, you find these association with the uncontrolled blood pressure and the resistant hypertension. The percentages are more when the disease is more severe. So when we come to the arrhythmia part of obstructive sleep apnea, it is known to cause all types of arrhythmias, including atrial arrhythmias, atrial fibrillation, and then ventricular arrhythmias, and then bradycardia as well as tachycardia. Bradycardia include bradyarrhythmias and asystole, and the basic mechanism remains the same as we have already discussed. And obstructive sleep apnea, with its increased inspiratory effort, can cause increased preload in the right heart, and which opens the patent foramen ovale and causes paradoxical embolism and can cause stroke independent of atrial fibrillation as a mechanism. And then the most common arrhythmia which is associated with obstructive sleep apnea is atrial fibrillation. Although the other arrhythmias are also known, AF is more common. And then it also demonstrates a dose-dependent effect. Dose-dependent effect with obstructive sleep apnea. The more the duration, you have the more the incidence, and the more the severe obstructive apnea, sleep apnea, the cumulative frequency of AF also increases along with time as well as with the severity of the disease. And then coming to the common coronary artery disease, as we already have discussed, so all the acute coronary events like STEMI as well as NSTSCS can occur in obstructive sleep apnea, and then it is it predominantly affects the middle-aged men. So there is no much difference in the elderly in terms of event rate when patients have obstructive sleep apnea, but the middle-aged men are more affected. And then predominantly the events also occur in the early morning hours and during the REM sleep. And then heart failure, when we come to the aspect of heart failure, OSA is associated with again the whole spectrum of heart failure. It is present in patients with decreased LV function, normal ejection fraction, which is called as heart failure with preserved ejection fraction, and then acute decompensated heart failure. So whole spectrum of heart failure is associated with obstructive sleep apnea. Once again, the pathophysiology remains the same, excessive RV preload, and then pulmonary vasoconstriction due to hypoxia, and then hypercapnia increasing RV preload, and then increasing the afterload of the left ventricle. So all these and excessive sympathetic stimulation can cause recurrent heart failure admissions. All the pathophysiology, it's a cycle which can cause these symptoms. So this is the graph which shows here the whole spectrum of heart diseases, heart failure is covered by this obstructive sleep apnea. Again, once again, when the AHI apnea hypopnea severity index is greater than 15, which indicates severe hypopnea, the incidence is more. So once again, the more severe the disease, the more severe the manifestations. And two important syndromes deserves some discussion, which is obesity hypoventilation syndrome, where obstructive sleep apnea is a part of OHS, So OSA along with daytime hypercapnia, which is quantified as PCO2 greater than 45 millimeters of mercury, and combination of obesity. It is classified as obesity hyperventilation syndrome. The basic difference is persistent daytime hypercapnia along with obesity is noted in this OHS syndrome, which is not there in OSA. So OSA is predominantly hypoxia. Here there is a daytime hypercapnia also contributing to the along with the obesity contributing to the syndrome. So what is the difference? So it is more sinister than OSA. It has got increased cardiovascular burden, even more than obstructive sleep apnea. The other syndrome is the overlap syndrome. Overlap of OSA along with COPD called as overlap syndrome. Once again, it is associated with more morbidity and mortality than the independent disorders. So till now we have discussed the cardiovascular manifestations of OSA, but however even the cardiovascular disease spectrum, which we have already discussed, all these can have OSA also as a part of their disease. Up to it is present in approximately 30 to 50%. So it is vice versa. So both can coexist together. So and then when to suspect OSA in cardiovascular patients. So when to suspect OSA, when to have to screen for OSA. So when the patient has got resistant hypertension or poorly controlled hypertension, in spite of giving adequate blood pressure therapy, which includes a diuretic along with the two first-line antihypertensives, then we have to screen for OSA, obstructive sleep apnea, and then patients with pulmonary hypertension, and then patients who continue to have recurrent AF, atrial fibrillation, in spite of ablation or cardioversion. All these patients should be screened for OSA. And then when the symptoms are present, in some cardiovascular diseases like NIHA 3-4 heart failure, and then tachycardia syndrome, and patients who had a history of VT or stroke. When they have symptoms, then we have to go for a polysomnography or sleep study to see whether it is present or not. So now coming to the treatment options, how to deal with the cardiovascular aspect of the sleep apnea. Predominantly the cornerstone of the therapy is positive airway pressure, CPAP. So and then the treatment depends upon the severity, and severe OSA, irrespective of the symptoms, needs to be treated, and mild OSA should be treated along with the symptoms. And the cornerstone of the therapy, along with lifestyle modification, we have CPAP or positive airway pressure therapy. So the lifestyle modifications includes weight loss. So 20% approximately decrease in BMI can decrease in approximately 50% of apnea-hypopnea index. So it causes a significant reduction in the index, but however, in spite of the reduction, still patients can continue to have residual OSA, so it has to be monitored regularly. And then weight loss, of course, irrespective of obstructive sleep apnea, it has got multiple other cardiovascular benefits. And then sleep hygiene to behavioral changes. So behavioral changes in terms of sleep, so have good regular sleep of approximately 6 to 7 hours a day, and then avoid stimulants just before going to bedtime. So evening smoke or evening caffeine or theophylline coffee, etc. should be avoided. So these will result in good sound sleep without any interruption. And then the cornerstone of the therapy is positive airway therapy, CPAP, which is called as CPAP. So approximately up to 15 centimeters of pressure can be adjusted at home. And the most important success mode in applying CPAP is adherence. So we have to strictly adhere to approximately or a minimum of 5 to 6 hours a day would give a good result with CPAP. And these are the different types where the advent zero ventilation has been used in the advent heart failure trial, but generally speaking, either CPAP or a bilevel PAP can be used in patients with heart failure and cardiac diseases. So that is reasonable and good enough. So what are the cardiovascular consequences which we have discussed until now? Respond to CPAP. So almost every symptom respond to CPAP. For example, there would be a reduction of 7 to 8 millimeters of systolic blood pressure with CPAP, and then 5 millimeters of mercury in pulmonary hypertension. So that can also be reduced by applying a CPAP. And CPAP is the first line choice of therapy in both the syndromes, special syndromes which we have discussed, obesity hyperventilation syndrome as well as the overlap syndrome. And then in terms of heart failure, CPAP has got a specific role. Similar to digoxin, it can reduce the recurrent hospital admissions. Rather than altering the course of the disease, it helps in that way. And this is what it is showing the CPAP where it is beneficial. Yes, it can reduce the all-cause mortality and CV mortality, cardiovascular mortality. It has got a clear-cut benefit in preventing the stroke and cerebrovascular events and routine cardiovascular deaths. However, it has it didn't prove to be very much beneficial or in reduction of the acute events which we have already discussed. So the acute myocardial infarction would not have much benefit on by treating with CPAP. Right? The other parameters are significantly bound to improve. So as we have already discussed, the most important success story when we apply CPAP is adherence. So compliance is more important. So at least 4 to 5 hours a day should be applied to have a good result. And then just a brief word about these devices. So other than CPAP, what are the other modes of therapy we have? So mandibular advancement devices and oral devices can be used. And where does this exactly fit and what is the role of the advancement devices? When you have anatomical abnormality, when you have a narrow airway and orofacial abnormalities, I think they fit the best. And for patients who are non-adherent to CPAP or non-compliant, that can be tried. So this is the basic summary of the chart which shows how to treat the cardiovascular aspect of obstructive sleep apnea. Right? So the narrowed airway and the volume overload in heart failure and the chronic kidney disease can be treated with diuretics. And then when there is a pharyngeal muscle dysfunction, the other modalities which can be used to stimulate the hypoglossal nerve and some oropharyngeal exercises and some medications can be used. And then there is something called elevated loop gain phenomena where there is excess response in terms of apnea and hypoxia. You have deep compensatory inspiration and the compensatory response is always more than what is happening. So this is called, it creates a loop, and to break that loop we can use the carbonic anhydrase inhibitors like acetazolamide. Yes. So thank you.
Beautifully illustrating the serious complications of sleep apnea.
So patients survive when they have a history of sudden cardiac death. So this is called as post-CPR ROSC patients. Some patients will have, they will survive the sudden cardiac death even either by doing CPR laid outside or they leave the hospital. Sometimes they have syncope and by having some chest thrusts, chest pumpings, that is called, which we call CPR. Even though that is not adequate CPR, but still they will survive, they will come back. So these are the patients who have to be probably screened if they have symptoms of obstructive sleep apnea. So that is what is that was what was advised.
Thank you very much.
I would now like
I think time is 40 minutes. I'll keep up to the expectation of all of yours. The biggest problem to speak is after lunch. Post lunch, అప్పారావు గారు ఇచ్చిన మంచి మంచి ముక్కలు అటు కూరగాయలు ఏవైనా తిన్న తర్వాత నిద్రపోవాలనిపిస్తుంది. But I think the active panelists, all 6 panelists will not make you sleep. Okay? Connect to my laptop. అందరికీ శుభ మధ్యాహ్నం. జాతీయ సాంకేతిక దినోత్సవం, జాతీయ మాతృ దినోత్సవం, నరసింహస్వామి జయంతి and also Uraka దినోత్సవం. Whatever it may be, evening 4 days are there now. In these few words, OSA Snoring, how to explore this field by young and budding ENT surgeons. A few slides will run through very fast. This is my own trumpet has already been blown by the organizers. So Madhusudan Rao, younger brother of SKE, famously known as Super, very kind, empathetic personality SKE. So now, first a big salute, though ceasefire has been announced, Vyomika Singh and Sophia Qureshi. Not only the 4 days, this is a big day for us. These are all the moderators in front of you. I just want to advise all of you, answers should be small and cute. Some answers needs only yes or no. Okay, done. Let's give maximum to audience to take home messages, because it's not ENT surgeons here. The whole galaxy of medical specialties are sitting here. I am not here to teach you at all, first of all. I am here to advise you to explore this upcoming branch. Of course, you should know not only what to do, what not to do. ఏమి చెయ్యాలి అనే దానికంటే ఏమి చెయ్యకూడదు అనేది స్నోరింగ్లో తెలుసుకోవాలి. Whether I can do this, whether I cannot do this, especially the budding ENT surgeries. And Kumbhakarna, time immemorial, Mahabharatam, Dwapara Yugam, ఆయన లేపేదానికి గురక పెడుతూ నిద్రపోతున్న, I mean, snoring is there from ages together. Even now, this pillow may be reversed to this side, it's nothing wrong. But if both partners start snoring, who has to suffer? It's very difficult, children. And I'll skip this video because the physiological aspect ఉంటుంది. Unnecessary 2 minutes time. We breathe. Okay. And nowadays I'm telling you, films are misleading that snoring is untreatable. Both husband and wife are snoring or sleeping separately, and that is not treatable. You sleep, you do. I don't know. I have not seen this. My son has given these pictures. Dear, good night. Satya Prem ki Katha. They should write this Guraka Prem ki Katha. And now, anatomical levels of snoring. If you keep all these things in view, level 1, something in the nose. Level 2, open your mouth. What you see is level 2. Level 3, something below the tongue. Before going to the questions, level 1, I think all can do. Level 2, some can do. Level 3, very few can do. That's most important, like Srinivas Kishore, Vidyasagar, Shima Abhishek, Vikas Agarwal, and many stalwarts are there. With these few words, now we'll go to the questions. We'll start from there. I think there are no budding ENT surgeons. Here also, Deepu, I'll start from you.
They are full-blown surgeons.
They are full-blown surgeons. They are stalwarts, outstanding surgeons, whatever it may be.
Outstanding into?
Outstanding. No. Because don't stimulate me, SKU. Who are stalwarts, I'll tell you later. Deepu, what do you mean by budding ENT young surgeons in time or experience?
Postgraduates, after finishing post-graduation, maybe we can say 3 to 5 years where their skill, they're developing in all subfields of ENT. They are called as budding ENT surgeons, according to me. It takes minimum of 5 years to master basics in all 3. Of course, it's subjective, but still I feel that is the given time.
Among all of them, I should ask, what is a budding surgeon to a senior ENT surgeon? Baparao, what do you mean by my son is telling about 5 years after postgraduate training?
It depends upon the surgery, sir.
Yes.
So take it as a tonsillectomy.
Yes.
Then a second year postgraduate can be a budding ENT surgeon in that particular surgery.
Okay.
But overall, to master all surgeries like Deepu said,
5 years. Apparao is telling you, Mike. Yes.
So regarding surgery, sir, to that particular surgery, if you take a tonsillectomy or septoplasty or simple temnoplasty,
okay,
even postgraduates can be called as a budding ENT surgeon for that surgery. But when you take for oral surgeries, at least to a certain level, maybe we need some 3 to 5 years, as Deepu said.
Yes, wonderful. I think the take-home message is, immediately after MS in the present situation, you may not be able to do a septoplasty. But what I mean to touch, explore the snoring field, at least I think 2 to 10 years depending upon your grasping power. So up to 10 years we will take as a young ENT surgeon. Now the essence of today's topic is these budding ENT surgeons or young ENT surgeons, how to explore this big pandemic which is going to rule the whole world, how to make use and how to explore. This is my new topic I have taken. Snoring has become an epidemic. Snoring has become an epidemic and you will get snoring doctors only. I'm sorry, I don't deal with cholesterol. I only deal with snoring. Boards will be there outside. Dr. Shiva Subramaniam only deals snoring and he also snores in bracket. So now coming to this question, why it is so epidemic, Pradeep? Snoring has become so epidemic. That's why we are all having so many conferences.
Yes, sir. Snoring, rather than epidemic, sir, it's not like more than like an endemic.
Okay.
It's been already in the society. Basically, depending upon our lifestyle.
Yes. I just want that answer. Lifestyle. I may be cut short because there are so many slides I do not want to. So lifestyle and Jeevana Vidhanam Purtiga Marpi. Changing lifestyles, eating junk food, stress and obesity. I need not stress about all these things. Every generation is now. Biryani is directly proportional to snoring. I can say this formula, mathematical, technological formula. Now for that, 2 laws has come like Boyle's law and Pythagoras law, Zomato and Swiggy. Kunda biryani, Bungu biryani, Naidu biryani, Tata biryani. And night they will sleep and they will going on munching overnight. So good answer. So the lifestyle, I think this is making the whole cycle to make ENT surgeons to get more number of cases. So we should tax Swiggy and Zomato. And okay, lifestyle, exercise, not doing exercise. And this is the way, not 2 hands are busy with remotes. So he's sucking each chip with his inspiratory capability and chip are coming into his mouth, munching and again sleeping. This is how. Now snoring has made up a disease and syndrome, modern disease and syndrome. Now we are to explore the 6 fields among these. All the panelists will be given questions on this. So when the snoring patient, whether a pediatrician patient or a child or an adult, comes to your consultation room, how? After the consultation is over, you subject him for examination. What you have to do. Third is what investigations you will ask. Don't CBP, don't, everybody will get CBP, but investigations which are very important related to snoring, pinpoint. Counseling, everything is over, he has again come to your, you have to counsel. It's not like acute tonsillitis, give a painkiller, go back, come after 5 days, he will not come because you have reduced everything. Treatment. Counseling is over, treatment. Last is, I have written in red letters, the awareness. Why today this big gathering is here in Snoring Awareness. The whole awareness, not only the general public, even among our own medical fraternity, they are not aware of snoring. So with this, shall we go ahead? Ready? Yes, right? Right. So snoring will become bread and butter for all of us. It's a new faculty. How to proceed when the patient has come into the consultation? Satish? Ramesh. So I think already I will try to cover up all of you. How to proceed in a consultation room? What's the incidence of OSAs in your practice? Whether pediatrics, the questions are very specific. I don't want you to elaborate. How many patients do you see per month?
Because I work in a government setup also.
Yes.
It depends, sir. In a government setup, based on the awareness we create to our colleague branches.
Now, whatever it may be, suppose you will see 100 patients per day, that becomes 2,500 holidays. How many patients, pediatric or adult? I just want numerical value. We want to just show.
In 100 patients, with the complaint of snoring, usually they come 5 to 10.
Wonderful, 5 to 10. Babarao, answer is very specific. If your practice, suppose you see only 30 patients or whatever may be the volume. What is the volume I want numerical? People should know.
At least 20% of the patients will be having, but they may not come with the same complaint.
Yeah, they may come at the complaint, you will explore.
After evaluating, we will be knowing that he is also a snorer.
Madhumani, you will be representing Madhumani.
Both pediatric and adult, if you take both, 50%. Adult, maybe 10 to 20%.
Right, sir. Annapurna Rao.
Adults is usually 20%.
20%.
Pediatric is 50%.
50%. Pediatric, that's what I just wanted. Pradeep.
Pediatric cases more than 50%.
Super.
More than that.
And Rakesh.
Pediatrics almost have 90% people coming this way.
This is the answer. Just let's give us a first good clap that all the ENT surgeons in future, this will be dominated by females. SKG, I think we know, there was we are all judges in last week Sunday. There are 12 poster presentations, only one male there, 11 are females. ENT surgeons, only one boy. So after 2050 people will speak about there were olden days, there was a male ENT surgeon called SK Apparao in Visakhapatnam. So I just want to tell you good news for all your female ENT surgeons. 90%, 50% average I can say.
But here no one is there on the diet.
That's what I am telling you. I think you are male predominant. You are not selected a single female ENT surgeon to be as a panelist. But whatever it is the consensus, even my hospital we see almost 40 to 50% children come with Amma Jalubu, Pachamu, Tumulu, Mawadi, Muna, Sal pediatrician Jubichamu, Anni Bound. Babu Ratri, North is going to the Sar, North Rodemator, Sar, the system is Sar. That itself is a sign that the boy is snoring and suffering. So, almost your pediatric upper respiratory tract, your volume is going to rise in future. Okay? Now, he has come with the complaint. Now, again, I will start from there. Rakesh, tell me one or two brief pertaining to the OSA's history. What will you ask? Same question will come to 3 next.
Mouth breathing.
Yes, good. Mouth breathing. Do you use mouth breathing, your child or adult also?
And many of the patients often they are telling they are mouth breathing but not snoring.
Yes.
So what I ask is in adults about their dietary habits.
Yes.
Because in often what I have seen is because of reflux, GERD, the oropharyngeal airway is getting narrow.
So GERD also, okay, gastrointestinal people are not there today in the faculty. So we have included GE, right? So we will stop here. You already told 3 points. Pradeep and Annapurna, next question will come to this.
So one important question to ask is any hypothyroid issue?
So see, the answer is asking when the patient has come with the features, he's still Amma. ఎందుకంటే almost every 4th female is having hypothyroidism. You hypothyroid, wonderful.
Alcohol, sir.
Abba. The alcohol for ఆడవాళ్ళు కూడా అడుగుతున్నారు. అంటే హిస్టరీలో you are eliciting, madam, do you take alcohol? So he has told next Annapurna. You asked history, very important, hormonal imbalance like thyroid, not other hormones. And do you take alcohol? Alcohol is linked. Another 2 important Annapurna.
Lethargic or daytime sleepiness is there or not?
Too much sugar udara. Kuchutera officers or software systems are. It is a very major symptom. He is lethargic and sleeping and dozing away. Okay? All these things are very good, important history eliciting points. Rest of the things may be there, but we will, because of short. I am also ready, madam, that is time still. అది 12 నిమిషాలు కాదు, మీరు అది స్టార్ట్ అవడమే 25లో స్టార్ట్ అయింది. It's 40 minutes, so I have another 12 minutes time extra. Okay? Now, in your consultation, are you able to see as a child about 10 years and he's an adult? I'll disclose because he took the permission. Newly married 3 years back. Wife brought him. Whatever it may be, what's the difference between a pediatric OS patient and adult OS patient? In your consultation, what will you concentrate? Manideep, maybe with the 3.
So pediatric, because we had to ask whether mainly mouth breathing.
Yes.
And usually pediatric because of adenotonsillitis, any pooling of saliva. And adult we have to ask many history points. So depending upon the snoring, if the attender has got, is it disturbing them?
Yes.
And is the patient waking up?
That is easy getting up,
arousals. And any associated comorbidities,
right?
As Sir said.
So 3 points he has already told. I think all of you should be very attentive. This is a very important take-home messages we are getting to elicit from this experienced panel. Sir, Ramesh, he already told the this.
Yes, sir. So pediatric OSA is different from adult OSA.
Yes, 100%.
Pediatric patients, usually they may not give a history of a daytime somnolence. So we have to ask for the sleep pattern.
Yes.
Sleep pattern and abnormal postures of sleep.
Yes, abnormal postures of sleep. Your child.
Yeah.
But ఇట్లా బోలపడుకుంటాడు సార్, నాకు అమ్మ సార్ వీడు ఇట్లా ఇబ్బంది పడుతుంటాడు సార్, సైడ్ కన్నా పడుతుంటాడు, బోల పడుతుంటాడు. Because falling down reverse, he will get some relief. That child will make his airway open. Very good, Ramesh.
Abnormal postures, and then we have to elicit the school history. So
School
any
history.
performance, how is his performance?
How is his performance?
Any abnormal behavioral patterns in the school.
Abnormal,
all these
yes.
patterns will make up in the pediatric OSA. Adult is routine, any daytime somnolence.
Right. And it's already told.
Right. Lethargy, work performance.
Baba Rao sir, all have covered. Tell me something extra or we will switch over to the next question.
What is the common observation in my OPDs when we try to elicit a patient?
Okay.
So when I ask them, is he snoring? Is he keeping his mouth open while sleeping? The next moment, the attendant will be asking the patient, are you snoring? Are you keeping his mouth open? I say, he cannot say, you must observe and say.
Yes.
Immediately the patient says, no, I will never snore.
No.
So no snorer will agree that he will snore.
So no snorer will agree except his life partner. Yes.
So we should gather information from the attendant rather than from the patient.
Yes. So with this, in consultation room, these are very important. I will just add another point. Is your child is suffering from deafness? So they, Amma, we are thinking that that child is inattentive, but that fellow is not having hearing properly because glue ear. Adenoids, eustachian tubal block and this thing. Now, how important and most important data you can ask the patient or relative to when they come for next visit? You have done all history and everything, you had to plan, you had to come further. So, what important data you can ask when a patient relative to come? Deepu? You know the answer, okay.
So data, is it in the form of like test result or history?
Yeah, I mean, this question data, when they come, it gives a lot of information for the surgeon. That, what I call it as, you ask the patient, if your husband is snoring, or wife or your child, Amma raatri padukunnappudu, vaadu etla guruga pedtadu, mee husband etla pedtadu, bharya etla pedutundi, get a video. I'll just show you a small example. I'll just start with video.
Nowadays, before asking them.
Because sometimes it will be like a train going through a cave. And sometimes it will be road and metal road. And every wife will have her own experience of telling her husband's DJ. And now you will see a child how audio is traction. How the child froth in the mouth. Both they are sisters. She is 10 years and 9 years. 4 days back we operated both same day. Mother and father wants, so that easy for them to be in single room and they can take care of. Whatever a patient comes for snoring, we'll certainly ask them to bring a 1-minute video. This is a check. And Bhavyasri and Tejasri. And another video I will just show you. And this is the young married person. He is working in Ranchi, but a Telugu person related to from Max. I'll show you the post of video also. This is she's a 32 years old man, married 3 years back, wife or son. How long should I enjoy this DJ? Lifelong. Padukunna 5 నిమిషాలకి Kabalam, Mudangam, describe any type of instrument, okay? Now, what I would like to say, whenever you deal with an young ENT surgeon, when a patient comes for snoring, you just ask them next time, bring a 1-minute video. You will have a huge collection in your video library and we can mix it up. Okay? Now, we will proceed to examination. So, we have done a good consultation, history, and now we will go to exam. You have to examine the patient. So, examination, how to proceed? Examination, we will start from Babarao. Examination, only snoring, which is general examination, what you stress upon, which will give you good information on only snoring.
Sir, we have to look for static obstructions in the
So, I give you only 3 points. You should not say more than 3 points.
Yes, we see the nasal cavity, and oral cavity and oropharynx.
Yes, oral cavity, nasal cavity, right, oropharynx. And you will immediately come to know, you will examine the oral cavity, what you will see of the tongue, what would you say?
Huge tonsils,
yes.
very redundant and lax, lazy, soft palate.
Right.
Sometimes a big tongue.
Right. Ramesh, next in examination. Suicide oral, next.
We have to initially see the BMI also.
Yes, BMI, manam report we examine
and neck circumference, we can examine the neck and his build,
yes,
facial
yes,
normalities.
Yes, and bulky, neck circumference, then you subject him for some examination.
In a clinic setup, we can just do a VLS,
yes, video laryngoscopy or DNE.
DNE video laryngoscopy.
So both are the same, right. And in examination, we go to next question. Deepu?
So first, as you have shown in the picture, for all budding ENT surgeons, if obstructive sleep apnea is divided into 3 levels, so nose, throat and hypopharynx. So you have to examine in that order only. First thing always comes is DNE. Then as you can just put a tongue depressor and examine oral cavity, and hypopharynx, VLS.
See, diagnostic nasal endoscopy, whether you do a rigid, whether it is sitting position, Megnath is doing in sitting position, and we don't do in sitting position, we make them to lie down and pass and show that this thing, attendance will be there. You see there is some septal spur, whatever it may be. DNE is very important. And video laryngoscopy also, there are a lot of things. Morning, Kishore was stuck. There's a big cyst, and the person, I'll show you a video, I'll show you an American report. Yesterday we discussed, I'm going to show that Kishore. This is unacceptable unquoting. You have shown is a big cyst and you are writing CPAP machine. How can CPAP help you when it is a big epiglottic cyst is there? How can it help? So DNE is most important. Next in examination, Sir Annapurna Rao sir, what you would like to go for examination?
In children, sir?
Anything, children, adult, మీరు అందరినీ డీల్ చేస్తున్నారు. No pediatrics. Next is my pediatrics. Now you are dealing all history అయిపోయింది. Body examination, treatments, మల్లం పాటి, oral, tongue, stature, deep DNA చేయాలి, VLS. ఇంకా anything you can examine.
What is BMI?
Yes.
Neck?
Yes.
Neck circumference?
Yes. Neck circumference. Yes.
Any associated comorbidities?
Yes. Comorbidity. In examination, mainly you have the upper airway which is involved in snoring. So in upper airway, what is causing that free flow of air is not there. So that's what we have to search for. So we have this flexible fiber optic bronchoscope. I thank Baba Rao. Baba Rao is the person who made me to introduce some Haridwar person. We purchased I think some 90,000 rupees. So useful. Very useful. Actually, this is supposed to be disposable. But 9,000, it's a beautiful for all dyes and everything we do. And nice, even you can just pass uncooperative patients, someone nothing, you just feel this is not a digit. So, these things, and I consulted Sagar. He does a pediatric OPD DNA with 2.7 nasopharyngeal. Rigid, suddenly the child moves, it may injure and cause bleeding. A drop of blood of a small child, mother and father standing behind, will not tolerate. So, coming to the examination, mainly we have to subject to these tests. Okay, patient has been examined, wonderful history. I am going fast because time is very short. We will cover up to the treatment. Investigations. Investigations, so CBP, leukocyte count, karma. Investigations, look, we will start from Rakesh. What investigations which will really help radiologically?
CT of PNS.
CT PNS, super.
Then few people do dynamic MRI.
Dynamic MRI, yes.
Then these are two things. Then polysomnography.
My town is not having a CT scan, so naturally I will not have a dynamic MRI. So I have to subject that child for some radiological investigation.
X-ray.
Even a pediatrician, a physician, a pulmonary, anybody, a child is snoring. Simple X-ray lateral view. This will help radiologically. And Pradeep, anything you want to add? Radiological investigation useful for snoring. Right, MRI. Right. So a simple X-ray, which is hardly some 400 rupees, will give a very good information. Then naturally we can. But here we would like to stress upon the importance of this wonderful cube machine, CBCT, cone beam CT. The exposure of an X-ray sometimes is more than the radiation exposure than taking a CBCT, where you get hundreds of films in coronal, sagittal and axial planes. And we are proud, this is the first hospital, individual ENT hospital in Andhra Pradesh. Madhumani is having this CBCT in Andhra Pradesh. Really wonderful. I'll just go through. It's hardly a 30 seconds procedure. Even a small child, a 4 years old child can be subjected, and the film will come in 2 minutes. Data will be transferred to your office desk, and you can see the office desk and very low radiation. Very low radiation. So this is the advantages of a CBCT, bone beam CT, not only for PNS, it's wonderful for even a temporal bone, ossicular reconstruction, mandibles, dental surgeons are having wonderful. So this is how you get a data, coronal section. So and you can see what is happening in the coronal section. And now you can see even the axial. Whether if it is a glue ear, naturally you will get a haziness of this mastoid system. Middle ear is effusion is there. Eustachians will be hazy. And even in axial, you can show the patient. Amma, idi mukku. Any ENT surgeons. This is pipe pedavi, kindi pedavi, pipe pallu, gali ila potundi. Ikkada chudandi. Ikkada nunchi ikkadiki almost 75% to 80% is blocked. ఒక కాలువలో నీళ్లు పోతున్నాయి మీ ఇంట్లో డ్రైనేజ్ ఒక పెద్ద రాయి పడిపోయింది. హౌ కెన్ వాటర్ ఫ్లో? వాటర్ సడన్లీ మేక్స్ నాయిస్. సేమ్ థింగ్ విల్ హ్యాపెన్ టు యువర్ చైల్డ్. And this gives a wonderful picture. And not only this, CBCT will give you airway analysis in a same exposure. How much is space? How much volume should be there? 21.2 cubic centimeters of airway is there. And how much is anterior-posterior diameter? How much is RL, right to left diameter? All these things make you a budding ENT surgeon. Within a half an hour, the picture will be there. Suppose a snoring patient, see how much compromised airway, where the compromisation is coming, what is the volume built up? It should be about 25 cubic centimeters. Now it has come to 12 cubic centimeters. And what is happening to his anterior posterior? What is happening to his right and left? All these things, information, more than an X-ray, and this we are doing for 1500s in Nandyal, just for the sake of getting more amount of data. So with this, now next important investigations, I think radiological is over. Sir, you PSG and DICE Baparao. Any important things what you can say about PSG and DICE?
Polysomnography is very important investigation when we evaluate a patient of OSA.
Yes.
Especially, we can show the data to the patient and his attendants.
Yes.
So this is what is happening while he is sleeping. So the desaturations, the number of episodes, and sometimes even the ECG disturbances, the desaturation, it's going up to 60%, 50% like that. So it gives us, it makes things easy for us to explain to the patient. So we will know whether it is obstructive or central or it's a mixed. So there is the advantage of PSG.
Ramesh, can you put a word on DICE, the important investigation?
Next to PSG,
yes.
Next investigation is DICE. DICE is important because after knowing the patient is having the OSA and the severity also we know by the PSG, then to know the level of obstruction and the type of obstruction, we go for a DICE at all the levels. We have the board classification. We get to know the level of obstruction and the type of obstruction.
Deepu, can you add something? How, suppose, what is a sleep lab? How you can establish, or you can establish, how about PSG?
So polysomnography for evaluating snoring is very important, and all the lectures have been very detailed. So this is a simple level 3 sleep polysomnography test being shown. This can be done by any beginner in their hospital. I think beginners should start with level 3 because it's economical, and also it will give you the main important indices that you need to look for, the AHI and desaturation indexes. And DICE, of course, everybody should do, especially ENT surgeons who deal with the obstructive component of the OSA.
I would like to add, polysomnography is mandatory, sir.
Polysomnography is mandatory, 100%. And how much does it cost?
So ResMed, I think now they are charging 1.8 lakhs for the level 3.
It was higher level polysomnography is about
10 to 12 lakhs.
10 to 12 lakhs. Even if you, 10 to 12 lakhs is ultimate. 2 lakhs is ResMed. Even if we can't invest, there are many outsourcing agencies. They will come to your house. మీ ఇంటికి వస్తారు, మీ బెడ్రూమ్కి వస్తారు, మీ పక్కనే ఉండి మీకు అన్ని పెట్టి పొద్దున్నే వచ్చి మళ్ళీ తీసుకుపోతారు. 5,000, 6,000 ఆ ఊరిని బట్టి వాళ్ళు తీసుకుని. సో PSG is a must. You need not worry that I should invest PSG. So there are wonderful centers all over. నంద్యాలలోనే ఉన్నారు, ఇంటింటికి తిరుగుతుంటారు. మేము గురక పరీక్ష చేస్తాం, మేము గురక పరీక్ష చేస్తాం. కాబట్టి వైజాగ్ ఐ డోంట్ థింక్ ఎవ్రీ వీధిలో స్లీప్ ల్యాబ్స్ వచ్చేస్తాయి. No problem by going Friday and Saturday weekend weakness, and you go to the sleep lab, get your sleep study test and come back. This is how we do a DICE. I am doing slide that the instrument Baparao has given us, and very nice. You can just pass it, very simple. With a mobile, data can be transferred. Okay.
Just, I want to add on this point for beginners, as this is a cheap one. You need not buy the costly Olympus chip-on-tip flexible scopes.
What's the cost of chip-on-tip?
With the processor and everything, Olympus or Pentax 15 to 16 lakhs. So this is 80,000 and you can see it in your phone. It can be connected to phone. And we are also doing with this for the past 2 years. So that is why we have put this photo kits.
I am concentrating on a budding and young ENT surgeons who can explore this sleep syndrome, snoring syndrome. So I am showing you how best you can invest less and get also the information. Now,
because talk is regarding the young and budding surgeons.
Yeah.
Patients might not come to your OT twice.
Yes.
For DICE, you need to take the patient once, and for surgical, you need to take the patient second time.
Yes.
The best suggestion is to do the DICE just before you are operating.
Just do the DICE before operating.
That is, if you are operating for level 2 or level 3 surgery.
You have made the patient to accept for surgery.
Level 2 or level 3 surgery. It is a second stage surgery.
Okay.
See, level 1 knows we operate already.
Okay.
For level 2 or level 3, we do it in the second stage.
Okay.
So generally, I reserve the DICE for level 2 or level 3 surgeries in second stage.
What I come to know from your advice is, sir, DICE you plan before surgery. I will ask the opinion of Srinivas Kishore. Patient has come, you have to investigate DICE and you make them, you are not done DICE. What information is, you do DICE on the table, then immediately intubate and do the surgery. How can you know what I am going to operate?
So, it's
I
actually
was thinking that DICE we will show earlier in one stage. I will come to some circumvallate.
one correct answer.
Yes.
There are multiple factors. One, it depends.
Message to the elders.
So it depends on two main things. One, patient factors.
Yes.
If the patient comes to you and says, I'm a very busy person.
Yes, I am a very busy person.
I do not have the time.
Yes.
I have complete faith in you.
Yes.
Whatever your decision is final.
Wonderful.
Whatever DICE you are doing,
yes.
I won't understand that.
Oh.
Whatever you are doing, you will do it.
Yes.
That is one group of patients.
So that fellow will slip away to the next window.
So that is one set.
Yes.
The second set of patients is the Google Red who is already aware of everything.
Yes.
Said, I want to understand my problem.
Yes.
You explain it to me.
Yes.
I want to know what all you are doing, how you are putting sutures, whether you are using robot, are you using laser, are you using what?
Yes.
So I want to know.
Yes.
For that kind of a person, you can always club your level 1 procedure with DICE. Do a nasal procedure with DICE, then say this is what we have cleared. And then because a lot of times, sir, what happens is, because of the Starling resistor model, if you remember, once you do the nose, your dynamics change.
Yes.
Because you are negating the upper proximal obstruction, things will change. So that is also correct, but if somebody else is there, the single stage multi-level is also fine.
I think we have to target to the particular patient and see his mentality and we can plan.
Yes, like how we do all surgeries.
That's what the experience counts. Thank you, Kishu.
Okay. First, I will tell, if you don't change your lifestyle,
I'll tell them about pediatric patients next week.
Pediatric patients, I'll counsel them about, because we do only adenoids and tonsils, most of them are not.
Yes, majority.
I tell them as the child grows, the septal and other nasal components might come into play.
Yes.
So we should take care of those things and don't expect this as the only and the best solution.
Right. So what you adutar, Doctor, next good answer. Counseling. In the chinna pillavadu 5 years old, గురుక పెడతారు మీద ఆపరేషన్ చేయాలంటున్నారు మందులతో తగ్గదా ఈ ప్రశ్న నేను అడుగుతున్నాను మీరు how will you counsel them?
So probably like I'll explain them to what is the level of grade of the adenoid and grade of tonsil and how it impacts the airway, how it is closing the airway. Probably level grade 1 or grade 2 we will try with grade 2 of adenoid we can try with medication. Or grade 3 is a borderline thing. You can wait for some time with medication, then go for surgery. Grade 4, mandatory surgery. Does not respond for medication.
So you will naturally, we have to first give a lot of counseling patients ni. Itla pillalni నేను కౌన్సిల్ చేసినానికి జనరల్ గా what I would like to say is, I think awareness will go next about this. And counseling is in which what I would like to say, pediatric counseling, majority of the parents will ask, sir, my child will withstand surgery or not? How can you do surgery for a 4-year-old kid? The best way for counseling is giving reassurance and showing an operated patient. So best is giving suppose a patient
Actually, tell the parents, I advise this kind of surgery to so many patients, but
Yes.
all patients won't get operated. I have been following the patients who have undergone surgery and the patients who didn't undergo surgery. I can surely say that if your child gets operated, the comfortable life he or she leads, I know about it. So please believe in this thing and go ahead.
So Baba Rao is saying evidence proof will give you the best counseling. Make the recording of that patient. Sir.
So I just want to add, because I've been seeing it since so long. Counseling a patient is like a drama. It's like a theatre art. You have to go into their space and then explain it into their own words. It's not like the technical stuff will not give them a positive opinion, because especially surgeons. So counseling a patient is itself an art which have to be learned by observing a senior doctor who is more experienced. Thank you, sir.
Yatha pitaha tata putraha. I certainly accept dramatization is certainly necessary. That doesn't mean that you should make an unindicated patient to become an indicated. So don't do that thing, but indicated amma idi adi, that is just an art that needs a separate class for me. Now I will not, because treatment, I don't think all of you know what you do for tonsillectomy and miracle condition. What I would like is a fast, a mixed edema. All these things just take 150 TSH. Give him some thyroid hormones. After 15 days he will come, sir, my snoring has disappeared. So another most important thing, a miracle condition, bilateral abductor paralysis. Thin individuals have gurkha. That is somewhere vocal cords are just like curtains, they are moving. For that any amount of tonsillectomy, any amount of laryngoplasty will not help. A simple video laryngoscope will tell that don't do any surgery. First thing is you have to explain mixed edema, obesity, gastrical reduction, I think which is the same to deal pediatric snoring and all these things. Awareness. Last, I will take only 1 minute, madam. We will end this. Awareness. This AMCOSA building on 11th of May 2025, SKFR of Dr. Sarojini and Dr. Susruta is making aware of all the specialties. Our own pediatricians, we have to aware. Make a dinner meeting. Ramayanam Madhya Gurakayanam. We have a pamphlet at Madhumani Nursing Home. We will give them. Read this. We will give 10 minutes time. By the time you come from my DNA, we will give some questions. What is OSA? Sir, I don't know about OSA. They had the Gurakayanam in Madhumani Nursing Home. What are the myths about this thing? We will deal it later. No, myths gurinchi, I don't know. Everybody think that adenoids and tonsils are like Qureshi and Yomika Singh of defense forces of body. So if you remove these tonsils and adenoids, my whole body will collapse. They think that it's an army general manager. It's a big myth. Oka adenoids ichina matrana meeku emi kaadu itladi పెద్ద న్యూక్లియర్ వార్స్ మన బాడీలో ఇంకా చాలా ఉన్నాయి. చాలా మందికి చెప్పేస్తారు, అమ్మ అడినాయిడ్స్ డాక్టర్ ఊరికనే మీకు సర్జరీ అని చెప్తున్నాడు, అది తీసేస్తే మొత్తం నీ పోలీస్ వ్యవస్థ సర్వనాశనం అయిపోతుంది. సార్ మా పోలీస్ వ్యవస్థ అంతా కుప్పకూలిపోతుందంట, మా పోలీసులు ఇస్తారా మా అబ్బాయికి? దీస్ థింగ్స్ యూ హ్యావ్ టు డ్రామటైజ్. యూ హ్యావ్ టు టెల్ దెమ్ అండ్ ఐ గో ఫాస్ట్. Friendship with your successful patients. And last conclusions. I think this 6 panelists, I thank them. I thank Appa Rao. Conclusion and such obstructive sleep apnea for young and budding surgeons is going to be a boon. It's not that difficult. Even if you don't operate, you investigate him and come to a conclusion and ask your good friend to do surgery, or Level 1 tonsil adenoids, I think a good 5 years or 10 years old surgeon can do investigation, simple CT-PNS or CBCT and hormonal investigations and all the examination pakka and counseling and treatment aspect. I need not tell everything, and I think I have kept to the time. Thanks for giving me this opportunity of post-lunch session, and next will be followed by speaker Srinivas Kishore. After Srinivas Kishore, Malli Rendava Krishnuni Madriga Malli మీ ముందుకు వస్తా. అది ఇంకొద్దిగా టాపిక్ వేరే ఉంటుంది, బట్ అది కూడా స్నోరింగ్ గురించి కాసేపు నాకు విరామం ఇస్తే. థ్యాంక్ యూ వెరీ మచ్.
Thank you, Dr. Madhusudan.
Thank you.
For the nice panel discussion. Now,
Sir is an oncologist. We are nice to have you. Thank you, Pradeep, for sharing your valuable. Madidi.
He is the topmost sleep surgeon in the entire country, and Dr. Kishore. And present subject is OSA even after surgery, pediatric surgery like tonsil adenoid. Still patient is not well. That is his subject. I think this is more important for the pediatricians to diagnose and to recommend for surgery and other management. Dr. Kishore, stage is for you.
Good afternoon. What I'm going to talk about in the next 35 minutes is a condition which is sleep apnea. Till now we were talking about it in detail about its manifestations, its presentation and management in adults. Let's shift focus to kids. Now, all the pictures and videos have been consented for, and if you want to take any photos of patients, please don't do that. Everything else can be taken. I would like to start my talk with a tribute to the great CG, as he is very lovely called, Christian Guilleminot. He is the father of obstructive sleep apnea. He was a pediatric neurologist with interest in sleep. It is him who coined the term obstructive sleep apnea, hypopnea, RERA. Everything is coined by CG. So he unfortunately passed away. So he is from Stanford. So Stanford is considered the Makkah of sleep apnea even today. So I would like to draw your attention to this particular video. Can you reduce pay attention to how he is breathing, his facial grimace, his mouth. He stops breathing. He gets up, and the mother very affectionately puts him back to sleep. And this happens again and again and again. This is the value of home sleep studies, which are as sensitive as 60% in terms of positive predictive value. So for kids, getting a home sleep study gives you so much information in terms of one, what all did you make out? You made out that this patient has an open lip seal. Number two, you made out that the child has malocclusions. 3, we made out that the child is pausing to breathe. And 4, obviously, obviously as he wakes up, he goes back into sleep and the problem starts again. So these kind of short clips can give us a lot of information. If you look at this video again same thing. Here what do you see differently from the other child? Look at the position of the head. The kids with severe obstructions in the upper airway resulting in obstructive sleep apnea generally tend to extend their heads in order to make the airway open so that they can squeeze some air through it so that they can breathe. So again, you can see that there is apnea. There is no air going in. And there is apnea. And she turns and she sleeps again. Again, this video is worth millions because again you are getting a lot of information in terms of the impact that is having on the child. So if you take this and bring it to what is happening in terms of school children in India, 9.6% of school-going kids in India have poor academic performance, and it has been shown that these kids have sleep apnea. 9.6% in our population is not an ordinary number. And if you take kids with Down syndrome, genetic problems like Cruzon, like obesity, craniofacial problems, these are problems which manifest because of multi-levels of obstruction. And lot of these kids also will have lot of residual sleep apnea. So what is the gold standard in the management of pediatric OSA? What is the gold standard? Come on guys, let's have some activity. Yeah, the person there who just spoke on the phone, you, who's sipping water. What is the gold standard of management of pediatric sleep apnea? Adenotonsillectomy, right? You have to say something, otherwise I won't leave you and the lecture won't proceed. Okay. So, adenotonsillectomy is the gold standard for management of pediatric OSA. Like how CPAP is gold standard for adult OSA, in pediatric OSA, adenotonsillectomy is the gold standard. Says who? Not us. It's AASM, it's AAP, AAO, HNS. Means American Academy of Sleep Medicine, American Association of Pediatrics, and American Academy of Otolaryngology and Head and Neck Surgery. So, what do we do? What such nice juicy tonsils, we get now good tools nowadays. So, once we clear off the obstruction, you get good space. So you can see hardly there is any space there. And once you do the procedure, you created so much space. Similarly, adenoidectomy, tonsillectomy nowadays will give very good results. The newer wand, which is the halo wand, it's come with a nice spoon which will make you scoop. Now why I am showing all this is because no matter what kind of tool you use, sometimes there is significant amount of residue. So if you take the data of all these procedures that you have done for sleep apnea, that is adenotonsillectomies in pediatric age group, and you put all the success together, it can be anywhere between 27 to 80%. That means, how can there be so much variation in what we are now calling as gold standard? So there is something there that we are really missing, right? This is a child. Adenotonsillectomy done 6 months ago, and the mother comes with this horrific video. So, we have done the gold standard therapy, and this is the video. This is a teenager. Look at the increased effort of breathing. Look at that mouth breathing. And the child is clearly suffering. There is no doubt about that. And this is the sleep study. 34 RDI, 5.6. Can anybody tell me, is this a cure or is this not? Is this good control of disease or no? Guys, come on, let's make it a little interesting. Yes? No? Anidhi? No. Why no? Because the metric of measure for pediatric sleep apnea to be diagnosed, to be having positive for OSA is 1, not 5. Right? So 5.6 is not good. This is another child. Pre-op 17.7, post-op 11.6. Is he cured? No. So here we are offering gold standard therapy to our patient, endorsed by all the greatest organizations in the world. We are not getting results. So there are a bunch of patients out there post adenotonsillectomy, rolling around, floating around with these symptoms of persistent OSA, going from pillar to post. What should we do? So what are we missing? Now, what can you look at this child? Look at the posture of the child. Most of these kids, the moment they come into your chamber and they are sitting and slouching like this, right? It means that the posture has changed. That means these kids are not able to breathe properly because of bad posture. Why did the bad posture come in the first place? Food for thought. Why? Look at the way the child is holding the head. Now remember how that other kid was breathing like this? Now will the adenoids regress completely when the person is awake? No, right? So, if there is a huge adenoid behind your nose, in order to breathe, what should you do? You should extend your head, correct? So if you extend your head and you start walking like this, how are you going to see what's there in front? So what do the kids do? They change their head, they protract it. So what happens? There is increase in space. So that becomes a habit, and that when the child is sitting or doing anything, watching TV, that is the best time to observe them. How is their body demeanor? How are they sitting? How are they breathing? Look at the body language. Look at this other child. What is this called? This is called as lack of lip seal. Also, these kids, when they are speaking to you, you can see little bit spit coming out. Okay? That means there is no lot of lip seal is gone because of persistent mouth breathing. All these muscles have become very weak, and then obviously there will be a lot of spit that keeps coming out. Now if there is a lip seal and that is lost, it's like drinking juice with a straw which has a hole. Will the juice come into the mouth if you have a hole in the mouth? It won't. So you will continue to mouth breathe. If you continue to mouth breathe because of that, when you open your mouth, what is the regular position of the tongue? Where should it be? High up in the palate, correct? Now let's, all of you put the tongue high up in the palate. Please do that for me. Have you put the tongue high up in the palate? Now breathe. Can you breathe? You can't. So if you are an obligate breather and you can't breathe through the nose and you have to breathe only with the mouth, when the tongue in its original position that it should be, can you breathe? You can't. So what do? You lower the tongue, and that is called lower tongue posture. So once that happens, the tongue is lying low in the upper airway. When the tongue is lying low in the upper airway, it has no other option but to fall back into the upper airway. Why? Because of loss of coupling. What is coupling? So when your tongue is in its natural position, there should be a vacuum that is created between your tongue and the hard palate. And this vacuum holds the tongue looking for high-arched palate, looking for lack of lip seal and malocclusions are very important. Look at this boy. What is striking here? Look at his jaw. This is a result of persistent mouth breathing, dear colleagues. How should the jaw be? Straight. How is the jaw? It is going to the south pole. The jaw is like this. So what kind of facial profile is this? A concave facial profile. So if you do the gold standard therapy, after all these changes have happened, will the child be better? No. Now, what is this? This is TRMR, tongue tie. There are two basic grading systems, the Kotlow and the TRMR. Okay? Based on Kotlow's classification, what we were worried before was speaking and breastfeeding. That's all we were worried about. But that's not the case anymore. TRMR is tongue restricted mobility of the tongue, restricted tongue mobility. So, what you should do is ask your patient to open the mouth and then put the tongue in the inner part of the incisors and open the mouth. Now, if there is a tongue tie, the child will not be able to touch the inner part. And based on how much is obstructed, you will call it from grade 1 to grade 4. And of course, if you do adenotonsillectomies on kids like this, do you know the percentage of success in obese children? Only 50%. That means, if you were to do a procedure to take care of a child with obesity and obstructive sleep apnea, please do not promise the parent that the child is going to get relieved of all the problems, because the success rate is as much as 50%. Why? Because fat competes with vital organs for oxygen. And where is the fat? Fat is predominantly abdominal and parapharyngeal. So what happens when there is fat accumulation in the parapharyngeal space? Your airway, which is elliptical, gets squished and becomes, the airway which is circular becomes elliptical. Which is difficult to collapse? A circular airway or an elliptical airway? A circular airway is difficult to collapse. An elliptical airway can collapse very easily. Right? So when you have a child like this, you obviously cannot promise an 80% success rate. So if you take all the causes from all the data out there and I made a chart, but what are the causes of obstruction post-adenotonsillectomy? Why is there a problem? So if you look at all the publications, look where the highest scores are. So there are problems everywhere, like 57% in nasopharynx. That means probably the adenoids regrew. But what is staggering is one, epiglottis 72% and nasal cavity 70%. Now wait a minute, nasal cavity 70%? Now why is there a problem in the nasal cavity? You've cleared the adenoids and tonsils, but the problem is that it is when you clear it that is important. After the child develops a high-arched palate, even after, if you clear off the adenoid, or if the child has a gross septal deviation, if you clear the adenoid, if there is persistent big huge concha bullosa on both sides, will clearing the adenoid alone be enough? Especially if the child develops a high-arched palate. Why is it important? Because the roof of the mouth is the floor of the nose. So if the roof of the mouth goes up, the airway becomes narrow. The piriform aperture becomes small. So it's like you are thirsty, I give you a glass of juice, but I give you a thin straw. How much will you suck? So in these patients, if you just do an adenoidectomy, can we give a good result? No. As ENT surgeons, we need to think outside the box. And what is the box? the skull. So we need to come out to be a little more extra luminal and look at the entire profile before we do something. So this is again another child, 45 pre-op, 4.9 post-op. So unlike in adults, where after your gold standard therapy, you've done some amazing work, didn't work, for 5 years it worked, after that you can give a CPAP. Can you give a CPAP for the child? And sir wanted to speak that, he forgot about his own nephew who actually he will speak in the next lecture. Also, there is a lot of data that shows that if you give a CPAP for whatever reason, the pressure of the CPAP will cause permanent craniofacial problems for the child if you keep putting the mask like that. Now, in some kids, suppose they have some kind of a metabolic problem, you don't have an option. That's a different subject. So let's go back to basics before we go and explain what all we have missed. So so how important is snoring? Like everybody says, sir, some days they snore, some days. So what is important? If the child is snoring more than 3 nights in a week with a normal PSG of less than 1, textbook wise, that is the definition. So when you ask the parent, it's important that we ask, how many days in the night is your child snoring? Similarly, if you decide to do a sleep study, and I will tell you when to do, mild OSA is more than 1, moderate is 5 to 10, and severe is more than 10. There is a role for questionnaires. Why? And all of us in the private practice, who of us, I mean just now they were all saying 80%, 90%, all these parents do not come out with the truth when they come to, because they're already scared that we may say it is surgery. So they withhold information. And you also don't have the time to ask all the relevant questions. So what do? We turn to the questionnaires. See here, you have a comprehensive analysis of what is happening to the child who is sitting in front of you. The parent also feels a little bit, they get involved and say, okay, maybe this doctor is also very interested in me, they're asking me all these questions. So this adds a lot of value in terms of your engagement with the parent as well. But if you are somebody who would want to do a sleep study, what are the guidelines? The guidelines are here. Okay, if there is anything that you could take back today, it is this. Routine preoperative sleep monitoring on basis of surgical decision making is not recommended in children without comorbidities less than 2 years of age. You are not obliged to do a sleep study. However, if your child is less than 2 years of age, probably it will be a good idea to do a sleep study. Number 1. Number 2, if you have a child with comorbidities, like for example, there is a seizure disorder for the child. The child is in some valproate or something like that. And then you have to do a sleep study. When the child is 5-6 years of age, then do a sleep study as well. Because we are not looking at a child who is independent of other problems. They may have a seizure during it. So if you do any kind of a simple test, it won't work. You need to do a level 1 PSG. However, what about situations wherein you want to quantify how bad the child is? You can get away with a simple pulse oximetry also. So what are the indications for using pulse oximetry? Number 1, if you have a child whose tonsils and adenoids are not too big, but the parent is giving history that the child is snoring, having nocturnal enuresis, having restless sleep, but on examination you found that your tonsils and grade 2 tonsils, grade 2 adenoids. That means there is a gap between the signs and symptoms. So either the parent is not giving the right information, or their interpretation is not correct, or your examination is not right. So in such situations, pulse oximetry will help you. So how do you use your regular pulse oximetry? You can use 4% reductions. The same metric that we use to calculate ODI, you can use it. So if the average baseline is say 98 for a said child who is sitting in front of you, based on how many times the oxygen saturation comes down from 98 to 94, if the child's oxygen saturation is come down more than 4 times in 1 hour of sleep, it is considered positive. Otherwise, no. But this is in a regular, healthy, normal child, not a syndromic child. So if you look at kids like this, do they all look normal to you? Guys, come on. Normal and abnormal. Say just one word. Come on. Something. Normal? Why do you think that? What is wrong with this boy?
Fatty abdomens.
Chubby and fatty abdomen.
Yes, he's got Prader-Willi. Okay? You know what is Prader-Willi? Huh? Prader-Willi syndrome. It's a growth hormone issue. We'll talk about that later. What about little warrior beam? What about this boy? And what about that boy? They are all syndromic with some problem or the other. So just because they don't look craniofacially challenged doesn't mean they have normal problem. They will have something or the other. It is up to us to evaluate. Okay? Just by the looks of it, don't go. Did you not observe a small tracheostomy tube there? So we had to do that because the child had severe tracheomalacia. And this. Look at the skull. Who can tell me what this syndrome is? Dolichocephalic facial profile. And lateral to lateral. This is Crouzons. And what is this? Is this snoring or stridor? Right? Correct, right? So if you have a child for whom you have to do an adenotonsillectomy and then they have large tonsils and adenoids and you don't have a video like this, if you do an adenotonsillectomy on that child and if this is the story, so always ask for home videos. You should be able to differentiate a snoring from a stridor to a stutter. It's very important. So, for residual patients post adenotonsillectomy, the problem is pretty significant. There are cardiovascular problems, there is hypertension, there is cor pulmonale, ventricular remodeling, neurocognitive problems, behavioral problems, nocturnal secondary enuresis, and somatic growth retardation. Why somatic growth retardation? Because growth hormone gets released in REM sleep. So if you don't have a good sleep architecture, your body thinks that you don't need growth hormone. So if your growth hormone is not getting released, you would obviously have a stunted growth. And there is data that says that there is cortical atrophy in the brain. With every apnea and hypopnea, your kids who are sitting in front of you, for whom you are responsible, will have cerebral cortical atrophy. That is just too much of a price to pay for our inadequacy to understand what the problem is. And needless to say, what happens to the craniofacial problems. What would start off as a sleep problem becomes an awake, disordered breathing problem. Continuously breathing becomes a issue. So, my big question to all you people here, when should pediatric septoplasty be performed? This is being published in 2018 laryngoscope. Sir, what is the age at which you will touch the septum in pediatric age group? Then I'll ask this sir also.
If it's really obstructing and this thing without causing growth, we can still make the airway compatible with the limited septal invasion.
Perfect. Sir, yes, sir.
Yeah,
with all the experience.
It's a general dictum that we have talked about doing a septoplasty after 17 years of age. But there may be instances when the child is really struggling for breathing and a lot of, then you can consider
exactly
the conservative
septoplasty. So the take-home message is, don't go with the fixed mind that pediatric septum should not be touched. The thing is, do not touch the growth centers. And this is best practice. If laryngoscope says best practice guideline, this is published. Pediatric septoplasty may be safely performed without significantly affecting future nasal facial growth. In fact, if you do not touch it, there is persistent problems causing more problems in craniofacial anatomy, further causing deterioration to the patient. Sir?
I have done septoplasty for a patient from Dubai because the parents were worried he is not able to breathe at all. There are no tonsil segments were not there. I have done it 5 years of age. I have done it 8 years, 10 years, 12 years. But don't touch the bone work minimal.
The growth centers. So, can you predict a potential failure in a child who is sitting in front of you? Because some people with experience you can pick up, okay, this guy is not going to do well. So how do you know? In a regularly looking normal child, you can actually do what is called as a highly sensitive CRP. So not only cardiologists use highly sensitive CRP, we also can use highly sensitive CRP to measure what is called as oxidative stress, the release of free radicals, right? So if there is oxidative stress, hypoxic burden, then there will be release of free radicals, which the body feels as it is inflammation, and it causes hsCRP to go up. And there are other things that you can do other than, so there is something called as insulin-like growth factor, interleukin 10, all of these can be used as biomarkers to look for residual OSA post-adenotonsillectomy.
Do you do the same CRP for all regulars?
hsCRP. Yes.
Any studies?
Yes, lots. We have also done a study of about 60 patients, which we are going to publish also. So, what are the factors that can bring your success down? Syndromic, craniofacial, obesity, persistent allergy. Please remember that. If you have a child phenotype which is like this, please be cautious of delivering 100% results. There is nothing like guarantee, like how sir asked me this morning. And very severe sleep apnea, that means if the PSG is very, very high, that means that cannot be explained just by the presence of adenotonsils. Please be very careful. That means there is some kind of a issue. For example, there is a Down's patient in front of you. They may have adenoids and tonsils problem. Will you get good result with doing adenotonsil in a Down's patient? Yes or no? No. Why? There are two problems with Downs. One, the skull base is very flat, right? The angle is very flat. Number two, muscle tone. How can you change muscle tone with adenotonsillectomy? You can't. So like how sir was saying, persistent OSA is a challenge, especially if you are the first operating surgeon, and the mother is back with you with the same video showing problems. Now the problem is you are not only dealing with the patient as in adult, you are dealing with the child, the parents and their respective parents. Minimum 6 to 8 people enter into your room when there is a problem like this. So to evaluate these patients and take the next step is going to be a challenge, but we have to own up. So can we try conservative management? Weight loss? Yes. All our kids, you please cut down on gluten, please cut down on processed foods, your success rate will magically increase. What about Montelukast? But please remember that when you are using Montelukast, there is a black box warning that is given by the US FDA. If you are using for more than 3 months, what is the black box warning? The black box warning says that if you use Montelukast for more than 3 months in a child having pre-existing behavioral issues, then the problems become worse in the form of suicidal thoughts and homicidal tendencies. And this has been proven, and that is why in Montelukast there is a black box warning for. However, adenoids have receptors for leukotrienes or histamines? Only leukotrienes. There is no role for histamine use to treat adenoids. So you have to use Montelukast and INCS. So 2 years and less you can use mometasone. From 3 years onwards you can use fluticasone furoate, and from 6 years on you can use fluticasone propionate. But is there any how can you treat adenotonsillar hypertrophy with nasal sprays alone? What is the mainstay of allergy management? It is intranasal corticosteroid. But is adenotonsillar hypertrophy because of because of allergies? No. There is a thought process there. So if your pediatrician is prescribing nasal sprays, if there is an allergic component, it will work. Because all tissues have steroid receptors. So as long as you give the nasal sprays, if the adenoid grading is more than 3, 3A, 3B and 4, most probably it won't reduce. CPAP already we spoke about. And the most important thing is biofunctional re-education, because can any procedure be done without physiotherapy? Nothing. So our physiotherapy is myofunctional exercises. We have to do myofunctional. I'll take 1 minute more. So what is the way forward? The way forward is to do sleep studies in these kids to know how much there is an obstruction. Flexible laryngopharyngoscopy and DICE. So I will quickly go to, this is dynamic MR. This is pediatric DICE. So this is how you do DICE in kids. It is a little bit intense. You will have to so how in adults you use dexmedetomidine and propofol. In kids you have to use SIBO and ketamine. And the International Pediatric Society has given, the IPSCS has given the scale how you are. This is how you have to score a pediatric DICE. It's completely different from adults. So when you do pediatric DICE, what is more important is, like in adults you stop at the level of the epiglottis. But in kids, you have to go through the cords to see if there is coexistent tracheomalacia as well. So this is how you have to look at, sometimes there may be residual lingual tonsil hypertrophy which could be cause for your failure. And one of the commonest causes for, in addition to epiglottis and nose, if there is allergic rhinitis or reflux disease, is lingual tonsillar hypertrophy, wherein your end result has to be to completely expose the valvula. So there is another fact that you need to remember. There is something called a sleep-dependent laryngomalacia. That means in stage 3 sleep, for the child, the laryngomalacia sets in. The rest of the time, the child is fine. Okay? So please be wary of that particular thing. If the child's parent comes, then only during a particular time of the sleep the child is snoring or having stutter or having stridor. The rest of the time the child is fine. Please remember state-dependent laryngomalacia. So, of course, if there is an obstruction at the level of the supraglottis, even if it's an infant, you will have to do some kind of a procedure, a supraglottoplasty, based on the Olson's classification of which type of laryngomalacia it is. So in these cases, you can see pre-op, post-op AHI significantly goes down. And please remember a persistent occlusal block. Look at the amount of high arched palate. The roof of the mouth is the floor of the nose. Remember that. And if you look at malocclusions, like I said before, prevalence of malocclusion in kids, what I said was adult 60%. When it comes to kids, it is 89.9%. So in kids, there is persistent nasal obstruction. Please do send them for a dental expansion. It's called rapid maxillary expansion. This is how it looks, pre-treatment and post-treatment. So this is the algorithm. Syndromic, non-syndromic, syndromic, see if there is high risk, low risk. If it's high risk, do a DICE, multi-level surgery. Low risk, consider conservative treatment, then plan for surgery. If it's a syndromic child, right away do a PSG, divide whether it is a skeletal procedure or to buy time you can do a tracheostomy or you can also do a PAP therapy. So dear colleagues, adenotonsillectomy successfully treats sleep-related breathing disorders in majority. However, there are a set of pediatric patients that will continue to have OSA after adenotonsillectomy. So DICE can help identify the anatomical causes for residual obstructive sleep apnea and guide additional surgical therapy in a child who obviously cannot tolerate a CPAP. And thank you very much for your patient listening.
Thank you so much, sir, for your informative talk. Now we request Dr. Ent Garu to present a memento to be ready there. Senior ENT Consultant Visakhapatnam, Dr. M.D. Apparao Garu, Senior ENT Surgeon Visakhapatnam, to come on to the dais.
I don't think so. Anyway, to highlight some of his achievements, he is the president of AOI Andhra Pradesh, past president and past president of South Zone AOI, and he is the president of ISO for year 2014 to 2016, and there are plenty of achievements in his life, like the President's Medal for during his student period, and he was awarded another President Robert Medal by Honorable President of India, and he was the best outgoing sports person of Andhra Medical College. Even though I also belong to Andhra Medical College, I know very well Dr. S.K. Apparao. He was my junior. First thing, I never knew that he was the best outgoing sports person. He was an excellent hockey player. Apart from all these things, he never relaxes. He is always on the academic front. So we really appreciate and congratulate his dedication to the profession. And I ask Dr. Kishore, my colleague,
during our graduation days, I am also from Andhra Medical College. Relentless efforts, continuing efforts to organize this kind of programs to help the youngsters to grow and to learn the things and to update themselves. Really appreciate them a lot for their great achievements in this field.
It's a wonderful two-day event where the world famous surgeon oncologist Dr. Vijayendra Garu, along with his son Dr. Vinay Vijayendra and Dr. Sangeeta, they are coming, and the organizers are making full arrangements. They have got a wonderful list of surgeries. So please make use of this two-day event. Thank you.
I do some exercise now. What will happen? My PCO2 will increase. Then what is the regulation? Auto-regulation is the chemoreceptors will take role to control that increased PCO2 level to reduce. That's how it will increase the respiratory rate. We increase our respiratory rate will increase. Again, once it is settled, the CO2 is washed out. It will settle. As most of the ENT surgeons experienced in those days, there was no pulse oximeter. The fellow who comes with stridor for long period, long duration. The PCO2 is so raised. Suddenly you open the trachea, what will happen? The patient will go into apnea. Because sudden washout of CO2 also produces a problem. So that's how auto-regulation mechanism is there. That's how the OSA, how this OSA will produce problems. So this is the central connections. Now the running triggers the respiratory rate and wash out the CO2. But whereas in sleep, what happened to the higher center? No behavior, no, it's not happening. Already brain is in dull. Brain is not that active to regulate it. So what are the leftovers in chemoreceptors? The CO2 will increase if there is obstruction. If there is no obstruction, normal airflow, nothing will happen during sleep also. So why the OSA occurs? If the nose is completely blocked, what will happen? We will try to breathe with the mouth. Okay. One day I eat ice cream or a cold drink, sometimes stuffed nose will have snoring for the summer. For 2 days it will suffer. It will clear with medicines. But if it is a permanent block, if it is a deviation, hypertrophy turbinates, the nasal air passages are most occluded. There is no alternate passage, it's only mouth breathing. Okay. But with age, as age progresses, the muscles in the pharynx, in the hypopharynx, or lower part of the air passes. The upper airway consists of nose, turbinates, sinuses, and the nasopharynx, and the tongue, and the he has to respire much air. That means it creates much negative pressure in the thorax. That pulls the air and the collapse of the hypopharynx and pharyngeal areas. That then it will stuck at the maximum level, it will block the air flow. That is apnea. So this is snoring, but this is apnea. So if you ask the person, they will explain, sir, మధ్య అసలు అది గాలి పీల్చు మాకు భయం వేసేస్తుందండి అది గాలి పీల్చారండి సడన్గా అలా అంటారండి దట్స్ కాల్డ్ అనౌన్సర్. సపోజ్ పర్సన్ గెట్స్ దిస్ అటాక్స్, ఫ్రీక్వెంట్ attacks, suppose 100 attacks. 100 means one attack minimum is 10 seconds. 100 into 10 is 1000 by 60. How many minutes? Suppose it is more than 100. 300 attacks. That means 3,000 seconds by 60. 50 minutes of his during sleep period is not breathing. That means the struggle for the brain tissues, especially for 60 minutes during 7 hours recording or 5 hours recording, so much. So that is the main basic phenomena takes place, this obstructive sleep apnea. All these diseases, all these morbidities, all these complications are because of the low oxygen levels. As mentioned in the previous talk, patients, they may live with 70% oxygen also. They live. But sudden loss of oxygen levels, sudden decrease in oxygen levels, patient can, because these are the smokers, clubbing, pulmonary problem, they live, they are walking. But when you look at the pulse oximeter, you'll be surprised and you'll be panic also. Patients have 78% SpO2, but patient is comfortable. He's already adapted. But here, it's not true. Because daytime is of 98, during sleep or sometimes 90. But if it is severe OSA condition, the persistent breathing breaks, produces apneic spells, and one more thing is hypoapnea. It's not complete apnea, it's hypoapnea. That means the ventilation has come down to 30% reduction. I mean, that is also sufficient. We can live without food for days, but we cannot live without oxygen for minutes. So, that is the basic pathophysiology of the OSA. So, name any condition, take obstetrics. You remember, you recollect, lateral position is better in pregnant lady. What is that? That means that reduces this OSA problem for a pregnant lady. As the gestation increases, the first trimester there will be a mild OSA, next increase OSA. As the weight increases, the OSA levels will increase. Okay, we label pregnancy-induced hypertension. Most of the time, but after delivery, what will happen? It may subside. Maybe the reason pathology is OSA. Pregnancy-induced diabetes, maybe that. Not only affects the mother, it affects the child. So look at this. This is nothing but a straw, already mentioned. You got to drink coconut water, take a straw, which is very thin. If you want to force it against resistance, then what will happen? It will collapse. That is what is happening in the OSA and the pharynx. So, 1997, I have come across one patient. I operated his wife, the cholesterol. The next visits, they came. Now, she has complained, she was telling about this story. Sir, my husband has chala problem undi, ilaga train journeys running water. I told, and those days there is no much monitoring level, the studies levels. We know something about it in the literature, not much of the knowledge. That I told them. So I do tracheostomy first. Even now, suppose one patient is 180 kgs or 160 kgs, the first option I tell is tracheostomy. To save his life. Then comes the morbidity. Even now, it's not the gold standard. CPAP, I don't agree with CPAP is the protector. Maybe that's not. If it's compliance and it is beneficial, okay, CPAP. But the ultimate goal is to save the patient is not the only CPAP. He is the only tracheostomy. So that principle I applied. I have done the tracheostomy. Then I did the nose job of the blockage of the nose and parallel surgery tonsils. And after 14 days, we removed the tracheostomy. Patient is healthy. The one more example I will tell you. In Australia, what happens is, for all driving license, they have to go for a sleep study. If the sleep study shows, say, abnormality is there, the patient is sleeping, they won't regularize the registration of the driving license. The day will come, it will become a notifiable disease in all countries. Because 100 crores of population in the world are having OSC, not 1 or 2 crores. Out of 750 crores of population, 100 crores population are having OSC problem. And that is leading to all the increased hypertension, increased diabetes and all. More, any condition it is linked with hypoxia. So, then one more example I will tell you. In Saudi, one farmer is working in pharma industry. He got a notice from the road transport authorities. Because when he was at the signal, he slept on the, just slept on the steering. Then what happens is, he got a notice. You are not supposed to drive. And he is working in a good machinery, big machinery, and lot of issues. Suppose he sleeps in that area, what will happen? Safety of the, not only that fellow, the other society. So, he came, he is a son-in-law of one of the friend, the port sports officer. He came to me and said, I lost my job almost. What is the reason? So, this is the reason. Then we did the surgery, the OSA has improved, now perfectly level, now we got back to job. So, we as ANT surgeons, as a doctors, we have to take this particular point into the notice of our health authorities and transport authorities to make a note of it. Why not? Why not we make, suppose we take a railway driver, there are a lot of hearing tests we do. Very strict hearing tests will be done for a railway driver. Why not have all drivers should undergo this sleep study to evaluate whether it is fit to drive or not. So this is what I want to convey this. Next, coming to there's a lot of, already the subjects are covered. The abstract to central and mixed. Central is because anything related to like air, blood flow problem, microvascular lethality, or infarcts, or congestive heart failure. All this can produce central causes. Mixed up. So next, so this is what my friends already have shown a lot of videos and. The one more point is I'll tell you. In child, where the tonsils are not there, pediatric neonates, before 2 years, the tonsils are not the major role for snoring. Otherwise, what is it then? It is the only adrenal tissue. The bulk of the adrenal tissue can produce, but they won't snore. They won't produce noise, but their thoracoabdominal movement is different. That is a different way of obstructive phenomena, low oxygen levels. But if it is 3rd year to 7 years, adding snoring, so tonsil also adds weight. Then, so even the child also like corneal atresia, patient will have voice like adenoid tissue. So before 2 years also it don't ignore. So consider that, and if necessary treat with medical line of treatment. Maximum you can do with the medical line of treatment. The membrane can do the answer for that. Yeah, coming to the epidemiology. See, recent studies shows that 32% of the Indians, out of 148 crores of our population, imagine how many. That means, so around 50 crores of population having OSC. So that 50 crores, out of 50 crores of population, most of the people are hypertension. Most of them are diabetes. Why the prevalence is increasing in India? Why not OSA? So think OSA and you will get the answer for most of the diseases. Somebody says, "Arey, Machipotra and try Bhajana." because the hypoxic state of the brain. And cognitive function is diminished. So these are not defined studies may not be there, but I can pursue it also. But these are the science. Science is nothing but a common sense. Today's science is tomorrow's blunder. What we believe today, as per the circumstances, what are the evidence given? So, as of now, the OSA is throwing the light. Knowing about OSA is you will become more mature about your medical knowledge. It will solve most of the problems. The fellow comes with sir, drink tag and sir, morning at heavy the hangover. Maybe it is because of the OSA. It is not the alcoholic effect. So that's the reason 6 hours prior to sleep, if you drink it, there won't be hangover. Why so? That means there is no OSA before it is 6 hours. So these are the simple points which gives you insight about the disease, not only from the books, not only from the lectures from outside. If you observe the patient, you will get the insight of the disease. Globally, it's almost 1 million. Yeah, risk factors. As already mentioned, obesity, male gender. How obesity of the neck or neck thickness will play a role in OSA. Maybe you feel that I am a hero, I am having a big neck and strong. It's not the strength. It is the fat deposit which produces the pressure of the laxed muscles, not normal muscles. Normal muscles will not get healed from this fat weight. The laxed muscles, because that stage REM sleep. REM sleep is for OSA patient is a dangerous sleep. It's not a safe sleep. Almost the machide, kani disease machide. But younger generation will get more REM sleep. But their muscles are tonic, tone is good, they don't get OSA. But if you take an old fellow who got dreams, he may suffer with the OSA. So, even dreams are also a problem. The older age group, family history, Asians are more common because our mandible is not that problem. If you take Africans, the mandible will be like this. Europeans, the mandible will be slightly anterior to the maxillary scale, like Kishore. Look at him, he is like a European. So,
South Indian.
Sir?
I'm 100% South Indian.
Maybe you are South Indian, but your structure. Okay. Next, anatomy, heterogeneity. As you mentioned, as he has quietly mentioned, so many conditions we miss. We only blame the whatever we see is the adenoids and the tonsils and take out the tonsils and adenoid filtration. But they help. While after removing it, they help you. But it's not the only answer for that particular patient. Large adenoid, enlarged tonsils and the neck circumferences, narrow upper way, and supine position. So, usually a patient changes the position during the sleep. When they get snoring, at least the bathtub will slap and it will change into the other position. So this is what will happen. There are a lot of simple measures are there. They put a tennis ball back and they play and they can't sleep on like this. They sleep on. They are bound to sleep on lateral side. A lot of measures are there which are the CPAP patient. Diagnostic examination we already explained. These two forms are given to you. Please note down and you can post your score in the group or anybody has filled this forms, they are all busy with the talks. This is about policy and a lot of already this is discussed. The diets already discussed by Kishore. The capillary, simple X-ray will give a lot of information. Since we are having the digital X-ray, we get simple information. X-ray, this is the This is a tongue area. See, this is a nasopharynx and the retroglossal and retroglossal spaces. But this is, the patient is alert. We don't come across this passes during sleep. So treatment is first and best and the most important is exercise. And weight reducing by medicines and retrognathia answer is the mandibular adjustment treatments and CPAP is the surgical management for the nasal cavity like septal deviation, turbinate, hypertrophy, polyposis. But Kishore, one more point. The patient comes with a lot of polyps. How many patients are around OSA?
So that's why I brought that topic this morning about CT scans. It goes based on Lund-Mackay scale. The higher the Lund-Mackay scale, the higher the chance of OSA. Again, because two things. One, the nose is the preferred way to breathe. If the nose is blocked, two things happen. One, you have to open the mouth. Because of opening the mouth, the tongue will become unstable, fall back. Two, because of oral breathing, there is dryness. Dryness increases surface tension. Surface tension will cause the mucosa to get stuck. That will also further cause problems. So that is why it's very important to treat the nose.
So Diagnostic is the mainstay of treatment in younger individuals. And uvuloparietal pharyngoplasty is taking over the uvula and the parietal. So BMI plays major role. Tongue-based reduction. So this is simple, just quoting what is the things we can do, the total dimensions we can change in these simple procedures which increase the airflow. Yeah, so this one. So if you take AHA means apnea, hypopnea, put together for 1 hour. If it is high score with static obstruction, the success rate is very high. I was insisting the same point. If it is a mechanical block, the success high rate. But if it is a airway collapse, the success rate will be less. Unless you answer that. Next, low score. 1 minute. So it's the latest. Suppose the patient is not fit to get operated by airway, nasal passages, morbid. This is the safest mechanism. So what happens, already Kishore mentioned about the genioglasses action. The genioglasses plays a major role in holding the tongue and retroparietal space maintenance. It is by the genioglasses. Suppose if I am breathing, my tongue is falling back, no respiratory movement. The chest will give there is a pacemaker like thing. It will be there, it will alert and pass a signal to the signal to the muscle. The muscle will contract. The airway will open and breathe. So auto-regulation of respiratory passes opening by the hypoglossal nerve stimulator. Okay. What is the cost of Kishore? What is it?
30,000 euro.
Euros. Disease has not approved in India?
There are Nexoa, there is another device from Belgium. That we make it.
So this is about the latest treatment. Those are morbid, those we cannot open. Some restrictions to manipulate other procedures is the best option. So, what is the sequelae? Hypertension, depression, diabetes, quality of life, cognitive disorders, arrhythmias, stroke, memory loss, and in children, growth, irritability, parasomnias, cardiovascular, reduced quality of life, hearing loss. Hearing loss, very important. Very, very important. Patient comes with usually, he'll stare look. Patient looks at our eyes. He'll search what, and if I put a mask, it will be very difficult to follow my conversation, my questioning. So then we will know the patient is having hearing loss, moderate hearing loss. And they're all reversible with the treatment of pregnancy. I have mentioned about it. So, IUGR low birth weight is there. Maybe the back is for the OSA of the mother. Thank you so much for the presentation.
Sir, one question.
Now, even women, there is equal prevalence of obstructive sleep apnea. But it's just that the AHI, that is the metric of measure, is not the same. So what happens is, even though the impact is more, since we are only using AHI as a metric of measure, a lot of women get slip between the fingers and we don't get them. But post-menopause, that means after estrogen leaves the body, obviously the muscle tone goes down and hence the prevalence is same in men and women.
That is so you cannot mention it under the risk factors.
It is, so that is why in stop bank questionnaires and all these questionnaires, but if you look at the prevalence, even in India today, male and women, in men and women, men as measured by AHI have higher AHI than women. So male is a risk factor.
Thank you very much.
To give this lecture in front of everyone. So, we play like according to the sleep medicine, there are various specialties which are involved in treating obstructive sleep apnea. Among those, you can see that there are like we have some role of organ manipulations or enzyme have some role in treating this particular organ obstructive sleep apnea. So generally, what is the role of dentists and maxillofacial surgeons? You see that we treat with various types of dentofacial deformities, ranging from skeletal deformities or the craniofacial deformities. Like, for example, the skeletal jaw deformities. We all know that there are 3 types of deformities, that is class 1, class 2 and class 3 deformities. So among these 3 deformities, you see that class 2 skeletal deformity, these are the patients who are more prone for obstructive sleep apnea, mainly because the mandible is retrographic or because it could be because of the high arched palate where it restricts the space for the nasal area also. So these are the 2 conditions which require like some more prone for obstructive sleep apnea. So the second condition should be the class 2 skeletal deformity in which the patient has prognathic mandible, which is good, but these patients have retrographic mandible. So we can see that there is some restriction of airway space retrocarietally. So that could be the reason why these patients may have this obstructive sleep apnea as they grow older. And other conditions where we generally treat these patients are like what we call it as ENT disorders. Most of these patients like what we call it as TMJ ankylosis patients, these patients are more prone for obstructive sleep apnea, mainly because this mandible is completely retrographic in these patients and these patients suffer a lot because of this particular retrographism. So you can see this particular bilateral retrographism in patients of what we call it as TMJ ankylosis. So these patients will have definitely these obstructive sleep apnea problems. So other craniofacial deformities where the people are more prone for this obstructive sleep apnea could be either cleft lip and palate patients or patients with like what we call it as like these syndromes, either the Down syndrome or because of Piper syndrome or unifacial microsomia. These people can have mainly because these people like cleft lip and palate patients, we already know that these patients are already completely nasal deformities there. And other important thing is these patients undergo the palatal surgeries and all. Even after undergoing palatal surgeries, what happens is the cleft lip palate closure, the palate undergoes fibrosis, so it leads to velopharyngeal incompetency. So these patients are more prone for obstructive sleep apnea because of velopharyngeal incompetency. And the other thing is these patients will also have this maxillary hypoplasia, so that also leads to decreased retroparietal space. So next thing is like some of the patients like craniosynostosis patients or syndromic patients. These patients generally have, because of craniosynostosis, these patients will be suffering from decreased growth of the maxilla and mandible, and they'll be having macroglossia and glossoptosis. So these children, when they're born in infancy stage only, they'll be suffering from these particular difficulty in breathing and all. So most of the time, these children will be kept on these tracheostomy tubes and all. To wean from these tracheostomy tubes, generally we start doing this distraction osteogenesis in early childhood also. So you can see this is a syndromic patient where the airway space is completely decreased either because of retrognathis or maxillary hypoplasia. So these patients will be suffering since the infancy. So these patients can be treated by means of distraction osteogenesis. So we can see the various methods of doing this distraction osteogenesis. The mandible is brought forward almost about 15 to 16 mm in these patients. And this is another symptom like Piri-Robin sequence where the patient will have retrognatism, and these patients will also have this particular obstructive sleep apnea syndrome. So next, what are the treatment modalities of OSA? To divide the treatment modalities of OSA, there will be surgical modalities and non-surgical modalities. So let me talk a little bit about these non-surgical modalities which we commonly do. So the non-surgical modalities, most commonly the dentist or maxillofacial surgeons does the maxillofacial advancement devices. So this is like, this can be used in patients who are non-compliant to this particular CPAP therapy. As they have been telling till now that many patients are non-compliant to this particular CPAP therapy. Those patients who are not compliant to the CPAP therapy, we can use this mandibular advancement devices, where it pulls the mandible forward. When the mandible is being pulled forward, what happens is definitely the tongue is also pulled forward so that the patient will have little bit difficulty, less difficulty in the airway breathing and all. So what are the most common oral appliances which are available in the market are, one is tongue stabilizing devices, the second one is mandibular advancement devices. So these can be used in patients who are not compliant to this CPAP therapy. So these are the tongue stabilizing devices. These are again two types. One is titratable, other one is non-titratable ones. Titratable ones are commercially available, and these can be made like customized also. So these tongue stabilizing devices are mainly indicated in patients who are like edentulous patients or who are having this poor periodontal status or who are having this TMJ problems, or a patient can't protrude its tongue forward or macroglossia patients. These are the indications of tongue stabilizing devices. So next important appliance what we give for the patients with obstructive sleep apnea is mandibular advancement devices. So we can see in this particular slide, so whenever the patient wears this mandibular advancement devices, the tongue is being pulled forward. And when the tongue is being pulled forward, we can see that the hyoid bone is also pulled forward so that the entire airway space gets opened up. So what are the indications of mandibular advancement devices? Those patients who are having snoring, if the patient is having snoring, this is the best thing we can give for this patient. Or those patients who are non-compliant to this particular CPAP therapy, or we can give in combination with CPAP therapy, we can give this mandibular advancement devices. So in the market there are lots of mandibular advancement devices being marketed. So how can we classify these? These are classified into monoblock and dual block. Either it can be single piece or a dual piece, or they can be fabricated or prefabricated or customized. Most commonly, compared to both of them, it's always better to give dual block appliance or customized appliance. So these customized appliances can be titratable. What I mean to titration means is nothing but the patient can advance the mandible to how much limit he is comfortable and all. So that is known as titration. You can advance 1 mm or 2 mm or 3 mm, whatever it is. So these are the customized appliances are more titratable. So these are the titratable and non-titratable devices, and based on the type of material also they are classified. They are made up of like acrylic material or plastic or nylon materials. So among these, nylon materials are less weight and they are more compliant for the patient. So have this, like we dentists, for snoring devices, what we give is a silencer, which are marketed by dental care labs. So it comes with the coupling devices like the plastic plastic connectors. So these connectors, what they do is they pull the mandible forward so that the patient gets comfortable with the snoring. He doesn't have the snoring problems now. So these are various connectors which we can titrate based on how much the mandible has to be advanced and all. So other company which is being marketed in India is about DreamVent. So this is also very good device for sleep apnea as well as snoring devices. So what are the methods of titration? How can we know this, whether this, how much amount of titration has to be done, how much amount of mandible has to be brought is by means of, one is polysomnogram titration or radiological titration. We need to see on radiograph how much of mandibular airway space is being opened, or subjective titration. Subjective titration is nothing but the patient knows how much the mandible has to be brought forward by adjusting those coupling mechanisms. So these are the various coupling elastics which are given, which increases in size. So as the size decreases, for example, the 19 mm means the patient can protrude the mandible less, but the size decreases, the patient can move his jaw, lower jaw more forward. So generally when a patient comes for this mandibular advancement device, what we do is, generally we do intraoral scanning, or taken impressions and send this intraoral scan directly to the lab. So in the lab they prepare these mandibular advancement devices, and we see in the patients how much they can try. We in the clinic we see the patient, how much the patient can advance and all these things. So these are the mandibular advancement devices. So these are the equipment what we need, bite case, other one is the intraoral scanner and the impression materials. So generally we ask the patient to protrude the mandible at least 50 to 60% of his normal protrusion. In this protrusion we take the bite of this particular patient and we send the lab so that the patient, these appliances will be given for these patients. So these are the various appliances. So what are the long-term side effects? Because these patients, mandibular appliance devices, these patients will be wearing for a very long duration. So they'll be wearing almost from 5 years or 6 years or 10 years and all. So these can happen, like there can be retroclination or proclination of the mandibular incisors and maxillary incisors. So there can be several side effects of the occlusion and all. So these things can be minimized. Many of the companies, when are they giving this mandibular advancement devices, they also give this bite strips. So we ask, once they remove in the morning, ask the patient to bite this bite strip at least for 10 minutes, so that his occlusion gets, like the muscles and will all get relaxed and it goes in normal position. So what are the surgical options of OSA? So we, the maxillofacial surgeons, we do some of the surgical procedures for relieving this particular obstructive sleep apnea. So there are various procedures based on the level of obstruction. Either it could be the nasal cavity, nasopharynx, velopharynx, or oropharynx. So most common procedures what we do are the rapid maxillary expansion procedures or mandibular advancement procedure and genioglossus advancement procedures. These are the procedures which we do regularly in our routine practices also. So these are the various procedures. As I said, one is rapid maxillary expansion, second one is the genioglossus advancement procedure, and third one is the maxillomandibular advancement procedures. So rapid maxillary expansion is a procedure where we expand. For example, many of these patients of class 2 patients have narrow maxilla, high aspiralis. So in these patients, what happens is mainly the nasal airway space also decreases, and there will be increase of airway resistance and all will be increasing. So the main mechanism how this rapid maxillary expansion works is we expand the maxilla so that the space of the nasal airway also increases. Okay, so it depends upon the age of the patient. In children we can use a simple hyraxiflex, but in adults, as there is maxilla doesn't split up, so we need to do surgically. That is known as surgically assisted rapid frontal expansions, or what we call as mini implant assisted rapid maxillary expansions, or what we call it as dome distraction osteogenesis maxillary expansions. So in the children, we can simply do this tooth bone appliances, hyrax appliances. We need to rotate this turn so that it expands, maxilla expands, so the nasal airway space also expands. But in adult patients, the maxilla doesn't expand, so we need to do the maxillectomy. That we need to do Burford osteotomies. In these patients, that means we need to separate the maxilla from the skull, and we need to do what we call the skeletal parental cuts, segmental cuts also has to be done, so that we can do then we apply this appliances and slowly the maxilla can be expanded. So this is known as rapid maxillary expansion. So either we can use the Hyrax appliances, that is in case of Sarpe, or in case of mini implant assisted appliances or dome appliances, we use this where we fix these screws directly into the maxilla and we expand the maxilla. That is known as dome appliances. So next important surgical procedure which helps in OSA treatment is genioglossus advancement. So this is the genioplasties routinely we do for our patients who are having this cosmetic where the genium is retrognathic or prognathic. So genioglossus advancement, genioglossus, let us see the anatomy of the genium muscle. Genioglossus muscle, it attaches to the genioid tubercles. Genial tubercles in posterior to the anterior area, and it expands in a fan shape and attaches to most of the tongue part, and it attaches to the lower part of the hyoid bone also. So generally, whenever we pull this genioglossus muscle anteriorly, what is happening is we are opening up the airway space. So this is how it works. By pulling the genioglossus muscle anteriorly, what we are trying to do is we are opening up the airway space in the posterior to the tongue. So generally, whenever we are doing these procedures, we need to see the CT scans. Exactly, we need to look at exactly what is the position of genial tubercles and what is the height from the upper tooth and the lower tooth. So all these things should be considered. And if you are not sure about these particular conditions, we can go for virtual surgical planning also. So in the virtual surgical planning, everything is decided in a computer base. So either the splint is given. So once we can place this surgical guide, and exactly it gives us osteotomy is prepared. And once this osteotomy is prepared, exact location, we can put the genioglossus muscle forward, and which can be rotated and plated in correct position. That is known as genioglossus advancement. So we can see this that because of genioglossus muscle advancement, there is an increase in airway space. So next procedure, how we can advance the genioglossus muscle is by means of genioplastic procedures. So genioplastic procedures will advance the genioglossus as well as other muscles like geniohyoid as well as mylohyoid muscles, and other diagnostic muscles also advances. So it pulls the genial, that is the tongue forward, so it helps in relieving this obstructive sleep apnea. So this is how a genioplasty will be done, or this is montage genioplasty where we pull all the muscles which are attached to the anterior mandible. So next important surgical procedure what we do are these particular maxillomandibular advancement procedures. So with the help of these maxillomandibular advancement procedure is very, very important procedure, and only this procedure will relieve obstruction for all the three airway spaces. Either it could be the oropharynx or nasopharynx or the hypopharynx. So when you pull the mandible and the maxilla forward by at least like 5 to 6 mm or 10 mm, what we are trying to open up is we are opening up the spaces in almost entire space. So this works out very well in most of the patients who are non-compliant to CPAP or when all other surgeries are not working. This is the best treatment protocol. So we do this maxillomandibular advancement by two means. One is orthognathic surgery. The second one is known as distraction osteogenesis. So we can see this is a pictorial representation of how all the three airway spaces will open up. That is, one is the nasopharynx, oropharynx, and the hypopharynx open up when you pull the maxilla and mandible forward. So based on Stanford protocol, previous protocol, what to say is, first there are two phases of surgery. One is phase 1 surgery and the second one is phase 2 surgeries. The phase 1 surgeries are soft tissue surgeries. So they say that once if the phase 1 surgeries are not working, then we can go for phase 2 surgeries. But now, in the latest protocol which is given in the year 2020, what they say is, the patient after imaging studies and the, what we call it as like drug-induced sleep apnea, sleep evaluation studies, if they indicate if the patient is having concentric complete collapse of the pharyngeal walls or lateral pharyngeal wall collapse, or if the patient is having skeletal deformities, the first thing is, it's always better not to do the phase 1 surgeries, it's always better to go for the phase 2 surgeries. The phase 2 surgeries are nothing but your maxillomandibular advancement procedures. So these are the best indications in patients who are having this lateral pharyngeal wall collapse as well as complete circumferential collapse of this pharynx and in patients with skeletal deformities. So what are the indications of these maxillomandibular advancement procedures if you see? These can be used in patients with moderate to severe OSA with or without history of phase 1 surgery, or with OSA of all severity if there is comorbid dentofacial deformity. Dentofacial deformity here what I am speaking is about either class 2 deformity or class 3 deformity, or if there is concentric and lateral pharyngeal wall collapse seen with drug-induced sleep evaluation. So these are the main indications where we can directly go for maxillomandibular advancement without doing the phase 1 surgeries, which will give a lifelong procedure, lifelong relief for the patient, where the patient doesn't need to wear the CPAP and all these things. So this is what we are seeing. These are the patients where it works is dentofacial deformities in class 2 deformities as well as in class 3 deformities. So the class 2 deformities, either we pull the mandible forward, okay, or the maxilla forward, both the maxilla and mandible is bring forward. These patients also have what we call it as hierarchic palate, so we need to do maxillary expansion also. So these are the 3 procedures what we do for this particular patients with class 2 deformities. In the class 3 skeletal deformity, class 3 skeletal deformity is nothing but mandible is protruded and the maxilla is retrognathic patients. These patients will have retropalatal space, decrease of retropalatal space. So if you bring the maxilla forward, we can relieve the space, airway space, we can relieve airway space is increased retropalatally. So you can see clearly that there is decreased retropalatal space. Once we pull the maxilla forward like that, we can increase the retropalatal space. This is pre and post of how we can see the differences in when we bring the maxilla forward. And aesthetics also will improve. There will be some problems with aesthetics. So what are the plans? What are the steps we undergo when we are doing this maxillomandibular advancement procedures of one is, once before doing this mandibular advancement, we send it for sleep studies. We see how much the patient is suffering from apnea, hypopnea index, and the orthodontist and the oral maxillofacial surgeons should sit together and plan exactly whether to proceed with first orthodontist or later first surgical procedures and all. So once we decide on that, we do the various procedures like symptomatic analysis is done, how much we need to bring the maxilla forward and mandible forward, we need to decide. And later we advocate this particular surgical procedure, and after surgery the patient has to undergo this particular orthodontic procedure again. After that we evaluate how it has improved by means of again this sleep studies and all. So nowadays we have this virtual surgical planning which has made this procedures very easy for us and more accurate and more simplified for us. Okay, so we take a scan of the patient and we take intraoral scans. We directly send this to the lab where we design this, how much we need to advance and all these things are designed. And we get this intermediate splints and final splints and almost entire osteotomy guides and plates, everything are being designed in the lab so that it will be more accurate for the patients. So this is how we do. So when are we doing this maxillomandibular advancement to get better aesthetics in adults, the only protocol what we follow is we do counterclockwise rotation. So that what will happen is the patient, because we are bringing the maxilla forward, the patient doesn't have more prognatism or something. So if you do counterclockwise rotation, the patient gets like the tongue is also being pulled forward and all. So the patient will have better compliance with this. So this is known as counterclockwise rotation of the patient, but where the aesthetics also will improve. So how we do this maxillomandibular advancement is we completely open up by doing vestibular incision from molar to molar. We open up everything, periosteal dissection is done, the nasal cavity dissection, nasal lining dissection is also done. And then we do the osteotomy of the maxilla at Leafold 1 level, and sometimes we need to do 3 or 4 piece osteotomies also. So once we do that osteotomy, we need to separate the maxilla from the pterygoid junctions. So once we separate the pterygoid junctions, we need to separate the maxilla from the nasal cavity also. That is, we separate from the nasal septum as well as the piriform rim. So then we downfracture the maxilla. Completely we downfracture the maxilla and bring the maxilla or mandible forward. So this is how after that we can do 2-piece or 3-piece osteotomies, and finally we fix the plates by bringing the maxilla forward by rigid fixation. So this is a suturing, and this is for the mandible. We make an incision in the intraorally and we do these cuts, osteotomy cuts, where we sagittally split the mandible and bring the mandible forward, completely split the mandible, and we try to bring the mandible forward and we do rigid fixation in these patients. So these are the several cases where we can see very good improvement in airway space after we do this particular procedure that is known as maxillomandibular advancement procedures. So this is the virtual surgical planning where we decide how much to bring, whether genioplasty is required or not, everything is decided on the computer base. So we get surgical guides like this, cutting guides. So these are one of my cases where we do these orthodontic procedures very regularly. So this is the intermediate spleen, and sometimes we need to do other procedures and all. Vertical ramus osteotomies, this is bilateral sagittal split osteotomy of this particular patient. The maxilla has been brought forward and the mandible has been brought forward, and we did genioplasty also in these patients. So these are some of my cases of orthodontic surgeries where we can see the improvement, where this patient is having a long face and bimax protrusion. We can see it has been shortened down and the patient looks better now. So this is how we do these procedures. Maxillomandibular advancement has been done. And this is a second patient who is having bimax protrusion. So in this patient we have done both, we have brought the maxilla as well as mandible forward, where we have made a straight profile, almost like class 1 occlusion and all. So this is a post-op. So this is another patient where we can see there is a bimax protrusion. So this is how the patient improves immediately, we get better results and all. This is a mandibular prognathism, pre and post-op. This is also bimax protrusion, where we can see improvement in this patient immediately after the surgery. So the last thing what we do for mandibular advancement is distraction osteogenesis. Already we discussed where distraction osteogenesis is indicated, mainly in patient with syndromic patient or in patient who are having very retruded maxilla or retruded mandible, where we need to bring the mandible or maxilla too much forward, at least more than 10 to 12 mm. We go for this distraction osteogenesis procedures. So we either use intraoral distractors or extraoral distractors. So this is an adult patient who is having acute maxillary hypoplasia, which the distractors, with the help of distractors, the maxilla has been brought forward. And in some cases of TMJ ankylosis also we do this distraction osteogenesis, or like TMJ process is also given in this patient. So in conclusion, I would like to conclude like oral maxillofacial surgeons and the dentists play a very crucial role in management of obstructive sleep apnea. Okay, and we treat by these things by various surgical procedures and non-surgical procedures, which are very helpful for the patient and which can give a long-lasting relief for these patients. So thank you very much.
Wonderful talk, sir. Now I request Dr. K.V. Sridhar Garu to come onto the dais and present mementos to the speaker. Chairperson. Now I request Dr. S.K. Apparao Garu to present the memento to Dr. K.V. Sridhar. Thank you so much, sir. Now I request Dr. S.K. Apparao Garu to give the
and this message to be passed on to your patients. So don't take it very casually. You have to caution the patients about the snoring. Snoring is not a jovial issue. It has to be taken very serious, and it can lead to so many complications as we discussed in the day-long sessions. What is the conveying is it produces simply low levels of oxygen, and that is producing a lot of problems. Thank you so much for the other minutes. Yes.
Madam, మీరు ఉంచలేదు.
Ready, all of you?
Yes.
Miles, sir, ready?
Wait,
sir. Ready, all of you?
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
ఇది చాలా ప్రమాదమైన పరిస్థితుల్లోకి వెళ్ళడానికి ఆస్కారం. ఎందుకు అంటే మామూలు గాలి పీలుస్తుంటాం, మనం పరిగెడితే ఆయాసం వస్తుంది. ఆయాసం వస్తుందంటే ఏంటి? ఆటో కరెక్షన్ అవుతుంది. అంటే లోపల అదే సిస్టంలో కరెక్ట్ అయిపోతుంది. లోపల కార్బన్ డైఆక్సైడ్ అక్యుములేట్ అయ్యి మనం పరిగెట్టడం వల్ల రెస్పిరేటరీ ఆయాసం వచ్చి గాలి బయటకు వదిలేసి కార్బన్ డైఆక్సైడ్ వెళ్ళి ఆక్సిజన్ వస్తుంది, మళ్ళీ రెస్పిరేటరీ తగ్గుతుంది. లావుగా ఉన్న వ్యక్తి బడ లావుగా ఉండి ఒక 41 సెంటీమీటర్స్ ఉన్న విడ్త్ కానీ, లేకపోతే టంగ్ అంటే నాలుగు పెద్దగా ఉండి ముక్కులో ఆయిల్, ముక్కులో బోన్ బెండ్ ఉండి ముక్కు బ్లాక్ అయ్యి జలుబుగా ఉండి సైనసైటిస్ ఉండి ఈ జబ్బుల్లో ఎయిర్ ఫ్లో తగ్గుతుంది. ఎయిర్ ఫ్లో తగ్గితే నోటితో గాలి పీలుస్తారు. ఇది గురక, మనం ఇదే గురక. కానీ మీరు చాలా మంది చూసి ఉంటారు, గురకలో గాలి పీల్చుకొని ఆగి ఇది చాలా ఇంపార్టెంట్ సబ్జెక్ట్. ఇంట్లో వాళ్ళు కూడా అబ్జర్వ్ చేసి చెప్పచ్చు. పేషెంట్గా మనకు తెలియదు, మనమే పేషెంట్ అయితే మనకి అబ్జర్వేషన్ తెలియదు. అప్పుడు ఏమవుతుందంటే ఆక్సిజన్ లెవెల్స్ తగ్గిపోయి బ్రెయిన్ చాలా ఇబ్బందుల్లోకి వెళ్ళిపోతుంది. ఆ ఇబ్బంది ఎంత ఇబ్బంది అంటే, ఎప్పుడైనా మనిషి స్ట్రెస్లో ఉంటే ఏమంటారు మనం? బీపీ పెరుగుతుంది అంటారు, పల్స్ పెరుగుతుంది అంటారు. అలాగే కార్టిజోల్ అని అంటే మనిషి ఒబీజ్ అవ్వడానికి, షుగర్ రావడానికి ఉన్న ఒక హార్మోన్ లాంటిది, అది పెరుగుతుంది. ఫర్ ఎగ్జాంపుల్, ఒక హెడ్ ఇంజరీ పేషెంట్ ఉంటాడు, వాడు అన్కాన్షియస్లో పడుకుంటాడు, కానీ కార్టిజోల్ పెరుగుతుంది, అంటే బ్రెయిన్ స్ట్రెస్లోకి వెళ్ళింది కాబట్టి. సో అలాగా ఇవి కొన్ని చేంజెస్ వచ్చి బ్రెయిన్లో, దానివల్ల వచ్చే జబ్బులు అంటే షుగరు, బీపీ, హార్ట్ అటాక్ రావడానికి ఆస్కారం ఉన్న పరిస్థితి. ఇప్పుడు ఒక పేషెంట్ ఒక 100 kg వెయిట్ ఉన్నాడు, బాగా గురక వస్తుంది, గుండు దడగా ఉంది అంటే హార్ట్ ఎఫెక్ట్ అయింది అని అర్థం. ఈ ప్రాబ్లం ఉందా లేదా అని టెస్ట్ చేయించుకొని సర్టిఫికేట్ తీసుకొని వెళ్తేనే కానీ డ్రైవింగ్ లైసెన్స్ ఇవ్వరు కొన్ని దేశాల్లో. టెంపరీగా స్టాప్ చేస్తారు. ఇది ఎందుకంటే సమాజానికి పనికొచ్చేటట్టు, ప్లస్ ఇండివిజువల్ కూడా. నువ్వు కరెక్ట్, ఇప్పుడు హార్ట్ అటాక్ వచ్చిందనుకో, డాక్టర్ తీసుకెళ్ళి వైద్యం చేస్తున్నావు. ఇది కూడా హార్ట్ అటాక్, మినీ హార్ట్ అటాక్ లాంటిదే. ఎక్కువ స్నోరింగ్ వస్తే అలాగే తీసుకోవాలి సీరియస్గా. అసలు చేయకుండా వైద్యం చేయించుకుంటే మళ్ళీ తొలి దశలో నార్మల్ ముఖ్యంగా వెయిట్, సెడెంటరీ లైఫ్. మనం ఎవరు సైకిల్ దొక్కుతున్నాం? మన 40 ఏళ్ళు మనకు ఎవరికి అందరూ సైకిల్ దొక్కున్నారు. బస్ స్టాండ్లో దిగి నడిచి వెళ్ళేవాళ్ళు, ఆటోలు లేవు. బట్ ఈరోజు పరిస్థితి తిండి ఎక్కువ, పని తక్కువ. అంటే ఫిజికల్ లేబర్ లేదు, మెంటల్గా ఎక్కువ వర్క్ చేస్తాం, చాలా ఎక్కువ వర్క్ చేస్తాం. అందువల్ల ఈ జబ్బుకి ఎక్కువ మంది 100 మందిలో, అంటే ఇప్పుడు మనకి 25-30 మంది ఉన్నాము అంటే అందులో 10 మందికి ప్రాబ్లం ఉంది. 10 మందికి అంటే తక్కువ ప్రాబ్లం కాదు. అంటే మనకున్న 148 కోట్ల ప్రజల్లో సుమారుగా లెక్క చేసుకుంటే దగ్గర 45 కోట్లు ప్రజలకి ఈ జబ్బు. సో 30%. సో ఈ వీళ్ళందరికీ కూడా హైపర్ టెన్షన్లు, డయాబెటీస్లు, హార్ట్ ప్రాబ్లమ్స్ రావడానికి ఆస్కారం ఉన్న జబ్బు కాబట్టి ఫ్యూచర్లో ఇది నోటిఫైబుల్ డిసీజ్గా మారితే మంచిది. అంటే ఒక డాక్టర్ గారు నా దగ్గరకు వచ్చారు, మీకు జబ్బు చూశాను, గవర్నమెంట్ అథారిటీస్ చెప్తాను ఈ పేషెంట్కి ఈ ప్రాబ్లం ఉందంటే మీరు కూడా వాళ్ళకి ట్రీట్మెంట్ చేయాలి, లేకపోతే గైడ్ చేయాలనేది మనం అవేర్నెస్ పెంచాలి. సో ఫస్ట్ రోడ్ అథారిటీస్కి, గవర్నమెంట్ అథారిటీస్ పెంచి పబ్లిక్లో అవేర్నెస్ తీసుకురావడం మీ అందరి రోల్ చాలా ఇంపార్టెంట్. ఇప్పుడు మేమంటే ఎంతమంది ఈరోజు 400 మంది వచ్చారు, వాళ్ళకి ఎక్స్ప్లెయిన్ చేశాను డాక్టర్కి. వాళ్ళు చెప్పాం మీరందరూ ఈ మెసేజ్ ప్రజలకి తీసుకెళ్ళండి. కానీ మీరు ఆల్మోస్ట్ నూకట్ కార్నర్ దీనికి వెళ్తారు కాబట్టి మీరు దీన్ని హైలైట్ చేస్తే చాలామంది ప్రజలకి మేలు చేసినట్టు లెక్క వస్తుంది. ఇందులో ఫ్యాకల్టీగా చాలామంది పార్టిసిపేట్ చేశారు. ముఖ్యంగా హైదరాబాద్ నుంచి డాక్టర్ శ్రీనివాస్ కిషోర్ గారు, ఏజీ హాస్పిటల్ హైదరాబాద్. ఆయన ఈ కాలేజీలో మా తల్లిదండ్రులందరూ ఈ కాలేజ్ స్టూడెంట్స్. మా తాతగారు కూడా ఈఎన్టీ సర్జనే, ఈ కాలేజీ నాకు 1940లో స్టూడెంట్ అయినా. సో అలాగా ఆయన పిలిస్తే వచ్చి మంచి లెక్చర్స్ ఇచ్చారు. డాక్టర్స్ అందరికీ బాగా అవేర్నెస్ క్రియేట్ చేశారు. అలాగే డాక్టర్ మధుసూదన్ రావు గారని నంద్యాలలో చాలా ఫేమస్ సోషల్ మెంబర్ కూడా, అన్ని సొసైటీ యాక్టివిటీస్లో బాగా పాల్గొని పబ్లిక్ అవేర్నెస్ తీసుకొస్తారు ఆయన. ఈరోజు చీఫ్ గెస్ట్గా మీ అందరికీ సుపరిచితులు శ్రీమతి అనురాధ గారు, వైవి అనురాధ గారు, ఐఏఎస్. ఇదివరకు వర్క్ చేశారు ఆవిడ, ఫ్యామిలీ వెల్ఫేర్లో కమిషనరు, చాలా పోస్టులు చేశారు. ఆవిడ వచ్చారు. నెక్స్ట్ మీ అందరూ సుపరిచితులు ఒక డాక్టర్ గారు, సీనియర్ మోస్ట్ డాక్టర్ గారు, మీ అందరికీ అర్థమై ఉంటుంది. సీనియర్ మోస్ట్ డాక్టర్ గారు యాక్చువల్లీ ప్రాక్టీస్ చిట్టుబద్దులు గారు. నాకు చిట్టుబద్దులు గారు వచ్చారు, ఆయన గెస్ట్ అపాయింట్మెంట్ వచ్చారు.
ఇప్పుడు అతను
90 years అండి. సో ఆయన
పేరు దావట్లకే పేరు.
సార్ ఇప్పుడు ఈ సమస్యకి ఏంటి సార్? ఏదైనా శారీరకంగా వచ్చే మార్పులా లేకపోతే ఆహార అలవాట్ల ఏంటి రీజన్?
మెయిన్ వెయిట్ నాన్న, వెయిట్ సెడెంటరీ లైఫ్. ఈరోజు కింద నా స్వాబింగ్ చేయడం లేదు, బట్టలు ఉతకడాలు లేవు, నీళ్ళు తోడాలు లేవు, సైకిల్ తొక్కడాలు లేవు, రుక్కు రోజులు లేవు. అంటే ఇవన్నీ ఇండైరెక్ట్గా ఇవన్నిటికీ దోహదాలు. కాలింగలు కూడా వచ్చేసే చేతిలో పెట్టుకుంటాయి. ఫోన్కి కూడా కదలవలసిన అవసరం లేకుండా పోయింది, సెల్ ఫోన్ చేతిలో ఉంటుంది. సో మనం ఫిజికల్గా మన మూమెంట్స్ తగ్గిపోయి ఈరోజు 5,000 అడుగులు నడిచాను, 10,000 అడుగులు నడిచాను అనే పరిస్థితిలో ఉన్నామంటే ఒకప్పుడు అది పెద్ద సబ్జెక్టే కాదు. నడకనేది మామూలుగా ప్రతి మనిషి చేసే పరిగెద లెక్క. ఇప్పుడు అది వింతగా ఉంది. నడుస్తావు, డైలీ నడుస్తావు, డైలీ వాకింగ్ చేస్తావా, 10 కిలోమీటర్లు 5 కిలోమీటర్లు అంటే దట్ ఈస్ ఎ ట్రెండ్ ఆఫ్ ద సొసైటీ. ఈరోజు ఒక 4 years బ్యాక్ సర్వే చేస్తున్న దాంట్లో మన విశాఖపట్నంలో ఒబిసిటీ ఇన్ ఫిమేల్స్ 14 years to 45 years హైయెస్ట్ ఇన్ ఇండియా. ఆ ఏజ్ గ్రూప్లో హైయెస్ట్. దేర్ ఆర్ ప్రోన్ ఫర్ సో మెనీ ప్రాబ్లమ్స్. సో ఒబిసిటీ అనేది చాలా కామన్ అయిపోయింది. ఇప్పుడు ఇక్కడున్న వాళ్ళు ఆల్మోస్ట్ 60% ఒబీస్. నేను ఒబీసీ అంటే మనం అప్పుడేంటి 60 కేజీలు దాటితే ఆడు హీరో, ఆడు పహల్ మ్యాన్. మా టైంలో అందరూ 40-45 ఉంటుంది. ఈరోజు 40-45 అంటే బతుకుంటారు. అంటే అంత సన్నగా రేర్ కనిపిస్తుంది. ఆ ట్రైబల్ ఏరియాలో తప్పించి మన సిటీస్లో తగ్గిపోయారు, వెయిట్ తగ్గుకుంటారు. అంటే రెగ్యులర్గా మీరు మీ దైనందిన జీవితంలో చేసే వర్క్ చాలా ఇంపార్టెంట్. బద్ధకంగా ఉండకండి, ఆరోగ్యంగా ఉండండి. ఇది
వర్క్ పెట్టేవాళ్ళు వాళ్ళకి వినబడుతూ పక్క వాళ్ళకి డిస్టర్బెన్స్ వాళ్ళకి ఎందుకు వినబడుతుంది?
ఆయన పడుకుంటాడు, ఆయనకి ఆయన ఉంటాడు కదా. ప్రాబ్లం
సౌండ్ ఏదైనా లేచిపోతారు, సౌండ్ ఏదైనా అయితే లేచిపోతారు. వాళ్ళ గురకు మరి వాళ్ళకి వినబడదు,
చేస్తాను లేచిపోతారు.
అవునన్నా, దేవుడు ఇచ్చిన వరం ఏంటి? అలసిపోయిన బాడీని నిద్రకు వచ్చి బ్రెయిన్లో కూడా రెస్ట్ ఇచ్చి బాడీ అంతా మళ్ళీ రిపేర్ తిరిగి. స్లీప్ అనేది ఇన్ఫ్లమేటరీ ఫినామినా. అంటే నడక వలన అన్ని పనులు చేయడం వలన ఇన్ఫ్లమేషన్ ప్రొడ్యూస్ అవుతుంది. ప్రతి టిష్యూ కొంత అలసిపోతుంది. అలసిపోవడం వల్ల కొంచెం చెడు పదార్థాలు క్లియర్ అవుతాయి. అవన్నీ క్లియర్ అవడానికి ఇచ్చాడు దేవుడు. ఆ స్లీప్లో రిపేర్ మెకానిక్ ఉంటుంది. ఆ స్లీప్లో రిపేర్ మెకానిక్ పోయి రిపేర్ ఇస్తుంది. స్నోరింగ్ ఆక్సిజన్ తగ్గితే ఇంకా రిపేర్ అవుతుంది. అందువల్ల వాళ్ళకి సైకాట్రిక్ ప్రాబ్లమ్స్ వస్తాయి, కోపం వస్తుంది, లేదా డిప్రెషన్ వస్తుంది, పడుకుంటాడు, డ్రైవ్ చేసినప్పుడు యాక్సిడెంట్ చేస్తాడు. సో ఎనీ ఎలాగైనా మేనిఫెస్ట్ అవ్వచ్చు ఈ గురుకు వల్ల. ఈ గురుకు వల్ల ఒక బీపీ వస్తుంది, షుగర్ వస్తుంది, కానీ చాలా లక్షణాలు రావడానికి
గురకం అది నిద్ర ఎక్కువ చలికాలం పడుతుందా, వేసవికాలం పడుతుందా, దీనికన్నా కాలం ఉంటుందా?
అంటే ఇప్పుడు
4 కాలం ఉన్నాయి.
జలుబు వచ్చింది, మీరు నోటీస్ చేస్తుంటారు. మన జలుబు రాగానే కొంచెం గురకు వస్తుంది, ఆ రోజు 2 రోజులు తగ్గిపోతుంది. కూల్ డ్రింక్స్ ఎక్కువ తాగనుకోండి, ఆ రోజు ఇంటికి వెళ్ళాక ఆ గురకు తాగి వచ్చింది. అంటే నాకైతే నా పర్సనల్ ఎక్స్పీరియన్స్ అంటే జలుబు వస్తే గురకు వస్తుంది, కానీ గురకు తగ్గిపోతే అది పెద్ద ప్రాబ్లం కాదు, టెంపరీ ఫినామినా. అలా కాకుండా గురకలో ఆక్సిజన్ లెవెల్స్ తగ్గే లెవెల్ కంటే ఆగిపోయే పరిస్థితి వస్తేనే డేంజర్. సౌండ్ డేంజర్ కాదు, సౌండ్ పక్కన వాళ్ళకి డేంజర్ కానీ వాడికి డేంజర్ కాదు.
సార్ ఇప్పుడు గురకన్నది స్థూలకాయలు కాకుండా పిల్లల్లో కూడా ఉంటుంది, చిన్న దానికి ఎలా ట్రీట్మెంట్ అని చెప్పాను సార్.
పిల్లల్లో ముఖ్యంగా ఇప్పుడు ఎలర్జీ ఉంది, మీకు అందరికీ అర్థం అవుతుంది. పొల్యూషన్ రోజు చూస్తుంటాం, ఢిల్లీలో ఎంత పొల్యూషన్ ఉంది, అక్కడ ఉంది. వైజాగ్ కూడా ఏం తక్కువ కాదు, 290 ఎలా చూపిస్తున్నారు. వాళ్ళకి 500 కూడా వెళ్ళింది ఢిల్లీ, వాళ్ళు 290, 300 కూడా క్రాస్ అయిన రోజులు ఉన్నాయి. తర్వాత హ్యూమిడిటీ వల్ల కూడా ఆ డస్ట్ డెసిపేట్ అవుతుంది, అంటే బయటకు ఎక్కడం ఇలా దీపోవడం వల్ల ఎలర్జీ. మేము చదువుకున్నప్పుడు 2% ఎలర్జీస్ ఇండియాలో, ఇప్పుడు ఈరోజు 46% ఎలర్జీస్. ఆఫ్టర్ 7 years మనందరూ ఎలర్జీ పేషెంట్లు అవుతాం. ఏదో ఎలర్జీ, ఫుడ్ ఎలర్జీ అవ్వచ్చు, స్కిన్ ఎలర్జీ అవ్వచ్చు, నోస్ ఎలర్జీ అవ్వచ్చు, ఆస్తమా అవ్వచ్చు, ఏదైనా అవ్వచ్చు. సో ఈ ఎలర్జీ వల్ల ఏమవుతాయంటే ముక్కులో కాయలు పెరుగుతాయి, పెరగాలి, నోస్ నుంచి గాలి ఫ్రీ గాలి. సో దానివల్ల అదే ఎలర్జీ ట్రీట్మెంట్ తీసుకున్నటువంటి ఎయిర్ ఫ్లో బాగుంటుంది, ఆక్సిజన్ బాగుంటుంది, గురకు కూడా తగ్గడానికి ఛాన్స్ బాగుంది. ఎర్లీగా ట్రీట్మెంట్కి వెళ్ళాలి. లేట్ చేస్తే ఆ కాయలు మళ్ళీ ఆపరేషన్కి వెళ్తాయి, ఆపరేషన్కి వెళ్ళినా ఎలర్జీకి మందులు తప్పవు.
చెప్పండి సార్.
నేను డాక్టర్ ఎస్కే చెప్పారు, కోర్స్ డైరెక్టర్, అంకోజా ప్రెసిడెంట్, ఐఎస్ విశాఖపట్నం ప్రెసిడెంట్. డాక్టర్ సూర్యనారాయణ గారు, వైస్ ప్రెసిడెంట్ అంకోజా. డాక్టర్ వాలేంద్రరావు గారు, అంకోజా సీనియర్ మెంబర్, ఆర్గనైజింగ్ కావ్యశ్రీ, సుశ్రుత అండ్ కావ్యశ్రీ ఆర్గనైజింగ్.
ఓల్డ్ స్టూడెంట్స్ దగ్గర ఏమో మనీ కలెక్ట్ చేయలేదు
అంటే ఆంధ్ర మెడికల్ కాలేజ్ ఓల్డ్ స్టూడెంట్స్ అందరికీ కాంప్లిమెంటరీ రిజిస్ట్రేషన్.
వాళ్ళు ఫీజు పే చేయకుండా వచ్చారు, మిగతా వాళ్ళు రిజిస్ట్రేషన్
అది కూడా తక్కువ
నామినల్ ఫీజు
1000 రూపాయలు.
నోట్ రిలీజ్ ప్రెస్ నోట్